We have the greatest surgeon with us. So the chairperson, Dr. Lalmohan Sway, please. So medical oncologist from Acharya Harihar Institute. So we have the first session, locally advanced CA stomach, moderator being Dr. Sunil Agarwal. Can I call all the panelists, Dr. Saril Parida, Dr. Saroj Sahu, Dr. Subhashish Mishra, Dr. Sanjay Mishra, Sri Gopal, Amit, and Dr. Subhashish Mahanti.
So respected chairperson and my dear colleagues, good to see Sunday morning, 9 o'clock. Surgeons are there, Dr. Dilip Karas, so I must congratulate all those audiences are there who has come on Sunday morning. Dr. Pani, good morning. And I must welcome all my panelists who are great and who are stalwart in their own field. Starting from surgical oncologist, medical oncologist, radiation oncologist, full house. So I am fortunate enough to get a full house. So I do believe it's a good discussion will be there. Now to begin with, I must say like why we have chosen this topic of a locally advanced gastric cancer is because of this is the third most common cancer which we are getting in our OPD. And the approach to this cancer is different when the patient approach to our different faculties, and at the end of the result, at the end of the day, we all want the best to the patient, but since there are different approach are there, so we thought of like why not to get in from the panelists, from the audiences, what best can be done or why their approach is something different. And I must request to all my panelists that they must come out with whatever the practical things which they are getting in their OPD based on their evidence, yes, definitely, but why the approach is something different. So we covered this 40 minutes with the 3 cases, and these are all our own cases. So let us see how our panelists, and I must say I will engage my audiences also to give their inputs, like how they approach. So to begin with, it's not working. Okay. So this is a 57-year-old female patient with fullness and occasional pain abdomen and no significant past history and family history. And on examination, she hasn't got any mass and no pelvic deposits are there. So so how you will proceed? So I may say this case is with a surgical oncologist. So to begin with, I must say my surgical oncologist colleague, Dr. Sahu, how you will proceed with this case?
Yeah, good morning everybody. So since the patient has presented with some kind of abdominal pain and dyspepsia, the first thing I am going to do is put a scope. I mean upper GI endoscopy and see what is there inside. And if there is a suspicious lesion, then obviously you need to take a biopsy.
So definitely an upper GI endoscopy and with the biopsy, and upper GI endoscopy shows there is a small growth is there in the distal end of the stomach, and you have taken the biopsy. And then?
So since if the biopsy is positive, that is adenocarcinoma of stomach, then we need to do further workup in the form of a local and distant disease mapping, that is CT scan of the abdomen, I mean whole abdomen, and NCCT of the thorax to rule out pulmonary metastasis. That is what we normally practice.
So the upper GI endoscopy, The upper GI endoscopy, this is the photograph. I don't know whether you can able to see it or not. There's a distal growth is there, and which small amount of distal body of the stomach is also been involved. That's the endoscopy report has been there, and that's the CT scan finding. So I may request to my Dr. Salil. So can you please see what is there in the CT scan?
I could look out, there is a circumferential thickening in the distal part of stomach involving the pyloric part, and there is no, the outer line of the stomach looks normal, and there is no perigastric or
Correct. So
perigastric,
distal
there is no
stomach,
lymphadenopathy.
correct,
Okay.
correct. Distal stomach, some thickening is there, and there is no nodes, perigastric nodes are there, and that's the finding of the CT scan, and that's a biopsy report has been there. So it's suggesting as an infiltrating adenocarcinoma of the stomach. So now my question to my pathologist, like, would you like to do an MSI in this patient apart from the whatever the routine investigation and the report is there with you? Would you like to suggest an MSI for this patient?
Actually, MSI panel is only suggested when you are having this polycohesive carcinoma. So that's your prognostic. But initially, if you do MSI, I don't know. It's,
can you please be loud enough?
Yes. Generally, we suggest for MSI panel. We
So
suggest for MSI,
MSI is a mandatory for all the stomach cancer, or would you like to do in some special cases?
It's mainly done in case of medullary carcinoma and polycohesive carcinoma. So as it is a very poor prognostic cancers.
No, we are not. Are you suggesting a MSI for?
Yes, we suggest
For any stomach cancer,
stomach
biopsy
cancer,
proven, you will suggest in your report that an MSI has to be done.
Yes, MSI has to be done.
Dr. Srigopal, what's your, and why you want to suggest an MSI?
I think in this scenario, clinical T2N0, I won't advise MSI.
You won't advise?
From clinical therapeutic perspective.
So you have got a special conditions in which?
Yeah, in inoperable, advanced or metastatic setting.
So what's the take from Dr. Salil, Dr. Pani? Yes. Can you please?
Sorry. When you are contemplating the neoadjuvant chemotherapy, the data published that if MSI is high and you are giving NACT, the response and the outcomes are poor, so it is better to go for the upfront surgery than for the NACT. That is what I think Dr. Agarwal is speaking. Even if the FLOT regimen, even if they give the intensive neoadjuvant chemotherapy, still the response is poor in the MSI high subset analysis.
So what you are, if I can draw your conclusion, that you will be saying that MSI should be done upfront for the for any biopsy proven in a
NSI in the neoadjuvant setting is required.
Sir,
So
I
doing
have one
off-late,
point.
but
As
it is
per
required.
NCCN guidelines, MSI should be done in all the newly diagnosed
Correct.
stomach cancer, especially those cancers which have intestinal type. And second important thing is we have known that MSI positive patients have less response to 5FU based chemotherapy.
Correct.
So this is another thing which we have to consider in this situation. As per NCCN, you have to do, irrespective of what cancer, what stage, you have to do all the newly diagnosed cancer, you have to do MSI.
So yes, it's correct. So as per guideline, we should do MSI in all setting, in all newly diagnosed CA stomach, we should do MSI as a part of evaluation, but routinely we don't do, we do in advanced metastatic or recurrent setting. But yes, as sir said, response to chemotherapy will be less when MSI will be
So
high.
it will just add on to some IHC cost only, but yes, definitely you will be having an upfront information because you don't
Yes,
know
yes.
after the report what is the coming out. So in one go you have got a privilege to discuss with the patient. So yes, yes, Dr.
So
Sir.
there are two aspects of doing MSI. One is you can biologically prognosticate the disease. I mean to say MSI high is associated with like intestinal type, early disease, low lymph node metastatic disease, and overall prognosis. The other aspect of doing MSI, what like Dr. Chinmay said, if you are planning to subject the patient for a neoadjuvant therapy, then you should think about it. Because it's MSI high, then your response to neoadjuvant chemotherapy is obviously less, though the overall survival is better. So then you can plan for a upfront surgery if it is doable.
Saroj, confusing. So we are talking about CS stomach. So early, locally advanced. So what is the role of MSI? So as of now, so MSI in stomach is only for a palliative intent. So we are looking at a immunotherapy. So the story of stomach cancer is different, and the colon. But I don't think, so if at all MSI high in a stomach, so are you not going to give a 5-FU based chemotherapy?
So
So there is no such, Chinmay?
It is like this. There are two aspects. MSI age is associated with something which are favorable.
The association
that,
may be different.
That you can prognosticate to the patient. One.
So I must say that the interpretation of the MSI in the later aspect, that's a different story.
So Shubhashi, so tell me, so what is the incidence of high MSI in a stomach cancer?
Yeah,
20
it is
to 30%.
around 20%. It is around, what is the literature says around 17%, but it can say it's around 20%.
So let us move from the MSI to the next one. So that's Dr. Salil. Would you like to do some PET scan for this patient since the patient has come to a surgical oncologist initially? So would you like to do some other PET scan for this patient?
We don't follow a routine PET scan in all cases of resectable gastric cancer if we are following upfront surgeries. And if we are in proximal gastric cancers, basically the role of PET scan is to prognosticate the disease basically. It's not about staging the disease. Resectable case, you have resected, post-op follow, you can do a PET scan, or as a response to chemotherapy, if you are planning a neoadjuvant setting, you can do a PET scan. But upfront is a staging process, it's not been proven, and we don't do routinely.
So you will straight away take the patient for surgery. So now how?
Thing is, as a staging procedure, next in line in follow-up is a diagnostic lab and a peritoneal liver cytology in almost all of our cases, because we hardly get any T1 cancers, right?
So you are doing a staging laparoscopy with a cytology also.
Cytology,
So
peritoneal liver
Dr.
cytology.
Sau, what about you?
Yeah, for any advanced disease, like what is beyond T2 and N+, we should always do a staging laparoscopy and cytology. There are two purposes. One,
it should be done. That's what you are doing in your institute. You are doing a staging laparoscopy with cytology.
doing a staging laparoscopy and a peritoneal.
Because in our institute, what I am saying, we are doing a staging laparoscopy for all, but we are not doing the peritoneal cytology for all the patients.
No,
I must say.
it is staging laparoscopy plus peritoneal washing, and it has its own implication. Staging laparoscopy, one is for resectability to see whether if it is a posterior wall disease, it is adherent to pancreas, you need to see whether it is resectable or not, that's one. The other is obvious metastasis to the peritoneum, that is for staging laparoscopy. And washing, if you are doing, you need to do a very proper
So you are doing washing with 200 ml or 50 ml?
It's a 50 to 200 ml. I mean, if you are
what you are doing?
200 ml.
200 ml. You are Dr. Salil?
Actually, we follow 3 quadrants. That is subdiaphragmatic, we give 200 ml, each paracolic 50-50 ml, and pelvis 100 ml. Like that we follow.
So Dr. Subhash, how many cases you are getting the cytology, in your institute? A surgeon sending you the cytology?
Very few cases.
Very few cases. That's the thing which is happening. Yes, everyone is doing staging laparoscopy, but cytology is something which is very different prospective point of view. Surgeons are thinking that since it's a T2, T3 tumor, when you are shaking the patient, when you are shaking the tumor, there might be an exfoliation from the primary site. The disease might not be there in the peritoneum, and that's the logic why some people are not doing the peritoneal cytology. So you did this one, peritoneal cytology, and my question to the medical oncologist, like, would you like to, suppose if you go a little bit back, would you like to give neoadjuvant chemotherapy for this patient?
So yes, in clinical T2N0, after peritoneal cytology comes negative also, still clinical T2N0M0, we can go for neoadjuvant chemotherapy as per FLOT4 study.
So what's the idea about T2N0 giving a neoadjuvant chemotherapy? Like how you are convincing your surgeon or to patients that yes, your neoadjuvant chemotherapy is
yes. So we can go for neoadjuvant perioperative chemotherapy as per the data we have. But still this patient can be taken up for upfront surgery. Suppose my surgeon is telling I will go for upfront surgery.
So your neoadjuvant chemotherapy is not going to have an OS benefit, only the resectability, control of the disease.
If I compare between the data, FLOT4 versus classic trial, there is not much difference in clinical T2N0. Still we can get a survival benefit with classic trial. But in FLOT4, yes, we have an advantage in clinical T4 and also T3. But in this T2N0, still we can go for upfront surgery. If our surgeon is asking that can we go for upfront surgery, yes, we can go for upfront surgery if peritoneal cytology and DLAB is negative.
Good morning. I am Dr. Sangram here. Sorry for interruption.
Yeah.
Actually, I am not agree on that because T2N0 you are telling neoadjuvant chemotherapy based on MAGIC trial, I think. But in MAGIC trial they compared
FLOT4 trial.
FLOT4 trial also. Yeah, okay. In FLOT4 and MAGIC both trial, they compared perioperative chemo versus surgery only. Yes. There is no data of perioperative chemo surgery versus chemo plus adjuvant.
Correct.
So I don't agree that you should give in T2N0 neoadjuvant chemotherapy.
So that's what I told, that if my surgeon is agreed for upfront surgery,
if it is operable,
T2N0M0, I will agree with that. I am not saying that must neoadjuvant chemotherapy.
If it is operable, we should go ahead with surgery.
Yes.
T3 onwards or node positive, neoadjuvant chemotherapy is
But if patient is not very fit for surgery at that moment,
that's a different story. So yes, our house agrees that T2N0, yes, upfront it's operable, no peritoneal mets, straight away go for surgery. So
to add, we are discussing a case of distal stomach.
Correct.
So whatever the study and trial that is for all, proximal or G junction, we are just extrapolating our data to distal also. But there is no study to say that neoadjuvant is better. We are yet to get it.
Yes, sir. Okay. As per the data, we are going for either, we have two options. We are not suggesting completely for neoadjuvant chemotherapy. In clinical T2N0, we can either go for upfront surgery or neoadjuvant chemotherapy. We can still take up the patient if patient is not fit for surgery.
So, in distal stomach, there is one catch as well. Distal stomach may later on very quickly land up to the intestinal obstruction. So, maybe sometimes, if we can, patient is also in obstruction as well, showing features of early obstruction, we should go for surgery first, I feel.
Hardly will get a clinical T2N0 with obstruction. It's very rare.
So one more point I need to highlight in this setting. T2N0, there are subset of patients which benefit from neoadjuvant therapy. Those group of patients where peritoneal lava cytology is positive. Okay, if you prognosticate those patients, you have to give peritoneal. I am telling about who strictly follow the Japanese guidelines and do a proper D2 gastrectomies. Okay, they follow protocol like they have to do a peritoneal lava cytology, which we follow in our institute. And if it is positive, then we subject the patient for a neoadjuvant chemotherapy and do a peritoneal lava cytology again. If it is negative, then those group of patients, up to 25% patient have a reasonable good survival. Okay, if it is positive again, then there is a role of surgery is doubtful.
So okay. So what kind of surgery, Dr. Sahu, what kind of surgery you are going to do for this patient?
So since this is T2, you said it is T2 lesion clinically. I mean there is asymmetric wall thickening means it is beyond T2.
So it's a D2 radical gastrectomy.
So that's a Dutch trial based on which you are saying about. That's a D2 dissection has got a disease-free survival, recurrence-free survival, and trend towards the overall survival. So yes, that's a trend towards a D2 distal radical gastrectomy. So post-op biopsy report has come out to be T1B and N1 disease. So again, my question to a medical oncologist, like what kind of regime, adjuvant CT, whether they want to give, and what kind of regime?
So probably this patient has undergone upfront surgery. Then adjuvant setting will go for classic trial, CAPOX.
So if the patient is been given chemotherapy versus no chemotherapy, forget about the regime. So what kind of difference you are going to make in the patient's life?
Obviously we are going to give a overall survival benefit by adding adjuvant chemotherapy to this patient.
So overall survival benefit based on which trial you are talking about?
Classic trial. Classic trial.
So how much is the benefit?
So almost you can say 5-year survival benefit is there. Overall survival benefit. Almost
chemotherapy versus no chemotherapy.
No chemotherapy.
Dr. Amit?
Talking about adjuvant chemotherapy,
Yeah.
role of adjuvant chemotherapy. Role of adjuvant chemotherapy comes as if there is a node positive disease, and second thing, if it is D2 dissection has been done. If personally I feel if it is less than D2, we should go for CTRT instead of.
That's a different story.
Yeah.
Adjuvant chemotherapy
Adjuvant
benefit to the patient for adjuvant chemotherapy versus no chemotherapy.
I think most of the trials show somewhere around 3 to 5%.
So classic trial 5-year update is there. Overall survival benefit is there with adjuvant CAPOX.
So due to lack of time, we will move to that's the evidence which shows about the MSI testing for routinely for all the investigation. That's the NCCN guideline shows, and that's a plastic trial which shows that PET scan, upfront PET scan cannot replace your staging laparoscopy. So for all the patients, you should do a routine staging laparoscopy and cytology, which cannot be replaced by the PET scan. And for any node positive disease, yes, the adjuvant chemotherapy has been required, and D2 gastrectomy by Dutch trial, which has been required. And this is the same patient where been the D2 distal radical gastrectomy has been done. And that's a biopsy report of T1B and N1 disease. So we move on to the next case, giving a different scenario, and let us see how the things move on. So this case goes to start with 50-year-old male patient with nausea and no vomiting, and no significant past history and family history and no comorbidity. His PSA is 1, and on clinical examination no mass felt and no pelvic deposit. So this patient goes to a medical oncologist, initially first to his OPD. Now my question to a medical oncologist, like how you will proceed with this case?
Yes, we'll do first routine blood investigation, upper GI endoscopy, and contrast CT abdomen pelvis.
Okay, then?
In upper GI endoscopy, if we get any growth, then we'll go for biopsy.
So upper GI endoscopy shows proximal, and the growth is there in the proximal and the body of the stomach, and D1 and D2 is passed with little difficulties, and CT scan shows the growth in the lesser curvature and the body, which is reaching up to the subserosa and perigastric node. Biopsy shows signature-ring adenocarcinoma. Anything else you want to do?
So after this, I would like to ask our surgical oncology team for a diagnostic laparoscopy and cytology evaluation. This
So
is
here
already
you are
locally advanced disease.
So here you are sending the patient to a surgical oncologist straight away for ruling out a metastasis by doing a staging lap and cytology.
Yes, yes. And along with that also, we'll do the thorax evaluation, CT thorax.
CT thorax you want
Obviously
to do?
this case I won't go for PET scan, being a signature-ring morphology, histology. It won't be giving a high uptake in FDG PET.
So you are not doing a PET CT because
In
of the
signature-ring morphology, in diffuse type, so subcentimetric node also I won't depend on PET scan. Their pickup rate is, their uptake is very less.
So that's a CT scan film is there, that's a CT scan report is there, and biopsy report. So again my question to, yes, you, as you have said, like you will be sending this patient for staging lab.
Yes.
And surgical oncologist did a staging lab and no mets, but peritoneal cytology came positive. Now what next? Dr. Amit?
That is interesting scenario. Actually, when cytology comes positive and laparoscopic no peritoneal metastasis there, then it has been said that the prognosis is a little bit worse than if there is both are negative. So in this case, I will treat it as a NSCT first. Thereafter, I will go for again the peritoneal staging. And if again there is a no peritoneal mets and cytology also comes negative, then I probably the surgeon will like to go for surgery and thereafter again the adjuvant chemotherapy. If I would basically like to go for NSCT with, it is called as a M1 stage, but still I will go for NSCT followed by repeat laparoscopy.
So you want to give an NSCT. So my question to surgical oncologist, like it's quite a tempting one, I mean operable one, no peritoneal mets, no gross disease is there. Only by routine, what you are sending for the cytology came out to be positive. What you are going to do? How tempting it will be to go ahead with the surgery, or you want to send it for a neoadjuvant chemotherapy?
Definitely, if it is positive, cytology is positive, then the benefit of surgery is nullified in almost 70% of cases according to recent data. So definitely we have to subject this patient for upfront chemotherapy for 3 cycles at least. Then subject the patient for, if you are following a protocol of doing a peritoneal lava cytology, if it is positive, then you have to give chemotherapy. Otherwise, there is no point of doing a peritoneal lava cytology. Then you have to repeat it again after chemotherapy. If it is negative, then only you subject the patient for surgery.
So what about the house says, the surgical oncologists who are sitting over here? Dr. Dilip, would you like to? Yeah.
I agree, no, neoadjuvant. There is no confusion in this case.
So all I agree with the neoadjuvant chemotherapy.
Only thing, one of my question to Sri, should I take home the message that in this case, of course, in a signatory cell, the uptake of PET-CT is less. Should I take the message by going out of this Padmaja hotel that in all signatory cells T3, I should not offer PET-CT scan benefit to the patient?
No, as far as PET-CT is concerned, all the trials and studies, whatever is there, the sensitivity for PET in gastric cancer is very, very low. That's one.
Because of the lack of that enzyme which has been present in the moderately and poorly differentiated.
The second point is the perigastric, picking up the perigastric lymph node is very, very low. The third thing is if you have a signet ring cell morphology, then the uptake is very, very low. The only indication for a PET-CT scan in gastric cancer is to rule out any occult metastasis. That's why a staging lab and cytology, peritoneal wasing is a far more better option than a PET-CT scan if you do not have any obvious metastasis in a CT scan of the abdomen and CT scan of the thorax.
So you would like to, so would you like to stamp this patient as a metastatic M1 disease or?
Yes, obviously this is a metastatic disease. If cytology comes positive, I will have one more point. If in 50 years in this patient, suppose patient's PS is very good, then all like what we have discussed, neoadjuvant perioperatic chemotherapy.
So your intent of chemotherapy is?
But if patient coming with PS3 or 4 for very poor GC and they are not adhering to our regular follow-up and all, then we may take it as a palliative case.
So your intent of chemotherapy is neoadjuvant or in a palliative setting?
I will take it as a neoadjuvant if patient PS is 1 or 2.
Okay.
And sir, to sir's question, I would say in mucinous in this signet ring cell histology, in spite of plain FDG PET, what we routinely do FDG PET CT. So PET with CT. That can add some information. Only FDG PET may not be enough.
Sunil sir, may I?
No, it's obvious. Nobody nowadays we are doing only PET. It's always
no. My point
yes,
is one is in mucinous tumor. There is no GLUT4 receptor, very less. So when you will give FDG PET scan, you will do the F18 will not enter to the cell. That's why the sensitivity is very low.
Correct.
So in mucinous or poorly differentiated carcinoma, there is no role of PET scan as such. First, second point, what you told that if that first time peritoneal vas is positive, you may intend on your intent may be curative. Then in second time after chemotherapy, if the cytology is positive, then this is purely palliative. There is no rule of, it cannot depend on the PS of the patient.
Correct.
Intent will be curative or palliative depending on the disease status, not the patient status, what I think.
Sir,
Correct.
yes, sir.
So
But from beginning, if we have a CS stomach with this cytology positive with PS3,
No, PS1, PS3, that is only
Correct.
surgeon's choice whether it is resectable or not,
to
patient
cut
is
short,
operable or not operable.
So to cut short all those
So I
things,
don't
it's
think,
a it's a purely in a new adjuvant setting. It doesn't depend on the PS score, performance score. So
And we have another option, sir.
how many chemotherapy cycle you want to give and then reevaluate it?
Yes,
3,
so-
4.
So as per as I told, if PS1 or 2, I will go for float regimen,
No,
4 cycles.
regime is something
4
different.
cycle.
How many cycles?
Yes,
Plot regime?
4
how-
cycle.
4 cycle.
So
and
whatever
then
I
you
will go, sir, that will be as per the evidence. If I am going for ECF, 3 cycle, float, 4 cycle. Float, I will go for 4 cycle, then re-evaluation, cytology positive, then palliative case, as we discussed. Cytology negative, we will go for surgery. Then after that, if we have adequate resource, then we can go for also HIPEC in adjuvant setting. Like
so
post-operative.
4 cycle you will evaluate by staging laparoscopy or by doing a peritoneal cytology.
Peritoneal cytology. Diagnostic lab with peritoneal cytology.
Okay.
So the scenario is like this. Suppose you are doing a staging laparoscopy and peritoneal vasing. If both are positive, it is palliative chemotherapy. If peritoneal metastasis is negative, cytology is positive, you subject the patient for a neoadjuvant chemotherapy. At the end of neoadjuvant chemotherapy post-cycle, you re-evaluate with staging laparoscopy and peritoneal vasing. If there is no peritoneal metastasis and cytology is negative, you make it treat the patient with a curative intention.
So okay, peritoneal cytology came as a negative one and the patient goes to a surgical oncologist on table. So in this particular case, so you are going to go ahead with a curative surgery.
We are going to operate with a D2 radical subtotal or total gastrectomy with a curative intention.
So
though it is cytology positive.
bursectomy
because
versus
overall survival
non-bursectomy?
So bursectomy, the trials and studies are showing bursectomy doesn't have
For
any
this patient?
for survival advantage. Just for a negative resection, you need to do a bursectomy.
So for this
Margin negative
patient,
resection.
for this patient, what you are going to do, Dr. Salil?
What we follow in our institute is if there is if a tumors are posterior tumor and serosa is involved, we do bursectomy in all cases. If it is an anterior tumor and serosa involved, we don't do. Though bursectomy has not been shown any additional survival advantage, but in serosal tumors, posterior serosal tumors in the LSS Act, we do a bursectomy.
So what we used to follow is that subserosal disease, wherever it may be, we used to do as bursectomy, and below T3 lesion, we don't do a bursectomy, or maybe a limited bursectomy. So
purpose of bursectomy is only to make it as a
definitely
margin negative resection. That's all.
It
doesn't
got
have any survival advantage.
So this final HP report, this is the total gastrectomy which we did, and that's a D2 dissection which we did for this patient, and that's the biopsy report. It came out to be T2N2 disease. 3 out of 35 nodes are coming positive. So LVI PNI is positive. So adjuvant treatment. Yes, I think adjuvant treatment will be required. Dr. Lalmonsa is a chairperson, so that's why I'm not asking him any questions. So, but he can give his comment also. You can intervene also, Dr. Lalmonsa. So this is the final case where I can involve. Okay.
I just want to ask: is there any role of HIPEC in that case?
So
cytology is positive.
So anyone want to take a HIPEC for this particular patient? Dr. Somsekar is there. Sorry. Dr. Somsekar. So we have got a legend with us, and how the things cannot be. I mean, HIPEC and without Somsekar. So
thank you.
yeah.
Anyhow, I have a talk later. Actually, next to pseudomyxoma mesothelioma ovary, the maximum advancement now has happened in gastric cancer. So this is one place where prophylactic HIPEC and HIPEC for a disease on the surface has come. Now, current recommendation for gastric cancer is like this. A patient who has PCA less than 9, preferably 7, and who is in good performance status, and who has responded to neoadjuvant chemo, preferably non-signet histology, and you can achieve CC0, are going to have overall survival benefit. So this is what now we do. We always do a staging laparoscopy. I was hearing the medical oncologist, I love to have a medical oncologist like that who is sending to surgical onco before giving chemo, which is very, very important, because after chemo everything looks normal.
Correct.
It could be a stage M1 and we would have missed an opportunity. So we always do any T3 lesion or N plus staging laparoscopy. Same time I put a chemo port, so I don't tell the patient that it is a waste visit to OT. Both happens together. And if they have PCI less than 7 to 9, after neoadjuvant we always do CRS HIPEC, and it is 90 minutes, and mitomycin is now the drug of choice.
So yes, but still now the HIPEC is not into the standard practice. Am I correct, sir? Criteria, but it is not, till now it is not a standard practice. So that's a final case which we are
Sir, again, excuse me. Here, sir, in the panel. Sir, in the panel. Sir, we just keep the last part, the adjuvant part in the case 2, which is also very important, a debatable topic.
I'm just running out of 6 minutes is there, that's why I'm just running out of the time.
But we discuss all the investigation and surgical part, and you are skipping the adjuvant part. So here 3 notes are positive. PNI is positive. Pre-treatment evaluation, Serosa was involved.
Correct.
So there is a clear debate regarding the role of adjuvant CTRT.
So
CTRT here.
Adjuvant CTRT.
Yes.
So, but what's your take? I mean, ask the medical oncologist. So, since it's an R0 resection,
So this patient.
I think this is not for us.
So the fire is on the stage or on the outside?
We still left with 5 minutes.
Okay.
So this is.
Okay.
Okay. Yeah.
Okay. So, so.
Role of adjuvant chemo is there. Adjuvant chemo radiation. Yes, we won't suggest because of.
Mike. So R0 resection is there and complete report is there.
Due to dissection, due to lymph node dissection, we can avoid adjuvant chemo. There is no definite benefit.
So based on trial 116, so since it's a D2 dissection has been done, so adjuvant chemoradiation based on only on PNI and LVI, I don't think it is. Yeah, correct.
Yes, the discussion.
So, okay, so we agree all about the adjuvant chemotherapy.
In this particular case, we can avoid adjuvant CTRT in view of preoperative chemotherapy, critics trial, and the D2 lymphatic has been done. If these 2 steps would not have been followed, then there was a role of CTRT.
No. Critics.
So if it is a proper D2 lymphadenectomy, it's a R0 resection. I do not believe there is any significant role of adjuvant.
Correct.
Adjuvant chemotherapy should take care of.
So we move on to the third and final case. We have got only 3 minutes. 67-year-old male patient with gastric outlet obstruction without any comorbidity, and on examination there is a vague mass is there and no pelvic deposit. Again for the workup, like how you will proceed? I mean, yes, with the apart from the upper GI endoscopy and the CT scan, I'm just running because of the time. We need some discussion point of view. The upper GI endoscopy shows distal stomach growth with antrum D1, D2 is not able to pass, and CT scan shows distal stomach with head of the pancreas been involved and with few perigastric nodes, and the biopsy shows poorly differentiated adenocarcinoma. So this patient is with a medical oncologist. Now how he wants to proceed? Dr. Amit?
I think this is 67 years old patient already present with the upper gastric outlet obstruction. I will first go to my surgeon. I will send the patient to the surgeon to relieve his gastric outlet obstruction by doing some palliative stomy, or if he wants directly go to the surgery. That's his choice as per patient. So I personally...
Dr. Sanjay, if suppose the patient land up with you with this kind of things, how you will proceed with the patient? So this patient is having a gastric outlet obstruction, he is vomiting, so you will straight away go for a CTRT for the patient. So that means you will be sending to a surgical oncologist, let him decide and let him do something for this.
So I may involve my medical gastro and put a stent and then can think of chemotherapy, and then later on evaluate for surgery.
So yes, that's also one of the options is there. So putting a stent and then can go for
since it is not metastatic, put a nasojejunal tube, improve the nutrition, and give neoadjuvant chemotherapy and reassess.
So, but what I think is that sending to a surgical oncologist is paramount important because your metastatic workup has not been fulfilled. If you start giving your whatever neoadjuvant chemotherapy, or your intent of the treatment will not be defined unless and until a staging has been done. So that's a biopsy report is there. Yeah. So after GJ, suppose you have done some bypass and some sort of treatment may be given by CTRT, or maybe it's a non-metastatic disease and chemotherapy. So I must ask my surgical, how many cases you have gone after this therapy and then you did a curative surgery? How many cases you have done? No, how many cases you got after this neoadjuvant chemoradiation or chemotherapy, and then you get a chance to do a complete surgery in your career? So you did a bypass and then you get a curate. Dr. Saroj?
I differ. I totally agree with Dr. Ghansham sir said. You send across your medical gastroenterology colleague, put a nasojejunal tube, improve the nutrition. If it is non-metastatic with staging lab, then proceed with neoadjuvant chemotherapy and reassess. If it is a superficial infiltration, like the capsule or something, you save up from the pancreas and do a R0 resection.
So okay, so I do agree also.
Even if the performance status is very good and it is not metastatic, you can also do a gastro-Whipple's if you are technically sound.
So because of the lack of the time, we just come to the conclusion that staging laparoscopy is a paramount important. It cannot be replaced by the PET scan, and it's a gold standard based on the plastic trial. And PET scan should be done in a locally advanced CA stomach where R0 resection, yes, definitely is a questionable kind of thing in a special situation. And definitely neoadjuvant chemotherapy has been come into role where the T2 or node positive disease is there. Beforehand, a staging laparoscopy and cytology is very important. And for T4B lesion, cytology positive, non-metastatic disease, neoadjuvant chemoradiation or chemo-RT should be an option, and after that re-evaluation should be done. So thank you very much. I must thank all my panelists. I would request my chairperson to put some comment on this one. So,
Thank you,
thank you very much.
Thank you, Sunil, and thank you all panelists. So on the eve of, since we are discussing gastric cancer, so there is a book published on gastric cancer, the primary editor being Dr. Ashok Bair, and I am one of the co-authors. And on this date, so let us give one book to each of you. Thank you so much.
That's right.
We will present the mementos.
दे दो संजय
Sabyasachi, Dr. Sabyasachi.
Subhashish.
Dr. Salil.
Next session, chalo. So now we move to the next session, is by Dr. Somsekhar on HIPEC. So you moved out of Manipal and joined after. So Dr. Somsekhar moved out of Manipal after so many years, no, and joined Aster Oncology.
Thank you very much. It's pleasure to be here because I always love Bhubaneswar and Cuttack both. People are very lovely, very friendly, excellent food. These are the only patients I don't know who don't do any shopping. And they trust the doctor. Still the doctor-patient, God relation is maintained. Few place that is only here. All other people will take 100 opinion. And when you are in middle path, when it's in medicine, if it is very clear, it's easy. When in that in oncology, most of the things are evidence can go this way, that way. But I really love to come. That's why when I was invited, unfortunately, I was in AIMS and Saftarjung. I was doing 2 live CRS HIPEC workshop. I operated from morning 7 o'clock to evening 10 to CRS HIPECs, which was live relayed in AOGD Congress International. But I didn't want to miss opportunity to travel here. I already had a beautiful chai, food, lovely people. So in the given time allotted, I will try to cover, since this is a GI session, I am not covering ovary to be apt with the Congress flow and also the session. GI surgery and HIPEC role only I am covering, because we know that the largest HIPEC in India are done in ovary. In world it is for appendical malignancy and colorectal. Next is ovary. But however, after OV HIPEC 1 trial and now OV HIPEC 2 trial happening in ovary, ovary is becoming the number 1. And I have a honor to be the only center outside Europe and US to be part of OV HIPEC 2. I'm invited and I'm part of the trial with Vandriel from Netherlands. So you will see first time in Indian patients data in an international OV HIPEC 2 trial. So I bring warm regards. As Gansham told, I moved to Aster International Institute of Oncology now. It's a 500 hospital across the world, and we have 4 very big cancer hospitals in Bangalore, dedicated hospitals, 4, and all of them have intraoperative radiotherapy. And we have HT Performer 3, the latest high-tech machine, the only one in India. So I bring warm regards from that. Those of you who want to come down to Bangalore, Dubai or Oman, please join me, and I'm more than happy to show our high-tech training program and international fellowship. Now remember, all GI diseases with peritoneal metastasis is not peritoneal surface malignancy. This is very, very important to understand. Leaving the ovary apart, all GI cancers are stage 4 to start with. So what is our traditional teaching? Stage 4, no cure, palliation, and prolongation of overall survival, quality of life. So remember, all stomach cancers, colorectal cancers, mesothelioma, or GI cancers, whatever it may be, gallbladder, pancreas, with peritoneal disease automatically doesn't mean PSM, peritoneal surface malignancy. No. There is a distinct group within that given area where by and large the whole disease stays in the peritoneum. Rarely they have extra peritoneal involvement, and the cause of death and suffering is the peritoneal disease and not deep liver parenchyma, lung or brain or bone mats. So it's very important to understand. Globally, if you look back, ovary contributes the maximum number of cases towards that. The reason is, even when you think you have a organ confined disease in colon or an appendicular malignancy or a gastric, because of the peritoneal current, peristalsis, the current from the pelvis, right, and it goes and stop at the superior coronary ligament, there is a stasis. They will all fail in peritoneal cavity in spite of not being have. That's why Profellowchip trial, Colochip trial, GastroChip, which is now a positive trial, a recent randomized control trial in stomach, where you have T3, N2, prophylactic hypec in stomach has shown survival benefit. Just last week from Alvojero, loco-regionally advanced, non-metastatic, no peritoneal disease stomach cancer, when they added cytorectal surgery, whatever gastrectomy it accounts to, and hypec, also surgery and IV chemo alone. Surgery, hypec, IV chemo had a overall survival benefit. It is just published last week, you can go back and read. So that is one of the reason, even though we believe it is early, peritoneum looks normal for either laparoscopic camera or human eye, they will recur because there is a peritoneal current. These are the mechanism by which a GI cancer can have the disease. Number 1, there will be implants which drop down during surgery manipulation, or they are already on the surface, or the cytology has got a disease already which you are not able to see. Gravity, respiratory movement, bowel peristalsis, that's why they come all along. This is very well stated that if you have an appendicular cancer, if it is at a base more than 2 centimeter, if serosa is involved, 30% of them will fail in peritoneal cavity, forming pseudomyxoma in your follow-up. Remember, even if it is organ confined. So what is this PSM, peritoneal surface malignancy? This is a disease which is confined predominantly to abdomen, involves the peritoneum, both parietal and visceral, and rarely there is a extra abdominal visceral metastasis, and that is not the cause of death. This is a totally different entity, unlike other entity, which you must understand that if you can give a good control. See, traditionally when you give IV chemo, there are 2 limiting factors. What are they? Bone marrow is a limiting factor. There is any cancer cell which can be killed by reaching very high dose of chemo, but you can't do that because the reason is then the bone marrow will also get suppressed and the vital organ GI tract will get destroyed. So there is a right dose that has been found in case of peritoneal surface malignancies and also in IV chemo, beyond which you can't escalate. So with that given dose currently today, what has happened is the peritoneal right concentration of chemo is very low, which means IV chemo what you give is only 1/10 of it goes to peritoneal cavity, not adequate to kill all the cancer cell. So in spite of the disease responding to systemic chemo, tumor marker becoming normal, the moment you stop chemo in 8 to 9 weeks, peritoneal disease comes up. That's why you need a high concentration in the peritoneal cavity, which you can't give IV, because then the patient will have so much of toxicity, it is very tough for them to do. So the peritoneal carcinomatosis in the peritoneum GI is classified into two, primary and secondary. Primary is mesothelioma. There are 3 varieties, you know that. And then we have primary peritoneal carcinomatosis, PPPC. And then you have secondary, which is from gastrointestinal, gastric, appendicular, colorectal, and also now, you know, dermatofibrous the tumors can also come, gallbladder and pancreas, 5% of them come. Then gynecological from ovary and others. So of all the thing, these are the top 5 reasons. Ovary, colorectal and appendicular, stomach, pancreas currently in the world are the largest. You can see that. So even pancreas, diverse rectum. So I keep getting this pancreatic cancer who have responded extremely well to the traditional treatment. Neither they die nor they stop progressing, only the peritoneal cavity is there. So people keep referring them for HIPEC or PIPEC because the medical oncologists are exhausted and they are doing well, only peritoneal disease, and we know that it is a stage 4 disease, there is no role of any surgical, so they keep coming for them. So now my next talk would be based on this statement we brought. We are a group of peritoneal surface malignancy expert. There is a body called as PESOGI, which is Peritoneal Surface International Group. I have the honor to be its council member. It's a permanent invitee until you die. This is a niche club. No election, by invitation. You have to have 100 papers in the field of HIPEC published in international journal. You should have been practicing about 100 HIPEC a year. You should have been an academician, and you should have practiced for about 10 years. And the body, individual academic body sees, analyzes you, and then they invite you, and once invited for life, you are the council. Sugar Baker, when he started, they never expanded it, they just expanded. Now I have the honor to be part of it. So we brought this particular statement, which I was a co-author, published in EJ. So I will let you know my talk to let you know how we can go up. So we took the 430 centers in the world who do at least 100 HIPEC. I have done more than 1000 HIPEC in Indian patients. I do about 100 to 110 every year. So I have the most recent HD Performer 3 machine with me. So we identified these centers in the world, Australia, UK, US, Europe, and then we analyzed this paper and brought this particular paper to give you a practice. I will let you know. This is a very important slide since the crowd is both medical onco surgeon. Just because you have hammer, everything is not a nail. In surgical oncology, more so in oncology, there is a 2 different terms. What can be done, what should be done. Just because something can be done is not that it should be done. Just because I know I can give immuno, I can operate, I can do HIPEC, I can do, is that to be done? So that is what is the knowledge, ethics, and right approach, a good head on a right shoulder. So this is a very important, I have summarized only pertaining to GI tract. Look at the survival curve of the patients who undergo treatment with peritoneal metastasis. The black one, pseudomyxoma, PMP. It can be from appendix or mucinous tumor ovary. They have got the highest survival if you do CRS HIPEC. So look at them, practically almost 85 to 90% have a 5-year survival. That is the black curve. This is a global 430 center of more than about 1 million patients undergoing CRS HIPEC for GI surgery with CRS HIPEC. Next, can you look back the red one? This is very important, mesothelioma. In that there are 2 varieties, low PCI, low Ka67, high PCI, low Ka67, high PCI, high Ka67. They don't respond, so I don't send them. I do laparoscopy, biopsy, I look PCI above 15, high Ka67. Even though I can remove all the disease, I don't touch them. My medical oncologist would then give pemetrexate, cisplatin with or without bevacizumab. I may do a PIPEC for them with an intent of palliation but not curative. So second disease which can derive maximum benefit CRS HIPEC is mesothelioma. Remember this, but remember, don't start a mesothelioma treatment without knowing the PCI index and Ki67. That decides they should always be with medical oncologist alone, with you stepping in as a palliative PIPEC and not HIPEC. Then if you follow the blue line, non-pseudomyxoma appendicular carcinomas. You know, you have this goblet cell appendicular carcinoma, signet cell carcinoma. They derive the third best with CRS IPEC. But look at the difference between the both. You know, it's very important to understand that all the difference. Then you have the green line. Colorectal cancer, PCI below 15. Non-signet histology responding to 4 cycle of neoadjuvant chemo. So they derive the benefit. So about roughly 40% are alive at 5 years. Currently, peritoneal metastasis, colorectal, IV chemo alone, mean median is 14 to 17 months survival. Here you can see almost about 30 to 40% are alive. Then the last comes the stomach. So stomach, what you have to do is non-signet preferably. Signet is not a contraindication. If an young patient signet responding well and limited peritoneal disease at the end of systemic neoadjuvant therapy, don't decline them a CRS IPEC if you can resect it. But stomach, so less than 7 PCI. This is a very important slide for student to understand. Also medical oncologists to understand the way the benefit in GI happens. So you can look at it. At one spectrum we have almost 90% living at 5 years, and the other spectrum we have 20% living 5 years. CS stomach with peritoneal disease, 20% being alive at 5 is not bad, right? Curative pancreatic disease, stage 1, stage 2, what is the current 5-year survival head pancreas? 15 to 20%. So for a non-metastatic local disease, we do Whipple's, we do BRCA1, BRCA2, we give PARP inhibitor, we'll give FOLFIRINOX, what all for what? 20% 5-year survival. Here we have a stage 4 disease. And remember, many times a good surgery in stomach is not just to achieve 5-year life, to make them eat every day, no vomiting, no bleeding, no misery. There are some field in oncology, even though OS benefit is not there, for DFS benefit we have to do, because in oncology adjuvant treatment curative surgery, OS is the mark, right? OS, you can't say DFS. That's why anastrozole in CA breast adjuvant has no OS benefit, only DFS benefits or tamoxifen. But there are some field in the human body, even though we can't achieve OS, we have to do for DFS. Number 1, head and neck cancers, pelvic, colorectal, cervix and rectal, because here DFS is also important. If they recur rectal cancer, miserable pain, fistula, discharge, and they can't live. With the modern medical oncology advancement, with sequential chemo and metronomic and immunotherapy and target therapy, people live long. You may say, oh, there is no survival benefit, why should I do that? But to achieve a good locoregional control with quality of misery-free, like in head and neck and pelvic rectal, you can still operate them. So if those stomach live, 20 lived 5 years, remaining 80 would have a good quality of life, eating without pain and bleeding, and they're fit patient for medical oncologists. So this is a very important slide I want you to understand and spend. I will take one by one in the given time allotted with small amount with my experience. PMP, pseudomyxoma peritonei, is not synonymous with appendicular cancer. PMP is not a disease, it's a syndrome complex where there has to be extracellular mucin. Peritoneal deposits because of appendicular cancer is not PMP. Remember this. Oh, you say appendicular cancer, peritoneal carcinomatosis, so I had a PMP. No. There has to be extracellular mucin, jelly bean appearance. And so you can have an appendicular cancer with PMP, without PMP. So it is not a disease, it's a syndrome complex where there has to be. Because they are extracellular mucin, they are low grade, low Ki67, chemo never acts in them, and they will never respond, they cannot penetrate, and they suffer, and they will never have extra abdominal disease. They will not have liver parenchyma, so they don't die. The best way to die in the hand of medical oncologists is by systemic metastasis. Best way to die is uremia, painless death. Worst way to die is no visceral metastasis, no extra abdominal disease, abdomen is contracting, neither can you eat, you suffer, home-based TPN, it's worst. Either you go up or stay here, in between Trishangu is horrible. This is the problem with peritoneal disease, neither there nor here. That's why local control is very important for them to understand. I run a course for 3 to 4 days only on PMP. So obviously in 20-30 minutes I cannot cover that. When you attend my course, we will do it. Now the next course I am doing in France, you can come there, we can attend. We just did one in Singapore. The recent, all medical onco, surgical, everybody should now follow 2016 Pesoghi classification of pseudomyxoma. I will not bore you, it is very difficult to read. Please read this paper. We brought this paper, I was a part of this consensus, and we published how to manage, when to do appendicectomy and stop, when to do quadricolectomy, when you have to do hemicolectomy, when you have to do peritonectomy, when you have to do HIPEC. You know what is the biggest confusion even among my colleagues, surgical oncologists, they'll call, Sombhai, I did an appendix. They have come, there is appendicular tumor ruptured, abhi kya karna hai? HIPEC, hemicolectomy, should I go back? Take my word, if you have not attended this course, 99% of my colleagues, GI and surgical, don't know when you have an appendicular tumor, when to do hemicolectomy, when to not do it, when to do peritonectomy. Most of the time, appendicular tumor doesn't need hemicolectomy. This is one abused, over-treated surgery. So this is very important. This is the guideline we have brought. So, yeah. So this is the guideline we have brought. I'm not going to trouble you. It's impossible. You have to attend my course for you to tell that, but you can read that, what to do. But this is very important. Whenever you see these particular features, can you see this? Small bowel has clumped down. Can you see whole small bowel? If you can see the picture D. In the D, full jelly bean, the whole thing has concentrated down. Whole small bowel has come down. And large volume of intraperitoneal mucin, and then the whole omentum, small intestine. This is called as central displacement of small bowel, or scalloping on the liver, or contour deformity of spleen. You have seen CT scan for various reasons, you never see a spleen. Contour deformity of spleen, centrifugal central compression of the small bowel. Then, you know, if you have a omental disease like this and scalloping of the liver and jelly bean, remember it is a pseudomyxoma. So this is the classification. We have integrated all of them. Those who do peritoneal surface malignancy, HIPEC, I do about 110 HIPEC, 1000 I have done. You must always document PCI index. Laparoscopy is best. Second is MRI with 3 Tesla machine with diffuse weighted imaging. It is called as peritoneal MRI, and your radiologist should give PCI index. I have trained a specific radiologist who will give that. After surgery, you must do what is no macroscopic, microscopic. If you leave any disease more than 2.5 millimeter, then HIPEC will not help, and that patient will not be cured. So it's very important to achieve CC0 or CC1. So PCI, CC score you must put. So this is the conclusion. When to do HIPEC, when not to do HIPEC. What I will do is I have brought this paper. You can go back and read when to do, but I will summarize all this in one slide. How many of you know there is a surgery called as radical appendicectomy without doing a hemicolectomy? We know radical hysterectomy, radical colectomy, D3 Japanese, D3 CMV colectomy, TME, all radicals, radical cystectomy. How many of you know there is a surgery called as Esincop type 3 radical ovarectomy? Without anything, only ovary radical. Please go back and read that. In my previous talk somewhere else I covered. I will now tell you, this is a beautiful paper by Sugar Baker, who told you should do radical appendicectomy but not knock off the bowel. Doing hemicolectomy, unless the tumor is perforated more than 2 centimeter in the base and margin is positive, has no value. Even then we don't do hemicolectomy because they don't spread by nodes. We just do quadricolectomy. Please keep the ascending colon, hepatic flexure. Let patient have a good, nice nutrition, potassium observation and good this one. So you can take a shot of this paper. It is taking the appendicular vessel, the lymph node, ileocecal area, a wedge of cecum. This is done by a double L staple technique. So radical appendicectomy, the way it is shown here, is the treatment of choice and not hemicolectomy. Please don't do hemicolectomies for appendicular cancer unless somebody has done lap appendicectomy, margin is positive. Even then, you can go back and do this. You can even keep the IC valve. God has given for a reason, right? If there is a survival benefit, we'll do. That's what. This is where. What can be done, what should be done. Just because I know how to do hemicolectomy doesn't mean I have to do. So this is the surgery which you need to for appendicular. There may be extensive peritoneal mats. Doesn't matter. You can concentrate on peritonectomy HIPEC, but don't need to be radical and be hard on the bowel when it is not required. All this I spoke, I concluded here. If somebody asks me what you should do, I will ask perforated, not perforated your tumor. Less than 2 centimeter, more than 2 centimeter, in tip, in base. Mucin present, not mucin present, peritoneal disease present, not disease. If you answer this question, I almost get every week from all the surgical GI what should we do, because they think, okay, Somshikar is like, high-pec guy. So they always ask, there is a case, tomorrow I have posted for hemicolectomy. I tell them, please don't do that. This is a patient who doesn't need. All patient also doesn't need high-pec. So this is the conclusion. If you have DPAM, diffuse peritoneal mucinous adenosis, look at what is the recommendation. No hemicolectomy. Radical appendicectomy high-pec. Even if you have PMCA, PMCA is peritoneal mucinous adenocarcinoma. उससे खराब और क्या हो सकता है? Mucin भी है, peritoneal disease भी है, adenocarcinoma भी है. Still see what is to be done? No hemicolectomy. Radical appendicectomy CR. The only condition where you may have to have colectomy is poorly differentiated PMCA or intestinal variety, goblet variety of high-grade mucinous signet cell adenocarcinoma. So the message I want to give is, please don't knock off the colon. Understand, within a pseudomyxoma appendicular, there are 7 varieties. Treatment is different for all of them. This is one of the few conditions where multiple surgery and high-pec. I have done 5 to 6 high-pec for pseudomyxoma patient, living over 15 years. This is the only condition in oncology, multiple surgery. There is another condition, low-grade liposarcoma retroperitoneum. जितने बार आएगा ऑपरेट करो उतना सर्वाइवल बेनिफिट है, इफ यू हैव अ सर्जन हु कैन ऑपरेट all this, because very complicated, second, third. So this is the only place, like in Bessin talk, if you see Professor Brendan Moran has done 15 CRS high-pec for appendicular in one patient living over 30 years. This is the only, it is called as iterative CRS. It is permitted only and only in low-grade appendicular carcinoma with recurrent. They keep living because they don't die, remember. They are non-metastatic, they never go out, their problem is intestinal obstruction and nutrition problem. So this is something which I wanted to say. Every effort should be made to achieve optimal cytoreduction. If you cannot do optimal cytoreduction, there is no survival benefit. I always see that, when I open this, I have 7 fellows who come to train. Across the world, people come to get trained. They will show this, they feel very happy. Sir, देखो अच्छा है, शाम को जल्दी खाना पीना और फिल्म जाएंगे. तो already they will be calling plan, girlfriend चलो खत्म, inoperable खोलता हूँ मैं, बंद करते 4 बजे. Remember, most of the primary, the enemy for that patient is you, surgeon alone, thinking it is not. The same patient, after 11 hours of me working on that, no peritoneum, parietal peritonectomy out, diaphragm stripped, whole mesentery gone, see the liver, no glycerin capsule also, bichara capsule also gone, liver is standing, not a speck of disease. It looks like better than a normal abdomen God has given. 11 hours, so you can do high-pec. So when I see such video, I tell my guy, no, you will be little early for tomorrow morning breakfast home, don't worry. So tomorrow hi jayega. So call back home and say that forget me today. So if you spend 11 hours, this is what happens. That is when high-pec helps. This is very important to understand that a good high-pec and a bad surgery doesn't go together. I have a special type of table, special type of this one. Patient is immersed in that. It warms you during cytoreduction. It cools you while you are doing high-pec, and then it makes you normal temperature. You need to have all these setups available. Special gloves which you can go off, special retractors. Able has supplied me Omni retractor. So you need good retractors for us. And then the right surgery and the right tubing and the right way to do bladder peritonectomy. Only then you have survival benefit. Otherwise, you can't have survival. The whole concept of high-pec is like this. Macroscopic disease is removed, what is seen to naked eye by cytoreductive surgery. There is always and always there is microscopic disease which will come back, which you put chemo into the peritoneal cavity, 10 times you do. So systemic toxicities are not there. If you add heat, penetration is more than 1.5 centimeter. Heat, pressure, and then intraperitoneal chemo and a good surgery and hyperthermia is what actually it does. So all the macroscopic disease is cleared there. Before you start, always clamp the Foley's catheter. I did 2 live operative workshop just in Safdarjung and EMS 2 days back. When I go to scrub, I clamp. So bladder is a pre-peritoneal organ, not retroperitoneal. Ballpoint cautery, 100 spray mode, whole thing is removed. So this technique is called as pouch of Douglasectomy, retrograde hysterectomy, everything removed in parachute. I don't open the peritoneal cavity. I just go back, strip the whole peritoneum like a sack, and then I do that. So you can see that whole pouch where the deposits are there all removed intact outside. This is very important to master this technique. Total parietal peritonectomy, extraperitoneal surgery, pouch of douglasectomy, retrograde hysterectomy you must do. That is when high dose of chemo into the peritoneal cavity with heat helps, where IV chemo cannot penetrate. But remember, there is already stabilization by medical oncology by giving neoadjuvant. So systemically you are controlled in the nodes in the systemic area. So increased uptake of malignant cell, apoptosis happening, accentuation of the benefit of the chemo. If it acts one, it becomes double potentiation and enhanced penetration above 39. Hyperthermic benefits already starts coming at 39. It stops at 43 degrees. So you should never cross 43 degrees. Then the chemo is destroyed in heat and bladder perforation bowel is high. So therapeutic window is 41.5 degree. That is one of the reason never try to do HIPEC with a desi machine. This is not adding garam pani, heart lung machine. There are 7 parameters. Number 1, the flow of the fluid should be at least 950 ml to 1 liter per second. How can you ensure that machine? You need to have a pump. Temperature in all the 6 quadrants of the abdomen should always be above 39, never more than 43, preferably 41.5. And you need a pressure of 21 kilopascal. All this should be done. Which machine? So that's why you need to take a US FDA approved machine. If you do it, do rightly, please don't do otherwise. What can be done, what should be done? Take a US FDA approved machine. There are 2 or 3 in company. The most popular one is the HD Performer from Rand, Italy. Very good machine, very fast. So drug, most of the time in GI it is mitomycin, temperature and this. So it's important to avoid hot spots. If you have hot spot, perforation, fistula. If you have cold spots, cancer doesn't kill there and hyperthermia is waste. That's why a dedicated machine of high quality is required. So I have the honor of taking this first machine. It is called as HD Performer 3. The first machine almost in entire Asia is with me. It does a forward flowing and I just change the connector. It does reverse flow also for me. So I use it now. This is the working horse in my institution. Just last week I did about 4 of them. 4 HIPEC. Every day I have a CRS HIPEC because mine is a referral center across the Asia. Almost 2 or 3 sometime I have. So this particular machine, very fast you can achieve, no hot spots, no cold spots and no human contamination, all a closed system, beautiful. And it comes with a dialysis kit like an equipment, you can use it and throw it one patient, so there are no biohazards for you. So second thing is, this is the technique of total parietal peritonectomy. What we normally do is, I don't open the peritoneal cavity, I just cut the sheath. Once I cut the sheath, then I use a single swab technique, double swab technique, ballpoint cautery, 100 spray mode with saline being spared. And I see all the retroperitoneal structure. I go backside on the vena cava and the aorta and the bladder, right and left diaphragm, all of them together. And then the whole thing actually comes like a sac. Then I do the whole parietal stripping and everything. So you can see that ballpoint cautery, 100 spray mode is extremely useful and very good. So the whole thing, all the structures I see retroperitoneal and in a sac, it comes like a parachute technique. The whole sac, can you see that? The whole sac has now the disease. Because that is the right way to achieve a optimal cytoreduction. It's a good technique. So we do this technique with ERAS. Average, I discharge the patient on 7th to 9th day. Mortality is less than 1.2% in my institution. Morbidity less than 10%. Sending that patient within 20 days to medical oncologist for first adjuvant is a very important marker. You have to balance this. So then when you open, all the disease would be there. This is a paper which I have published. You can read how my technique of parietal peritonectomy versus this, how it gives a survival benefit for you if you want to do this. So these are the some of the techniques which you need to do. There is also, I will take a minute more, okay? I'll take 1 minute more. So this is called as Gleason capsulectomy. Most of the people say, oh, it is frozen, liver is frozen. If you just learn diaphragm stripping, no use. You have to learn stripping the whole Gleason capsule. I don't go at the diaphragm, I go on the liver, then I strip the whole Gleason capsule and then we remove. And second thing is, there is something called as a peritoneal disease management, ponta hepaticus. Always open the bridge between segment 3-4 and then the ligament of teres, you need to take that up completely there and then remove it, which is extremely important. Always, people always say porta hepatis recurrence. It is not a porta hepatic recurrence, it is pontis hepatis between segment 3 and 4. I go down, I open the bridge and at the left portal vein and the segment 3 duct, there is a disease which needs to be removed, which is extremely important. Hidden areas, you must always look this. Second, people say when I have a disease like this, inoperable, early dinner, no, late tomorrow morning. You can take a fine tip needle 100 spray mode, it acts like a laser. Technique 1. Technique 2, ballpoint cautery, 100 spray mode, electro desiccation. Technique 3, I will show you what we have developed in India, my favorite technique. I take a APC laser and I take a Varys needle at the root of mesentery, I infiltrate air and I put my finger, whole mesentery comes out. Like, as a sari, you pente ladki both nicely like that. So you put a air, mesentery lifts up, put your finger, the whole mesentery I can remove. So don't call something inoperable in the abdomen just because you don't know how to do it, it's not inoperable. Make all the effort to do it, or involve a person who can do that. So you can do this, and I have APC laser, I have a plasma jet and a cold knife. These are all the technique, KUSA, which I use because we do 4-5, and they have very less penetration, so there is no injury. Use all these techniques. Second, you must master this pouch of Douglasectomy. I'll tell you how. You can see the whole disease, the whole pouch of Douglas would be kept outside. I always say that you don't remove the disease from the patient. I remove the patient from the disease. Patient को उठा के table से रखना, बाकी सब disease और table के पास में रहेगा. That is what is the technique you have to do. That is when the HIPEC works. This is the standard regime people use with the US FDA approved machine. Systemic chemotherapy in appendicular will not help, but in stomach, colorectal, neoadjuvant, please use it before you go. If it recurs after a HIPEC, that is when we do a PIPAC. I had a honor of being a part of the international program. I am the PI for this program, colorectal and appendix. I had done this. So we had a 236 patient recurrent after HIPEC. When we applied a PIPAC, the survival even then increased beyond 19 months. So this is a paper we are going to publish. I will end in last minute. This is a HIPEC registry of India. From all the hospital, people would say in private hospital, Somshekhar may do in one high funda center. Here, AIMS, Tata, all the government international centers are there, 26 centers. This is the registry of India. Over 2016 patients are there. Look at the mortality, less than 2% in India. So even in India, when we had a HIPEC register, mortality is less than 2%, morbidity is very low. If you want to do stoma or if you want to do anastomosis, always do anastomosis first. Then you do the HIPEC. This is my paper, which is a prospective only paper in the history of HIPEC, which showed anastomosis if you do before or after, it doesn't make any difference. This is also published, you can go back. This is the NCCN which has put for mesothelioma, CRS HIPEC as a level 1 evidence. Level 1 evidence for mesothelioma, you can go back and read. So I will conclude in this finally telling this is a Castripec trial which was published recently, which showed that if you use chemo and HIPEC in gastric cancer with 9 PCI, then there is a very high survival benefit, and colorectal cancer up to 14 you can do that. So in conclusion, surgical skill, expertise, understanding the disease of peritoneal, performance state of the patient, operation successful, patient died. So please don't do that, look at the patient. Then the setup where you do and what is your skill set, balance morbidity, mortality and the biology of the disease. None of these are in our hand. Only one thing is there, surgery performed by aggressive surgical team able to achieve. Don't take a patient for CRS, HIPEC or PIPAC without discussing an MDT with your medical onco, pain, palliative, nursing team being there. They may give a better idea what is the right sequencing for you to do. Keep PIPAC also with HIPAC because it is required for you to do. Right patient should be done in a right way. When everybody agrees, that is when it helps. And the whole team is important. And remember, a fool with a tool is still a fool. So a bad surgery cannot be compensated very beautiful HIPEC machine. Okay, that is my lovely family, my wife, my daughters who are professional Bharatanatyam dancer. Thank you for inviting me.
My bad throat. Any questions?
Actually, a lot of questions will be there, but difficult to run. Maybe you can meet me over tea, or you can attend our course, or you can attend more sessions. We can ask and discuss and debate.
Super awesome session.
Thank you.
Thank you so much.
Thank you.
Thank you. Thank you, Dr.
Yeah, there is a very long learning curve in HIPEC. When I started it almost 10 years back, the learning curve was 90 cases. Means, see, the golden rule of CRS HIPEC is what? People think it is very complicated. No, mortality is same as normal surgery. Morbidity is same. Patient goes back on 7th day with ERAs. First adjuvant chemo is taken within 20 days. Between second, third week, I send my patient back. Now with all the available technique guidelines, the learning curve has come down to 40. So we have set up a good team in my HIPEC team. All the patient goes through a good nutrition regime, physiotherapy regime. Surgery is done bloodless fast, and there is a specific ERAS regime which we apply. So that's why. But the beauty is, I showed you the Indian HIPEC registry. Lot of cases in India are done in government hospital, very poor nutrition. Even then, across India, in a center who is doing at least about 100 a year, the mortality is around 1, morbidity less than 10%. So if you are doing 2-3 HIPEC, like vacation, I say एक बार Switzerland गए, Thailand जाके, ऐसा नहीं है. If you are doing that regularly, that is the center where you should do, or you have to build up that center. So centers who do 100 HIPEC a year, morbidity, mortality is very minimal. It is like any other surgery. Otherwise, you end up with a problem. In French protocol, 4% is the mortality.
Thank you.
Thank you.
Thank you. Can we take up a few quiz questions? Our quiz master, Dr. Ajay.
So we have 3 questions and we have cash award for that. These are simple questions. Those who will answer first, they will be awarded with cash prize. So you will identify who will raise the hand first. So our first question is, how many lymph nodes are required for optimal surgery in colorectal carcinoma? No. When we will, you have to raise the hand, not answer. So who raised first? So 12 is right. Thank you. So you are surgical oncology colleague? So our second question is, how many adenomas are required to label it as FAP, and how many % will develop cancer if they are not treated? Second part? Right. So ready for third question? Third question is, so you have to name this trial. This is the study design. Disease is CS stomach. Patients were randomized to capecitabine with plus cisplatin versus capecitabine plus trastuzumab. Who raised first? Toga trial, right answer. Thank you.
So we proceed towards our next session, role of systemic therapy in advanced hepatocellular carcinoma, recent update. Can I please call Dr. Sushant Kumar Paikre to present his talk?
Hello. Good morning to all, and welcome to all to our temple city that is called Bhubaneswar. So it is Nice to have that fourth Indo-Onco here in our state and this city. And this type of event should happen in not only in metro cities, but also Bhubaneswar, like Bhubaneswar and other tier 2 cities, and so that people know each part of the country, what happening in everywhere. Thank you to organizing team to give me the opportunity to present this topic. And today we'll discuss systemic therapy that about advanced hepatocellular carcinoma. Before going this, we should know the incidence. It is second leading cause of mortality in the worldwide. But in India, it is it is among 10th most common, but mortality still high. You see, around 34,700 patients are diagnosed, but among that, among these, 33,000 are died. So it is high mortality in our country. This is the BLCC staging, how we manage the hepatocellular carcinoma. Initial stage, if it is very early stage, we know we have to resect it out. But if it is more than 3 or more than 3 centimeter size, or it is portal vein was infiltrated, then we are not able to give the local treatment. So we should go ahead with the systemic therapy. So for advanced or hepatic extrahepatic spread, we have to go with systemic therapy. And in terminal stage and child-pox C, if liver dysfunction is there, then and PS3, then we have to go ahead with the best supportive care. Next, coming to the topic of discussion, that is systemic therapies for management of hepatocellular carcinoma. We know this is the very good slide to show that what are the treatment available for first line treatment for advanced hepatocellular carcinoma. First is sorafenib, then coming to lenvatinib and atezolizumab, bevacizumab. This is the sorafenib. If we going to trial wise, this is a sharp trial in sorafenib. In reflect trial, it is lenvatinib versus sorafenib. And in the IM Brave 150, it is the comparator is the atezolizumab, bevacizumab versus it is sorafenib again. So all the trial they comparing with sorafenib. In sharp trial, they compare with placebo. So this is the sharp trial. It was published in 2008, and here they showing there is sorafenib versus placebo. That here they seen that median overall survival 10.7 months versus 7.9 months, which is significantly different. So there is overall survival benefit in across the all region. But if we going to Asia specific, if you going to Asia specific for Asian population, that also they showing median overall survival 6.5 versus 4.2. So we conclude that sorafenib in first line setting unresectable hepatocellular carcinoma, if you are giving, there is a significant overall survival benefit. But sorafenib associated with toxicities, we know sorafenib most commonly associated with mucositis, hand-foot syndrome, hypertension. These are the most common side effects, and also associated with the loss of appetite, and sometimes it is fatigue and gastritis. Then coming to reflect trial, I want to focus here that this trial was published in 2018, and the SHARP trial was published in 2018. From the 10 years, we have no choice except sorafenib for first line of treatment. Then the lenvatinib came after 10 years of sorafenib, sorafenib trial. So here they compare with lenvatinib with sorafenib, but here they found the overall survival is 13.6 months versus 12.3 months, which is not significant. But there is a PFS benefit that is 7.4 versus 3.7 with significant p-value. So, and also there is median time to progression also very much significantly different. And here they also found there is a response rate which is very much significant. It is 24% versus 9.2, which for which we are likely to use lenvatinib in spite of sorafenib. But you may use sorafenib also because there is no overall survival benefit. If you using lenvatinib, then you get rapid response. Most of patients were responded to the sorafenib with no significant difference in overall survival. The lenvatinib also associated with side effect that is most common is hypertension, diarrhea, or decreased appetite, and also associated with decreased platelet count. This is the real world scenario where they using the total 31 patient and that BCLC stage C with those are not a viral hepatocellular carcinoma, childhood A, B, C all included, and lenvatinib using 12 mg per day above the 60 kg and 80 mg per day it is less than 60 kg. Here they found PFS, median PFS 7 months, overall response rate 9.35 and disease control rate is 58%. And so if you compare the original trial and it is matching that it is PFS around 7 to 8 months and overall response rate is 20% around. This is another trial with real world scenario. They also using PFS benefit irrespective of etiology. That is whether it is viral hepatocellular carcinoma or non-viral hepatocellular carcinoma, in extrahepatic or not extrahepatic, all the groups are compared. They found lenvatinib is effective in all age group, and the forest chart also showing favors in all age group whether the alpha AFP level is less than 200 or more than 200. In all age groups, they found difference in the lenvatinib is effective. Then coming to that first line, that is whether the immunotherapy is effective or not in advanced hepatocellular carcinoma. This is the IMBRAVE 150, that is atezolizumab, bevacizumab versus sorafenib. That in REFLECT trial, they did not find any overall survival benefit. But in this trial, when they compared with sorafenib, they found overall survival benefit. That in detail, the patients are enrolled as locally advanced metastatic hepatocellular carcinoma, childhood A, and ECOG performance status less than equal to 1. This actually, if you ask me, this type of patient we did not found in day-to-day practice in our country, because childhood A and ECOG performance 1 with metastatic spread, it is very difficult to find this type of population. But still, they find they enrolled 500 patients enrolled, that is atezolizumab and bevacizumab. That is atezolizumab 1200 mg 3 weekly and bevacizumab using very high dose, that is 15 mg per kg 3 weekly, and versus sorafenib 400 mg BD. Then the primary endpoint here is overall survival and PFS benefit. The OS here, in the curve, it is around 19.2 months versus 13.4 months with significant p-value with hazard ratio 0.66, and median PFS is 6.9 versus 4.3. So both OS and PFS are very much significant here. Though we are getting the benefit if you using the upfront atezolizumab, that is immunotherapy, and bevacizumab. If you are using, then it have very significant OS difference and PFS difference. But thing is that the patient have to PS1 and childhood A. Here the overall response rate is 30%. No doubt it is very much difference in the response rate. The another thing is the complete response rate. Complete response rate is very much high. That is 25% is have complete response compared to 1% in sorafenib. If you real world scenario, if you discuss, if you are giving sorafenib, very few like the data, very few patients may achieve complete response rate. But here they were able to achieve 25% of complete response rate. And the disease, that duration of response was also very much high. That is 18.1 versus 14.9 months. So coming to side effect, if you discuss what is the side effect, what is the quality of life in sorafenib, even if it is single agent in oral tablets, it is more toxic than atezolizumab and bevacizumab. Because sorafenib have very significant, that is, they have diarrhea, they have hand-foot syndrome, they have also decreased appetite, all the things associated with sorafenib. And in atezolizumab, it is only the bleeding risk which associated with the atezolizumab compared to sorafenib. And the patient reported quality of life also very good with atezolizumab and bevacizumab. This is the TTD, that is time to discontinuation. How much patient can continue the atezolizumab, bevacizumab and the sorafenib. It is 11.2 months. The patient can take till the 11.2 months till toxicity, that is the time to discontinuation, compared to it is 3.6 months in sorafenib. So quality of life is good, overall survival good, and that progression-free survival also good with atezolizumab, bevacizumab. And coming, that is, what are the precautions we have to take before using the immunotherapy and bevacizumab? That, like other immunotherapy also, we have to ask whether there is a organ transplant or not, whether there is autoimmune disease or not, whether there is a immune-mediated pneumonitis, colitis, endocrinopathies are there, and bevacizumab also like whether there is a recent surgery, whether there is any GI perforation, whether there is any bleeding, whether there is proteinuria or not, anything congestive heart failure. We have to see this type of things before using bevacizumab. Another thing also, whether there is any thrombosis or not. So these are the precautions we have to take before using atezolizumab and bevacizumab. Only thing before going to other slide, only thing by this trial, one thing is that everything has benefit here. That overall survival PFS. Only thing here in our resource limited state, it is the economy which prevents us to use this. And another I want to comment here, it was not compared with lenvatinib, whether it is the immunotherapy is beneficial with that is lenvatinib or not, we don't know. So if patient is affordable, we can use this for advanced hepatocellular carcinoma. Then coming to next, that is there is another trial, it is immunotherapy plus immunotherapy. That is, one is durvalumab and tremelimumab. It is using dual immunotherapy, immunocheckpoints we are using versus durvalumab alone and sorafenib. Here the primary endpoint also overall survival, and secondary endpoints are OS non-inferiority. Here again they are taking BLCC stage B or C and child PUC A and ECOG performance status less than equal to 1. And here they enrolled around 1100 of patients. This is the Himalaya trial, where also Ghanshyam sir also were part of this trial, and it is also enrolled in our city also. Few patients enrolled in our city also. And if you are giving the OS, that is, it is around median OS is 16.4 versus 13.8 months, and with significant p-value. Both the trial, the immunotherapy trial, that have significant OS benefit. And the 36-month OS percentage, if you compare, that is 30.7 versus 20.2 months. So here also they have compared with sorafenib, have significant OS benefit. The coming to tumor response and all the things, that is time to response, that is 2.17, and durvalumab 2.09 months, and it is 3.78. So here the immunocheckpoints has also rapid response compared to sorafenib. This is the treatment related side effect. In my opinion, the side effects are not much difference with sorafenib. In fact, immunotherapy checkpoints immuno checkpoints are more tolerable than sorafenib. Because most of time in our population we are not able to use 1800 mg per day. We have to use 400 mg, maybe 600 mg, maybe sometime 200 mg BD also. We have to use sorafenib. It's so much toxic. Coming to the trial, which I emphasize here is they use lenvatinib pembrolizumab versus lenvatinib. In this trial, they enrolled 750. The primary endpoint is PFS and OS. Here they did not find any OS benefit, which I emphasized before that, this previous immunotherapy trial should compare with lenvatinib, which is now, which is maybe significant effect. Here they trial, this trial they failed to prove OS benefit if they using lenvatinib pembrolizumab versus lenvatinib. So even some factors are favors lenvatinib pembrolizumab, some factor also lenvatinib alone. So then another topic is here, whether the etiology based treatment is possible, or whether patient is viral infected or not infected, the etiology factor is the hepatitis virus or not, then the treatment can be changed. This question was asked, and for this ESMO has some guideline. They enrolled non-viral advanced SCC and atezolizumab plus bevacizumab, lenvatinib or sorafenib 36 centers in 4 countries. Here their primary endpoint also overall survival. So here they found lenvatinib alone is very much significant in that is in non-viral hepatocellular carcinoma which are associated with alcoholic hepatitis or fatty liver. This type of patient are benefited with lenvatinib alone than atezio bevacizumab. Here both the overall survival and progression-free survival are more significant in lenvatinib alone group than compared to atezolizumab bevacizumab group. So these are the summary of the first line treatment, front line treatment, phase 3 trial, lenvatinib, sorafenib, atezolizumab, bevacizumab, all the trial are summarized here. Then coming to second line systemic therapy, if you are using, this is the slide, it's a very good slide to summarize how to use the second line. If you are using atezolizumab, bevacizumab and it failed, you can go ahead with cabozantinib or ramucirumab if the alpha fetoprotein more than 400, or you can, if you are not using atezolizumab, bevacizumab immunotherapy previously, you can use nivolumab, pembrolizumab or nivo plus EP. If you are using sorafenib or lenvatinib. Or you can use, after lenvatinib if failed, you can use cabozantinib. Cabozantinib may be the second, in second line therapy may be the treatment of choice if you are using immunotherapy and lenvatinib. So these are the another thing, the regorafenib, cabozantinib, ramucirumab. These are all the anti-VEGF inhibitors. So, so if you going to, I already discussed cabozantinib, we can use second line due to time constraint. So we cannot discuss details, but I can to focus the cabozantinib. If you have patient progress, cabozantinib have some help if you are not using anything. So cabozantinib plus placebo, cabozantinib have a very significant overall survival benefit and PFS benefit. It is 10.2 versus 8. So already this is the data, the resource trial. It is regorafenib and placebo. One thing I want to inform to you, regorafenib can be have beneficial effect if you are using first line is sorafenib. But if you are using lenvatinib or atezio bevacizumab, regorafenib may not work. So this is the highlight. And for ramucirumab, it is the alpha fetoprotein. If more than 400, we can use. So this is the summary of the second line therapy, what are things to be used or not to use. The regorafenib, ramucirumab, cabozantinib, only thing regorafenib can be used if you are using the sorafenib in first line. This is the guideline that atezolizumab, bevacizumab is the category 1 recommendation for first line. In our state, if the patient is affordable, we can use atezolizumab, bevacizumab if patient have child-poor class A. And other things are sorafenib, lenvatinib in the other recommended regimen, and we can use second line in the ramucirumab, cabozantinib. Thank you.
Thank you, Sushant. Thank you, Sun, for the sponsored session. So now we move to a panel discussion. advanced colorectal cancer. So moderated by Dr. Chinmay Pani. Dr. Amit Kumar will be joining virtually. Tushar? Tushar ko nahi? Amit Kumar join kar dekho to? Amit Kumar join kar dekho?
Yes, sir. Joined.
Yeah, okay. Sumit Goel is also joining virtually. Then we have physically Prashant Parida, Sudham Sarangi, Sangram Kesri Panda, Dr. Aparna Dhar, and Tushar Mahapatra. Chair. जाओ ऊपर चले जाओ. Sumit join करते
I'm there, sir. Good morning, sir. I'm there, sir.
Yeah, thank you, Sumit. Thank you. Good morning.
Yes. Good morning, sir.
Good morning to you all, and respected chairperson, my honored delegates, and it's a proud privilege given me the platform by Dr. Bishwas to discuss about the panel discussion regarding metastatic colorectal cancer. And my learned esteemed panelists are there with me, to whom I am going to ask questions very quickly. So due to the time constraint, I requested everybody to speak very focused point, because otherwise we'll have difficulties in doing this. So I'm so sorry. Can we last? Okay. So here you go. We all know. Okay. Still it is not working. Okay, sorry. So my panelist, Dr. Amit Kumar is there online, and Dr. Goyal sir is there, Prashant is here, and Dr. Sudham is here, and Sangram is here. Dr. Dhar is here, and Dr. Tushar is here. So, you all know that in the global data that the colorectal cancer incidences are increasing, and the number is quite high, and so also the number is quite high in India too. So my first if you see the colorectal cancer, metastatic colorectal cancer, it may be an oligometastatic disease, or it's maybe a disseminated metastatic disease, and almost the data shows that 15% are the oligometastatic disease, and almost 85% are non-resectable at clinical presentation, and out of which the never resectable are in the range of 70 to 90%, and 10% are potentially resectable. Is the same thing that you got in the clinical practice, or you beg to differ, or you have any difference in opinion? Anybody can say. Prashant, you are in a very high volume center. You can say. So my question is that, are you seeing the resectable metastatic patient in 15% of out of all metastatic colorectal cancer, or your number is less or more? Okay. Sure. Sure. So for evaluation, do you routinely practice PET-CT in a metastatic colorectal cancer? To Dr. Amit, who is in online, do you routinely
No, sir.
practice?
So for colorectal, it is mostly the CT, thorax abdomen, and is being done. In only in the rare situations where we are thinking it to be a potentially resectable disease, in that case, we are going for the PET scan in those group of patients to just to rule out if there is a metastasis also. Otherwise,
Yes.
so for routine practice, it's only a contrast CT.
Okay. So, Dr. Tushar, can you elaborate in which condition you provoke or you call to the medical oncologist to go for the PET-CT?
Chinmay, so far as NCCN guideline is concerned, so far as oncologists are concerned, the role of PET-CT in carcinoma rectum and carcinoma colon ends before it starts. It's like, so if you go into few points, that is CT and MR are adequate in evaluation, and whenever there is an equivocal finding or doubt, you can go for PET-CT for confirmation. And universal indication, wherever in any type of cancer where there is creatinine is increased or chronic renal failure patient, so you can go for PET-CT because you cannot give contrast in the CT scan or MRI. The most common indication or the classical indication is when there is a potentially the plan of metastatectomy.
So, oligometastatic disease that you are
potentially resectable disease.
So
you can go for PET-CT to rule out any other site of metastasis.
Correct. Okay. Correct. Almost it is clear. Routinely not indicated. In oligometastatic disease, definitely there is some indecisive condition where the contrast was an issue or the intermediate lesion, or in the monitoring per se, and if there is a little bit confusion, and there is another condition when there is asymptomatic rise in CA and you are not getting any lesion in that condition, PET may help you to get an early.
Chinmay, for the house, the summary or the single liner is when anatomy is not distorted. That means you have not intervened. Surgery is not done, radiation is not done, no chemotherapy is not done. It's always the anatomic modality, either CT or MR. But when anatomy is deformed, it is the PET-CT. That is the summary of the investigation.
So there are many influencers that changes the treatment plan. One is patient, another is molecular characteristics, then there's tumor characteristics, then the patient preferences, then finance and cost. So many are the determinant variable that will change the treatment outcome. And out of which the anatomical location, the right and left, change the mindset after 2016 or maybe 2017, and there is a lot of data coming that what is effective, what is not effective in the both right and left, etc. and etc. But the most important thing is that what the progress we got, it is due to the availability of the biomarker that actually changed the treatment paradigm of the patient. So and initially we got in difficulty because probably the block what you send from the pathology and for the evaluation for not doing the biopsy in the metastatic setting, and we got a call from the molecular oncologist lab that the fixation of the tissue is not proper. So my question to Dr. Dhar, so can you elaborate how to make the block properly so that we won't get a call like that in order to increase the sensitivity of the test? Yes, madam. Okay. So thank you. So it is basically a neutral buffered saline, and this is the retention time. And you are telling maybe 10% tumor is perfectly fine. Okay. So fantastic. The other questions is that So other question to madam, because we need to understand and how, when, and what to profile, because there are armamentarium of lot of molecular biomarkers that has been developed, and my questions to my medical oncologist that routinely the molecular testing should be done. So are you doing in 100%?
No. If you will ask me for my opinion in my personal or in my clinical practice, though there are some patient support program from the company side where I was able to do it almost 60 to 80% of cases, but nowadays they have withdrawn, so almost 50% of cases I am able to do, especially at least individually, KRAS, NRAS, BRAF. So these are the tests, and though MSI or MMR should be done in all cases of colorectal carcinoma from the diagnosis, whatever the stage may be, but most of the time I am not able to do that also. So also
thank you.
For to new, I have started to do in the first line whenever it is possible. So if you will ask me, it is less than 50%.
Okay. So Sumit sir, are you there? So are
Yes,
you
I'm
doing
there.
the
I'm
yes,
there,
sir. Yes sir. Are you doing the repeat biopsy from the metastatic site or the primary site sample you are sending?
It depends. If it is oligometastatic disease, definitely we are trying to prove the metastatic site also whether the disease is there or not. But if the tissue is not there, it does not matter from where we are sending. Till a year back, we were sending for all the patients, but now we had a thesis program, so that's why we were able to send. But now, rightly said, there are a lot of constraints. We are not able to send in all the patients. But yes, we are trying to send in as many as patients who are affordable, approximately 60%, 50%, the same range.
Okay. So my another question is that, madam, you are a very proponent of the liquid biopsy. So can liquid biopsy replace the tissue when it is not there for doing the testing? So my quick question to Sumit sir. So are you doing sequential or you do NGS upfront?
No, we are not doing NGS upfront because the value, to my understanding, is very limited that we get from NGS. What we are doing is we are doing MMR, MSI, either part of the PCR test that is incorporated in KRAS, NRAS, BRAF, and HER2 we are doing by ISC.
So, Dr. Amit, what do you prefer in MSI, either do in ISC or in do the PCR testing?
No, ISC is initially what I am considering in my practice. So first line sending ISC for all the things, and rest the BRAF and all rest with the PCR based. Otherwise MSI, ISC and HER2 ISC, which I is practicing.
So if the first line mutation, if the first line you have started chemotherapy and then the disease recur after a duration of 2 years, so do you do the repeat testing? Madam, are you advising to go for the repeat testing? If the sample is good and first NGS has been done, and so are you advising to go for any, so I mean to say any change of mutation pattern seen when you are seeing a not second prime in the metastatic in the second line? Sumit sir, do you agree? If you have done the NGS in the first line, are you provoked to do the NGS in the second line when it is metastatic?
See, NGS, actually I did not hear what the madam said because the panelist, the voice is not there. We are not able to hear that. But our understanding is what we are doing is, suppose I have run out of the treatment options. I may be tempted to do it at the end if I have done it earlier, just to see whether something is there or not. The second indication that we are doing is, suppose we are re-challenging with EGFR inhibitors. Then to see the NeoRAS variants, maybe we are doing at that point of time. That we are doing on liquid biopsy also sometimes.
Okay. Okay, sir. So I'm not going to ask in this regard more. And these are the so the recommendation by the 4 marker has been advised by the ESMO. So you are all well read and well. So okay. So I'll not ask about the HER2 testing now because of the lack of time. Kindly make the screen enlarged. Okay. So the outcome has already been improved and it is going on improving, and there are a lot of new recommendations coming to move forward. So let us go to to surgeon. So what is your basic, because you know as the lines increases, the progression-free survival decreases and the response rate also decreases. So most important thing in discussion in a MDT, that whether it is a upfront resectable or not. So you just tell me what are the oligometastatic disease where you like to operate first, and what is your policy in your MDT and how you prefer? Dr. Sudham.
Upfront operable, you are selling, sir?
Yeah. So initial resection when you want to do, or what are the indication of the oligometastatic disease when you want to go for surgery? It is only liver only disease, or it is liver, maybe lung, or any peritoneal disease, because Dr. Somsekhar told that the peritoneal disease, some segment you can do surgery too.
If a limited metastatic disease, then obviously we will go for first chemotherapy and followed by surgery.
Okay, so I mean to say, in what condition in the MDT you will tell the oncologist that the surgery can be done, what is in the liver part, what is in the lung part, what is in the peritoneal part, does it have any survival advantage of doing the surgery or doing the local therapy to this?
Yes, if it is limited metastatic disease to the liver, we can go up to metastatectomy up to minimum 3 liver metastatectomy we can go. But before that we should proceed for chemotherapy for the survival benefit. And even after lung metastasis is there, we can go for lung metastatectomy after chemotherapy.
Okay. Regarding peritoneal, what is your option, Dr. Sangram?
Yeah. So first we have to see how much the tumor burden in a metastasis. Means in only one organ like liver or multiple outside abdomen or inside abdomen. Second is we have to see what is the, can we achieve the R0 resection. Primary site is resectable or not, that is first important. So if primary site is resectable, then only metastatic has a role. Otherwise, it has no role. Second thing, we have to see if metastatectomy and primary resection can be done simultaneously or staged procedure. Okay. That is another point. So first we have to give neoadjuvant chemotherapy, then go ahead with surgery like either simultaneously primary with metastatectomy or staged operation, then completion of the chemotherapy. So, but there is no consensus regarding that whether you will go ahead with simultaneous surgery or staged procedures. It is totally surgeons dependent and surgeon's decision, purely surgeon's decision depending on the local extent of the disease and resectability, whether we will achieve R0 resection or not.
So the ESMO guideline says if it is a clearly resectable, go for resectable. If it is a borderline or the resectable is in a little bit of confusion, then go for the neoadjuvant chemotherapy. Yeah. And before doing neoadjuvant chemotherapy, you plan for the molecular profile, then you give chemotherapy. Regarding the poor performance status group in older age, Dr. Prashant, so are you always tend to give the doublet or singlet is better in an older age? If singlet, then what is that? Number one. And number two question, if it is younger, then are you intensifying giving the triplet therapy? So what is your opinion on that?
So doublet versus triplet.
No. In older, when the performance status is low, are you giving single agent chemotherapy along with targeted therapy?
Yes. So those who are frail patients or elderly with some comorbidities, even it has been seen few trials, single agent with biologics or as a monotherapy. It is also have similar benefit with
so
doublet
you have
also.
answered the questions. Single agent chemotherapy along with biologics like bevacizumab can be tried. There is data from the PANDA study that the 5-4-uracil along with panitumumab versus the modified FOLFIRINOX, and in the wild type group you can give panitumumab and cetuximab in the group of more than 70 or 75. And does young age is a poor prognostic factor, Dr. Amit? If you see a patient of less than 40 colorectal cancer with metastasis, are you tending to provoke the patient that will respond poor? Are you intensify the therapy in subgroup of patients?
Yeah, surely if the patient performance status is good and a young age, I'm going for the triplet regime along with the addition of the targeted therapies in those group of patients.
Okay. So per se, Sumit sir, are you telling something? So per se, the patient, those who are younger, they behave very poorly in spite of the adequate treatment, and intensifications of chemotherapy may not improve the survival of the patient. And another important question I like to, can you last one? So definitely when the oligometastasis is there, then definitely there is an improvement of the overall survival. So are you telling, Dr. Prashant, are you telling that the cure can be achieved in oligometastatic colorectal cancer if that can be achieved, that is in the liver limited disease or in the peritoneal disease or in the lung disease or in all of the three?
Yes, if with resectable metastatic disease and we resect, the outcome is better. Even some of the trials and meta-analysis shown that those are resectable will resect. The 5-year survival is almost 30% around.
Fantastic.
And if you will resect.
Correct. So correctly you have narrated.
Yes.
So patient resectable and surgery have resected, the outcome is better. Resectable, not resected, the outcome is poorer, and if it is unresectable, then it is less interest. It is not only for the disease of the liver, but also in the peritoneum, though there is lack of randomized control trial, but we provoke to think because our surgeons are very aggressive, they can able to do the HIPEC, and so also that has been extrapolated to the pulmonary metastatic too, to go for the surgery after giving the neoadjuvant chemotherapy in that setting. So till what extent, if the lung and liver both are involved, if lung, liver and peritoneum both are involved, till what extent you can go for doing surgery? So 1 disease, 2 disease, 3 disease, 4 disease. So what is your...
Actually, surgery has role in oligomets, not in extensive disease. First of all, even liver only, yes, there is a survival is up to 30% of our survival. Lung, livers, also you can go ahead. If lung has 2 to 3 deposits, it can be resectable.
Perfect.
And in peritoneal disease, of course, there is no standardized randomized control trial, but still there are ICARO study and 2-3 studies are there who found around PCI less than 15, it is a very good prognosis and good survival. More than 15, we should not go ahead. And recently, PRODUCE 7 trial, French trial also came in that they compared CRS versus CRS plus HIPEC also. In that they found CRS is benefit, overall survival benefit, but adding HIPEC there is no extra benefit of survival. Also, it is increasing the complications. So, PCI less than 15 in a peritoneal disease only, and that the limitation is that disease should not go beyond abdomen. Then only peritoneal disease we can go ahead with CRS plus minus HIPEC.
Perfect. So my question to Dr. Sumit sir. Sir, left-sided RAS wild type. What is your preference and what is your chemotherapy backbone, oxaliplatin versus irinotecan, and the targeted therapy of choice, panitumumab vis-a-vis cetuximab?
So first thing is left-sided tumor, RAS wild type, pan-RAS wild type, BRAF not mutated. My choice definitely is to add EGFR inhibitors. So backbone, it will depend upon the 2 things. One is the age and the toxicity comorbidities of the patient, the likelihood of neuropathy that patient is likely to have, and the renal function test.
So patient is fit.
Fit, I will add Folfox with the panitumumab but there is no such thing. We can add either panitumumab or cetuximab. But the FDA approval, I think, is with Folfox, and first line is with panitumumab. But we can use either of them.
Okay.
And if there is contact
Sir,
indication or something.
Sir, my question is that Folfox, Latron, Folfiri, vis-a-vis Folfiri, Latron, Folfox, the result almost equal. So
That's
how you
the same,
optimize to give Folfox or the Folfiri? So that's my question, sir.
I will give Folfox first.
Okay. Okay.
The results are the same both ways. Anyway, whatever you do, they are
So perfect. There is, I think, no doubt about it. Everybody agrees that you have to give either Folfox or the. Regarding the two targeted agent, panitumumab versus cetuximab, how you choose and opt, Dr. Amit?
Yeah. So it's mostly what in our practice is mostly using cetuximab in this group of patients. There's no hard data to not to give panitumab, so it's just counseling the patient and we can choose either.
Okay. So my next question is that in the KRAS mutant and in the right side and VRAF mutant. So what is your options of therapy? Either right side, number one, number two, mutant BRAF, and number three is KRAS mutant. What is your option, Dr. Prashant?
So if KRAS mutant, the biologics will be always bevacizumab along with bevacizumab, either doublet or a triplet. So it depends upon who is someone younger patient with potentially resectability. Then I will prefer a triplet, where because if we give triplet, the response rate will be higher.
Perfect.
And it has been seen that the response rate is correlated with the resection rate also.
Perfect.
So
basically, you
has
prefer to give the triplet
Yes.
and along with bevacizumab
Especially
because
in
it has a
potentially
more
resectable.
response rate, so that it can give the conversion rate will be high to go for the surgery, and overall survival data not came. That is yet to mature. This is by the Cairo 5 study, and so also the BRAF mutant cases. So in the MSI high, are you routinely practice to give pembrolizumab to the patient, or still you are giving chemotherapy? Because the penetrations of the pembrolizumab into this in the range of 3% because it's a cost factor. So what are actually doing in the MSI positive group?
So the data regarding MSI high subgroup, especially those who are unresectable or potentially resectable, we have options of using IO like pembrolizumab or Nivo plus EP.
Yes.
But the data is promising, so we have to wait for the mature data, the OS data. So that is a very good option with good quality of life, because if we'll start with some IO agents, quality of life will be better in comparison to the triplet plus biologics.
So I think this is the algorithm. The first line, if it is clearly resectable, go for surgery, and if it's not resectable, then do the MMR status. If the MSI is high, go for MNO by the keynote trial. If it is stable, then it is fit for the chemotherapy. Then left and right, what we have already discussed, and the BRAF already well discussed. I think I am stopping this because of lack of time, and I'm not going to the maintenance. Do you believe in maintenance? Are you giving maintenance just
Yes.
one half line? Okay.
Yes.
Okay. So then second line you have to opt Latron and choose the alternative drugs, and I think I have covered some topic, and okay, thank you very much.
So Dr. Aparna, what is your take on doing a regular ctDNA
Yes.
patient
Because lack of time, I could not
patient
ask
who has
you.
progressed on anti-EGFR. So what is your take on that?
So in adjuvant and vis-a-vis in metastatic setting. That's my.
From a treatment monitoring perspective, in a metastatic, yes. Adjuvant too, I think we have very good data that's come out that does show the benefit of ctDNA. However, then if you are doing ctDNA, it has to be done from the correct lab. It comes because it's very sensitive, right? So when your patient has gone through adjuvant chemotherapy or has even progressed, or you're doing it in a metastatic setting, it's extremely difficult calling out these mutations. The sensitivity has to be very high. So whoever's your service provider, my main point. Doing something is great, but make sure the technology supports.
My question is on metastatic setting, are you still convincing or using the ctDNA data? In adjuvant, there are enough data. In metastatic?
Absolutely, because if you suddenly see progression, you have, so in metastatic setting or any, when we're just treating patients in general, you know, as just before the resistance comes in and the patient starts responding, if you can see that slight spike, you get to change chemotherapy, so it might not change line of treatment. It's easier, I wouldn't say easier, but it's a little less difficult versus, you know, when the patient, the tumor is fully resistant. So while yes, it's very clear cut in adjuvant and metastatic we're still getting there, but I've always seen physicians using it more in a metastatic setting, and we have seen it to be very, very beneficial, to be honest.
Thank you.
So another question. So normally KRAS, NRAS, BRAF, HER2/neu, MSI have been done on baseline. Patient exposed to oxali, irinotecan, bevacizumab, cetuximab. Still good GS. So what is the role of doing a CGP or NGS? So what is your take? So are you going to pick up something which can be drivers so that the patient can get some benefit of that treatment?
So upfront CGP, I think for me, if a patient can afford it upfront, the reason I would prefer it is because while it will not tell you the driver from a therapeutic implication, it will actually help you understand what is the tumor biology. Is this an aggressive tumor? Something like a PEAK1 mutation will tell you your patient will not respond to chemotherapy or immunotherapy or just any therapy in general.
Yes.
So a lot of these genes are actually indications that are telling you what's happening in the tumor, what is the tumor thinking. So to understand your next line of treatment, I prefer CGP, but I know it's very expensive, but it does help me understand the biology of the tumor, which in turn helps us.
It's not more expensive than a human life, definitely.
Absolutely, that is it, but you see, then it happens that the molecular person only wants CGP, so I put that caveat.
So people spend so much on cetuximab, panitumab. So it is half the cost of one cycle.
One course of therapy is half that cost.
If you can afford immuno, you can do this for sure.
Thank you so much, Chinmay.
Thank you, sir.
Thank you so much, Sumit and Amit joined virtually. So we now move to one of the keynote sessions by Dr. Sabyasachi Parida. And so he'll talk on oncoplastic techniques in breast cancer surgery from his own institute, KIMS.
Very good morning, and thank you for giving me the opportunity to present my work. So as you can see, it's a vast topic. So what I'll be doing is I'll be touching upon that part that is relevant to practice and that I can do justice with rather than the entire gamut of it. And so you'll have to bear with me when I skip certain parts just by mentioning them. So these are my, it's not working, okay. These are my disclosures, so it's always teamwork. And this is how we'll still proceed. So it shall be part of science, the art, and some of those that I can consider as innovations. So coming to the science of it, now as you can see, breast cancer is the most common site for cancer worldwide. Incidence is increasing, faster increase in countries like ours, and India ranks with China and USA among the top 3. And more and more younger patients, although you still have more patients aged above 50 as a bulk of it, but more and more younger patients are getting breast cancer at a faster rate. So breast cancer survival is increasing because death rates are coming down. So, and that leads to is that it is the most prevalent cancer today. What it implies is that more and more younger women are suffering from breast cancer, survival is improving, and hence the importance of quality of life of the survivor is becoming more and more important. So I want you to remember this. This is the background on which we shall discuss. So more of science coming from radical to modified radical to breast conservation. So that's all data which proved it. So is this enough? Probably not. That's because when you are not replacing the lumpectomy cavity with adequate tissue, then this is what might occur. If you want to avoid these things, therein comes the role of breast oncoplasty. So what are we doing in breast oncoplasty? We are trying to remove the cancer with adequate margins of normal tissue, while at the same time making the patient look as good or better than she looks now. So you remove the ideal volume, avoid breast deformity, and reduce the indications for mastectomy, make BCS safer oncologically and better cosmetically. So coming to basics of it, incisions, these are what you consider in case of other skin lesions, but in the breast the incisions can be different. So if you know these incisions for small volume disease, these will be adequate. So bat wing, hemi-bat wing, semilunar, and these all incisions. So this is how it was classified by Krishna Claw et al. When they proposed it initially, that when you have less than 20% of the volume excised, level 1 techniques suffice, 20 to 50%, then advanced techniques come into play. So if we try to understand roughly what it means you have two different types of techniques. One is volume displacement, where you are displacing the breast itself, remodeling the breast to make up for the deficit. As a corollary of that, you are reducing the breast volume. So there are techniques at the bottom part which means reduction mammoplasty. So that is one part. The other part is where you are replacing the volume deficit with other flaps which are coming from near the breast. So that is another part. So coming to displacement techniques. So this is J-plasty. Roughly, this is a cartoon I made just so that you can understand. There's a left breast lesion that is excised. So you move the breast medially so that is what you get at the end. So it is a smaller breast, the nipple areola rises up a bit. So this is a matrix rotation technique. Again, you can remove good volume and then do that. You can also do dual planing. That means you can move the breast parenchyma separately from the skin if required. So that is another technique. This is a Grissotti flap. This is in fact the first flap that we had done in 2015, and these are the results that we got in that case. Matrix rotation, this is a filled streamer, but I'm showing it just to show you the technique. So those are the results. Reduction mammoplasty, I'll mention in passing, is based on an understanding of the blood supply of the breast. So it may be a supramedical, medial pedicle, inferior pedicle, and the like. And this is what I mean by that. So I do not do much of this, so I'll not be talking about this motion. The replacement techniques are my forte. Perforated flaps are my forte. Free flaps come into place when required. Now, when you're talking about perforated flaps, it may be based on vessels, which may be a LICAP, which may be an anterior intercostal perforator, medial intercostal perforator, lateral thoracic artery perforator, or even a TDAP. So free flaps, of course, you can do. So coming to perforated flaps, a semilunar flap is not based on any particular perforator, but nevertheless, it can be used for small defects laterally. You can use a lateral intercostal artery perforator flap also for defects. So those are the results. Thoracoepigastric flap is an uncommonly used flap which can be used in cases where there is an inferior deficit. For this patient, this is there. That's a deficit. The ACAP pedicle is shown to you just for demonstration. So that is the result. LTAP flap is my favorite flap. Here I'm using it for a superior defect. That is the flap. And those are the early results. So adjunct techniques to BCS I shall mention in passing. Lipomodeling is very important when you have contour defects. NAC graft, or you can have nipple sharing that can be done for reconstruction. Sentinel lymph node biopsy by blue dye or by using ICG, these can be done. There is a lymphatic tract and all. So axial reverse mapping is used. Blue dye is not very effective. ICG is effective when you want to avoid damaging the axial lymphatics while doing an axillary dissection. So sometimes you may see this. This is very rare. This is part what I had captured once. So going ahead, lymphovenous anastomosis may be done at the time of surgery if you want to avoid lymphedema. And in those cases who have lymphedema, you may go for lymph node transfer. So moving ahead, specimen mammography comes into the picture when you have a patient with DCIS. This patient has got segmental DCIS with small foci of carcinoma. So how we go about doing it is this patient also had involvement of the subareolar plexus as per an MRI. So resection volume in this will include that part along with the areola. So that is the defect, and that is a specimen mammogram which has been compared with the patient mammogram, and that you can see has led to proper excision. So again, the flap is there, ICG has been used, that is the flap, and there are the results. Wire-guided clip localization comes into picture when post-NECT the lesion is no longer palpable. You have put a clip in the lesion. This is pre-NECT, post-NECT, that is the clip only visible. So you localize the clip with the help of a wire. So you can see the clip over there. That is under ultrasound. That is the wire with the introducer needle. Needle being placed inside. I shall go forward. So that is the wire in place, and you can see it is within 3 mm of the clip. So this is how we proceed. That is a specimen, and you do a specimen mammogram to ensure that you have excised adequate volume of tissue around that clip. So that is a reconstruction for the patient, and that is how it is. So coming to the innovation part of it, there are some innovations in my practice that I've done that are not commonly reported, are not in world literature. So the MICAP flap for upper inner quarter lesions is something, this is a reoperative case where we had DCIS in the upper supromedial part, and we had to reoperate. So that is how we locate the medial intercostal artery perforator. So that is a flap. That is a pedicle of the anterior intercostal arteries, again not required in this case. You are seeing the MICAP perforator there, and that is after reconstruction. So LTAP flap for central breast lesions is something that I am doing routinely nowadays, and this is the case. This is how you localize the LTAP pedicle with the help of a Doppler. That is there. So other pedicles have been marked out. I will not be showing them because of want of time. Okay, so that is the patient where you, that is sentinel lymph node biopsy, lumpectomy, that is the vessel. There you can see the vessel pulsating. That is the lateral thoracic artery. That is the flap ready. And this I'll show as a video if possible. So reconstruction is completed. Then in extreme oncoplasty is where you have larger lesions, or you have multifocal lesions, or you have multicentric lesions. Even in those cases, carefully selected cases, you may go in for oncoplasty. So this is a case of large volume replacement where you have a patient who has got multifocal disease, post-NSAT, persistent, some lesions are close to skin and hence require skin excision also. So that is a resection specimen, more than half a kg, that means almost half of the breast has been removed. So that is a flap. It encroaches on the territory of the LICAP and LD. That is a pedicle. Deepthelialization in progress. The pedicle, that is a large volume replacement. That is on table. These are on table aesthetics. They are even better right now, but I don't have the images right now for that. And LD for thoracodorsal artery perforator for total breast reconstruction. This is a patient who was a reoperative case who had extensive DCIS. So we had to reoperate. That is the flap planning. This is the TDAP perforator localization. So that is post skin and nipple sparing mastectomy. The specimen showing you the DCIS part covered in that. That is a flap planning, and that is on table. Once we have divided all the attachments, then we see whether the perforator is still intact or not. That is there. So that is a pedicle. insert. There's another flap involved over here that I'm not mentioning, but that is on-table aesthetics. That is early. The patient has some got a hematoma that's been drained. There's an operative video I'll show you. So before you start, you always define the breast footprint so that you know what is the volume deficit, where your incisions are to be placed. We have marked out all the perforators which are there so that if required, they may be utilized. It has been speeded up, so it will be done within 5 minutes. This patient has a central breast lesion, so we are marking it out so that we can excise that as part of the lumpectomy. Methylene blue is what I use commonly. Certain cases I do use ICG. You incise the superior part for the sentinel lymph node dissection. The biopsy is done while taking care of the pedicle, the sentinel lymph node packet, and in this case it was mentioned as positive. This is actually, I think, 2 years old case. So in that case, we have gone ahead with the axillary dissection also. So that is lumpectomy in progress. So I'm palpating as I'm excising. That is the specimen. The dye marks out the orientation, but we shall put for the sutures also for orientation. That is a cavity shape that we send routinely, including the deeper part. 5 valves we are sending. So because we are going ahead with an axillary dissection in this case, we have to be very careful with preservation of the pedicle. Now that is a bit tricky, and it is not advisable if you have extracapsular extension, extensive nodal burden, it's not advisable. You will have to rely on other accessory pedicles or another flap like a TDAP flap. So that should be at the back of your mind also, and you should be ready with that also. So that is how we are dissecting out. In this case, they had told that the medial wall appears suspicious, although on histopathology it was all clear. So we revised it then and there. That is the pedicle after the axillary dissection. Intercostal brachial nerve is also visible. Cavity marker clips are placed before we start the reconstruction proper. So the lower border of the flap is incised. As you can see, I have revised the lower border to account for the increased volume loss that has taken place. So that is why we put the inferior margin, define the inferior margin later on. So I have encroached on the territory of the LICAP over there, lateral intercostal artery perforator. So therein you can see the LICAP vessel. There are 2 or 3 vessels. One of them will be larger. Here we are sacrificing that vessel because we have a bigger vessel to support that flap. But if required, a smaller flap volume can be very well supported by a LICAP also, but you have to be very careful with the dissection. Most cases I prefer an LTAP if it is there, because it is more robust and gives me more volume. So an access tunnel is created in front of the pectoralis major into the lumpectomy cavity. We are putting it in so that we can determine where to place the neoareola. That needs to be defined. The volume distribution of the tissue has to be assessed, and then you define where you want to have the areola on the flap. So that is what is being done in order to study. Here, if possible, you should have a table which is at least 80 to 90 degree head up, so that you can see how it appears when the patient will be upright. The trick here, when we insert the flap, is also to put it in a way that it doesn't remain in the upper parts of the breast. It has to fall down with the natural fall of the breast once the patient is upright. So that is de-epithelialization. You can do it in different ways. The cheapest way is, of course, a blade. You can use the scissors, but again, that makes it blunt. No, it's continuing. So de-epithelialization has been completed. The neoareola is ready. Now the flap is ready for insert. The trick I told you earlier is that how you place this flap, how you distribute the volume that is there is very important. Otherwise, you can have good volume inside, but the contour will not come. So you have to understand where do I put the anchoring stitches. Excess anchoring stitches are not required, just 1 or 2 will suffice. You should have the, once you have put them, have the patient upright and check whether it is adequate, proper placement is there or not. So I'm bringing the neoareola to the level of the surrounding skin. Subcutaneous followed by subcuticular stitches. So that is how we come to closer. I shall end the video at that, although I do have time. Okay, so take home messages. These are the most important part and I want you to listen to them very carefully. You have to understand the disease biology. Without understanding the disease biology, you must not treat a patient of breast cancer. Must not. You understand the disease biology, it is what it dictates to you that you do to the patient. You understand the biology, you plan out if I'm going for neoadjuvant, what kind of neoadjuvant. If it is showing you that it is not responding, should I change the regimen? Don't overlook the, ever overlook the disease biology. This is the most important point. Understand the patient. If a patient does not want breast conservation, after you have explained everything properly, again and again in multiple sessions, do not give that patient breast conservation. That patient will not be happy. If a patient wants it, you give it. You have to explain what you have, what you can offer to the best. Let the patient choose. Study the breast characteristics. Different shapes demand different approach. Breast composition is important because if in a glandular breast you can move the breast around much, you can play around rather, to put it literally, but in a fatty breast, you have to put in volume from additional places. That means you have taken a flap rather than move about the breast. Breast measurements are important, especially when you are going for reductions. So you have to learn a wide range of techniques so that you have backup. If one technique does not work or you need additional tissue in a particular case, you should be knowing how to take care of that. So individualize and apply the simplest one applicable to the patient. That will give you a happy patient. So thank you very much for the opportunity. I hope I have made justice to what has been done. Thank you.
Thank you so much. So now you move to a talk by Dr. Latendu Maharana. So he'll be talking on a role of bevacizumab in non-squamous metastatic NSCLC.
Very good morning to all of you. I'll be talking about the role of bevacizumab in non-squamous non-small cell lung cancer. Next slide, please. This one. So, this discussion will base it on we'll discuss it in two headings. First, we'll discuss about the role of bevacizumab in metastatic non-small cell lung cancer, which do not have a activating mutation. And second, we will discuss about those cases who have an activating EGFR mutation. So, first the rationale, like why bevacizumab is thought to be having a role in metastatic non-small cell lung cancer. As we know, angiotensin is an essential process of tumorigenesis, proliferation and metastasis. And many of the environmental factors and genes that are involved with tumorigenesis may increase the vascular endothelial growth factor, which ultimately will bind to the vascular endothelial growth factor receptor, and that ultimately will lead to survival, proliferation and migration of the endothelial cells and leading to angiogenesis. And like targeting tumor angiogenesis is thought to be like a therapeutic goal in many of the cancers, and is postulated to improve the survival in these patients. And in particularly in lung cancer, it is thought to be very important because like those lung cancer patients who are having microvessel density high or vascular endothelial growth factor level high, those have been seen to having poor prognosis in comparison to the patients who are having low vascular endothelial growth factor level or low microvessel density. So this ECOG 4599 trial, it tried to test this postulate hypothesis that whether bevacizumab is having any role along with chemotherapy in this setting. What it did, it randomized non-squamous non-small cell lung cancer patients, stage 3B and stage 4, to 2 arms. One arm received paclitaxel and carboplatin 6 cycles, and the other arm received paclicarba along with bevacizumab. And what it found, like the primary goal, overall survival was significantly higher in comparison to the paclitaxel carboplatin arm. And not just the overall survival, PFS as well as overall response were also found to be significantly better in bevacizumab arm, bevacizumab containing arm in comparison to the paclitaxel carboplatin only arm. So, and and in this trial, those patients who are young, less than 65 years, with good performance status, PS ECOG performance status 0, found to derive maximum benefit out of bevacizumab addition to the chemotherapy backbone. So this is another real-world retrospective cohort study taking patients from the SOR database, and it also compared whether it also tried to find out whether addition of bevacizumab had any survival benefit in comparison to the chemotherapy only. So it also found that addition of bevacizumab resulted in longer overall survival in comparison to chemotherapy paclitaxel carboplatin arm only. And this holds true for both the young patients as well as the elder patients, more than 75 years or less than 75 years. Both cohorts are actually deriving benefit out of addition of the bevacizumab. So that's how bevacizumab became came into the first line treatment along with chemotherapy in metastatic non-small cell lung cancer who did not have a activating mutation. And as we know, the Paramount study, it found that after chemotherapy induction, maintenance pemetrexed had PFS benefit in those persons who have responded to induction doublet with pemetrexed and carboplatin. Likewise, after bevacizumab came into picture in the first line induction along with chemotherapy, some studies tried to find out whether continuing bevacizumab beyond induction had any survival benefit to the patients. This is one study, ECOG 5508. It in this patients were patient given paclitaxel and carboplatin along with bevacizumab for 4-cycle induction chemotherapy, and then patients were randomized to either bevacizumab only maintenance or pemetrexed only maintenance or bevacizumab plus pemetrexed maintenance. And it found that in terms of overall survival, there was no survival difference, significant survival difference, whether patient received combination maintenance or a single agent maintenance with bevacizumab only or pemetrexed only. But there were significant difference in terms of progression-free survival in combination maintenance arm. Likewise, another study, COMPASS trial, it also tried to find out this same answer to the same question, but here chemotherapy backbone was PEM carbo instead of paclicarbo. So patient received PEM carbo plus bevacizumab 4-cycle, then maintenance PEM bev or bevacizumab only. And this study also found that there was no overall survival difference with maintenance PEM bevacizumab arm in comparison to bevacizumab only. So no significant overall difference of bev plus chemotherapy maintenance. So if we are planning to add bevacizumab in the maintenance after induction chemotherapy, in that situation, we know that there is no overall survival benefit, only PFS benefit is there. So we have to take into take into account other factors like potential cost and whether patient is tolerating it or not, or patient preference. All these things has to be taken into account when planning a combined bevacizumab plus chemotherapy maintenance after induction bevacizumab along with chemotherapy. So, this point break study, it tried to find out like which chemotherapy backbone is better, whether it is pemetrexed carboplatin or paclitaxel carboplatin. So, it randomized patient to bevacizumab plus PEM carbo followed by PEM bev maintenance, or pacli carbo plus bevacizumab followed by bevacizumab only maintenance. What it found that in terms of PFS, in maintenance population, that is those patients who received at least one cycle of maintenance, in those population, the PFS was significantly better in PEM carbo along with bevacizumab arm in comparison to the pacli carbo arm. But again, there was no overall survival difference between these two arms. And if you see this forest plot, we can see there is no significant difference between the response rate and usually those young patients and those patients who are young patients are deriving maximum benefit. Young and ECOG performance status 0 patients are deriving maximum benefit, if at all, in the PEM carbo arm in comparison to pacli carbo arm. So, while deciding on chemotherapy backbone, there is no difference in overall survival between pacli carbo or PEM carbo along with bevacizumab if you are planning. So, likewise, the bevacizumab came into the category 1 indication in the first line setting in non-small cell lung cancer patient who did not have a activating driver mutation. But in the present scenario of immuno-oncology, this Keynote 189 trial, what it found that addition of pembrolizumab with chemotherapy backbone is it had survival benefit irrespective of the PD-L1 status. So, after this Keynote 189 trial, pembrolizumab along with chemotherapy backbone became the preferred first line regimen irrespective of the PD-L1 status. So now the question is, does bevacizumab has any benefit in the present era of immuno-oncology? This question was answered in this IM Power 150 trial, and it tried to test the chemotherapy backbone along with bevacizumab along with immuno-oncology drug atezolizumab. So it randomized patients into 3 arms. One arm received PEM carbo, pacli carbo along with bevacizumab. One arm received pacli carbo along with atezolizumab, and third arm received both atezolizumab and bevacizumab along with chemotherapy backbone pacli carbo. What it found that ABCPM, that is atezolizumab and bevacizumab along with chemotherapy arm, had both PFS and overall survival benefit, which are statistically significant in comparison to bevacizumab and pacli carbo arm. So therefore, at present scenario, at present era, so it is the category 1 indication for those metastatic non-small cell lung cancer patients who do not have activating driver mutation. So NCCN also incorporates this regimen as a category 1 indication, that is bevacizumab along with atezolizumab along with chemotherapy backbone of paclitaxel and carboplatin irrespective of the PD-L1 status. If PD-L1 is more than 50%, again there is an option of IO only and IO plus IO, but irrespective of the PD-L1 status, we can give paclitaxel carboplatin chemotherapy backbone along with bevacizumab and your atezolizumab immuno-oncology drug in first line. So coming to our next question, does bevacizumab has any role to play in those non-small cell lung cancer which are having activating driver mutation, activating EGFR mutation? So this NEJ026 trial, it tried to answer this question, and it randomized patients into 2 arms. One arm received, this patient randomized patients with activating EGFR mutation, that is exon 19 deletion and exon 21 mutation, that is L580, 8588R mutation, and it randomized patient to 2 arms, that is one arm received alertinib only and other arm received alertinib plus bevacizumab. What it found that there was significant difference in terms of progression-free survival in the bevacizumab arm, that is addition of bevacizumab had significant PFS benefit in comparison to the alertinib arm only. But when overall survival is compared, there is no significant difference in overall survival in comparison to the alertinib arm only if you are adding bevacizumab. So, and if we do a subtype analysis in the overall survival statistics, we can see whatever benefit patient is deriving in terms of overall survival is actually more pronounced in those patients who are having exon 21L858R mutation. That you can see the hazard ratio is also better, and your p-value is also, both the p-value is not significant, but p-value is tends to be significant in those patients who are having exon 21L858R mutation in comparison to exon 19 deletion. So if at all patient is having any role to, if at all bevacizumab is having any role to play, it is more pronounced in exon 21 mutation rather than exon 19 mutation. So in another study, Beverly trial, it also tried to answer the same question, and in this study also there was significant PFS benefit in bevacizumab, in adding bevacizumab to alertinib arm in comparison to alertinib only arm, but there was no overall survival benefit in the bevacizumab arm. And but this is a very interesting forest plot, and we can see those patients who are never smokers, who are actually current smokers. Current smokers, they derive the maximum benefit of adding bevacizumab to the first line anti-EGFR TKI, that is alertinib. And these are all other studies which try to answer the same question, like addition of bevacizumab to the first line, to the first generation alertinib in this population, in this patients with activating EGFR mutation. And most of these studies found PFS benefit, but no OS benefit. So at present era, so is there any role of adding bevacizumab to alertinib? So we can say when third generation anti-EGFR agents like osimertinib is the treatment of choice, and it is associated with far better survival in comparison to first generation TKIs with bevacizumab. So if your patient is eligible for osimertinib, patient is patient can afford, patient is eligible for osimertinib, then probably osimertinib is the way to go. But those patients who are not eligible for osimertinib, whatever reason it may be for, those patients we can add bevacizumab to first generation TKIs in order to derive maximum benefit for those patients. But is there any role of adding bevacizumab to the third generation TKIs like osimertinib? These questions will be answered in this trial. These are ongoing trials of addition of bevacizumab to osimertinib. This question, whether bevacizumab is having any benefit of adding to osimertinib, these trials will answer these questions. So coming to the last part of my discussion, that is it is a very difficult subset of patients to treat. That is those patients which are having exon 20 insertion, and we know they don't do well with EGFR TKIs, and usually we prefer to treat them with chemotherapy. And NCCN also tells that these patients should be treated like those which are not having any activating EGFR mutation. So this is a Chinese trial that tried to find whether bevacizumab is having any benefit in those. There is median survival benefit of adding bevacizumab to the chemotherapy backbone in this subset of patients in this trial. And therefore, NCCN tells to treat them like those patients who are not having EGFR activating mutation, that is chemotherapy along with bevacizumab plus minus IO. So to concluding, metastatic non-small cell lung cancer without any driver mutation, yes, there is benefit with bevacizumab induction and maintenance, and we know that the few of the studies have found overall survival benefit, and in terms of maintenance is concerned, overall survival benefit could not be found, but if patient is fit, performance status is good, and patient is young, we can add bevacizumab to derive the maximum benefit out of it. And in terms of EGFR mutation, positive non-small cell lung cancer is concerned. Adding bevacizumab, it helps obviously in exon 20 mutation, and exon 21 mutation also, it can derive some, a patient can derive some survival benefit if patient is not a candidate for third generation TKIs like osimertinib. Thank you.
So thank you, Lord Andu. So can I make a statement and you have to say yes or no? So bevacizumab as an anti-VEGF lost its path in the lung cancer treatment. Probably got a new partner in EGFR space. Is that right?
Yes, sir. Like after the invent of the osimertinib, which is having overall survival of almost up to 36, 37 months. So, with the addition of bevacizumab to the first generation TKIs, we could not achieve that that degree of overall survival, that degree of benefit, we could not achieve. So therefore, bevacizumab actually lost its parts in the way when better TKIs with better CNS penetrance came into picture. But addition to the third generation TKI, that question has to be answered yet.
Thank you so much. So now we move to the last talk of fourth iOS. So after this talk, so we'll have the award ceremony, followed by, for any organization, any conference is valedictory. So there is already a lunch being served. Please don't go away without having lunch on a Sunday. And after that, who all are interested for the radiotherapy workshop, they can go to Apollo, or we can have a live display of the sessions here, so people can stay back also. Otherwise, people can go straight away to Apollo. So now we move to the last session by Dr. Sajida Begum. So she will be joining us virtually on behalf of Aspira Nutrition, and she will be talking on nutritional preconditioning. So you talk so much about keto diet, you so much talk about intermittent diet. So she is going to take over from now. So Dr. Sajida.
Good afternoon, everyone. Am I audible? Is my screen visible?
You can start.
Good afternoon, everyone. I am Dr. Sajida Begum. I am presenting Aspira Onco Nutrition. Here I am the Medical Affairs Manager. So I would like to thank you, everyone, for giving me this wonderful opportunity to present my work today. Next slide, please. Can you please present my slide from there? I'm not able to change my slides from here.
Is she facing problem or what?
Yes, I'm actually facing issue to change these slides.
So till the time is it ready? Okay.
Okay, I'm able to change now. Okay, so we were talking about how nutrition plays an important role in the quality of cancer patients. How will the slides would be changing? I'm not able to change the slides. Is somebody there to change the slides? Okay, so how this is important? So since cancer patients experience unintentional weight loss leading to the diagnosis of cancer, so emerging evidences have shown that around 20 to 25% of deaths, which are during the cancer treatment, before the cancer treatment, and after the cancer treatment, this can be prevented with the intervention of proper nutrition to the patients, which can definitely improve the overall quality of life and well-being. Also, several research papers have suggested that loss of lean body mass, like sarcopenia in patients in cancer, is an independent risk factor of poorer outcomes. So as the cause of the death in the developed world, cancer is one disease which is surpassed by cardiovascular disease. So globally, number of people with cancer is projected to double by 2030. Currently, more than 1 in 3 people will develop cancer in their living. Next slide, please. Request to change the slide, please. Hello. So in the year 2020, there has been estimation of new cancer cases, which is around 1.92 million cases, and around 6.09 lakhs cancer deaths has to occur. I would request to come on slide number 4. Hello. Thank you so much. Thank you so much for sharing this screen. So we have seen that in the year 2020, and there is expected that there would be a number of new cases, which would be around 1.92 million cases, and 6.09 lakhs cancer death has been estimated. So cancer is a major public health problem worldwide, and this is the second leading cause of death in the US. Please change the slide. Next slide, please. So the number of new cases in 2020, we have seen that the breast cancer has been the maximum one, which is around 11.7%, followed by lung cancer, colorectal cancer, prostate cancer, and NMSCA, and other cancers like stomach, liver, cervix, uteri cancers. So number of deaths in 2022, which includes also both the sexes in all ages, So maximum number of deaths which is seen in lung cancer cases, which is around 18% cases, which is followed by colorectal, liver and stomach cancer, followed by breast, esophagus and pancreas and prostate and other cancers. Next slide, please. So since how cancer and nutrition is interrelated. Now metabolic and the physiological alterations, they affect the nutritional status and changes the nutrition needs even before anti-cancer therapy. Anorexia, early satiety, taste and smell changes and GIT disturbances. This leads to inadequate nutrient intake in the patients and thus causing malnutrition. Now this malnutrition influences the metabolism, the pharmacokinetics and healing dynamics. Highest prevalence of malnutrition is seen with 30 to 50% of hospitalized cancer patients. Next slide, please. Next slide, please. Okay. Now we will talk about the metabolic reprogramming in cancer cells compared to the normal cells. Now, some of the most striking changes of the tumor cells, the bioenergetics, this includes the elevation of glycolysis, increase in glutaminolytic flux, then upregulation of the amino acid synthesis and the lipid metabolism, then enhancement of the mitochondrial biogenesis, induction of the pentose phosphate pathway and the macromolecule biosynthesis. So compared to the normal cells, the cancer cells, they prefer using glycolysis even in normoxing condition as well. So this phenomenon is known as the Warburg effect. Now in normal cells, this glycolysis is prioritized only when oxygen supply is limited. In contrast, the cancer cells preferentially use glycolysis even in the abundance of oxygen. So this is why the tumor glycolysis is often called aerobic glycolysis or the Warburg effect, to distinguish from the normal anaerobic glycolysis as compared with the normal cells or the healthy cells, which we say in layman language. Next slide, please. Now, why is nutrition during cancer treatment is important? Now, nutritional deficiencies, this often contribute to fatigue and reduce the quality of life of the cancer patients during the treatment. Now, this adequate nutritional intake is important for maintaining energy levels, muscle mass, and a healthy weight during and after treatment. Now, in turn, this will improve the treatment tolerance, improve the quality of life of the patients, and reduce the risk of adverse effects in cancer patients. Hence, proper nutrition during the treatment supports the immune system, which may lower the risk of infection, help healing, and recover faster. Next slide, please. Now, how is malnutrition associated with cancer? As per the previous slides, which we have already talked about, now I'll talk in a very simple, simple terminologies, like what basically malnutrition we mean. So this is a very common problem which we see among the patients with cancer affecting up, which is about 85% of the cancer patients. Now, in severe cases, this malnutrition can progress to cachexia, which means a loss of lean body mass, loss of skeletal mass, muscle wasting, and which impairs the immune system, the physical and the mental function is also compromised. So cancer cachexia is also associated with poor response to therapy, increase the susceptibility to treatment related adverse events, as well as it results in poor outcome. The treatment outcome is compromised, and hence the quality of life is also compromised. Now, early intervention with nutritional supplementation has been shown to halt the malnutrition, and this will improve the outcome of the cancer patients. Next slide, please. Now, how malnutrition impacts the cancer patient? First of all, it is related with immunocompetence, which leads to decreased cell-mediated immunity, depressed this T-cell proliferation, NK cell cytotoxicity, and macrophage cytotoxicity. Inability to tolerate the antineoplastic treatments. Toxicities are more severe here. It results in treatment delays and hence leading to higher cost of treatment. We have also seen post-operative complications, like we can take example like wound infection. There would be delayed healing, hence compromising the quality of life of the patients and increase the treatment cost. Next slide, please. Now, what do we mean by nutrition preconditioning? So it has the potential to prevent short-term toxicities, improving the therapeutic efficacy and reducing the late life effects. Nutritional strategies have been shown to reduce the endogenous DNA damage levels and to boost the maintenance and resilience mechanism. So this protects the body from exogenous damages like chemotherapy, radiotherapy, and protective survival response prior to DNA damaging treatments. Nutritional preconditioning might prevent these toxicities in normal tissues. So probably to a lesser extent or not at all in the tumor, thereby alleviating the short and long-term side effects and the burden which is experienced by the cancer patients. Next slide, please. Next slide, please. So over the years, nutritional preconditioning has been used in cancer disease management. We have seen this in 4 stages like dietary restrictions or caloric restrictions, where the reduced calories by 20 to 40%. We have seen about in ketogenic diet, which is a high fat, low carbohydrate diet, around 70 to 80%, it has been seen that it has improved the condition of the cancer disease patient management. And short-term fasting, only water is given for a range of days here, and fasting mimicking diet, which is a low-calorie diet for a period of 5 to 6 days schedule, and which includes the plant-based and low-protein diet. Next slide, please. So we will talk about ketogenic diet as this plays a very important role during the chemotherapy and the radiotherapy treatments. So we have seen several studies. So this is one of the research paper from where I have taken this. So this study includes a very small number of patients, or when started with a larger cohort, experienced dropout during the study. So most trials has included the safety and feasibility of ketogenic diet. Consensus, this seems to be feasible and safe in patients with different types of cancer. So this combined results suggested that a ketogenic diet for a maximum of 5 to 6 weeks, consisting of a ratio of fat to other macronutrients of less than 4.1%, 4:1, is most promising as a feasible intervention. Next slide, please. So this is the metabolic pathway of ketogenic diet. So when glucose is scarce, the body seems to form of energy for the cells. So the liver then produces the ketones and the fatty acids, which provide to normal cells, but they do not benefit the cancer cells. They benefit only the normal cells. So this is due to the cancer cells become heavily dependent on ATP coming from the less efficient process of glycolysis. So these diets, they slow the cancer by inhibiting insulin and downstream the intracellular signaling pathways such as phosphoinositide 3 kinase or protein kinase B or mammalian target of rapamycin. So ketogenic diets also amplify the adenosine monophosphate activated protein kinase, which inhibits the aerobic glycolysis and suppresses the tumor proliferation, invasion, and migration. So we have seen that mouse models of metastatic cancer shows that exogenous ketones themselves have direct cytotoxic effect on tumor viability. So 5-beta hydroxybutyrate can modify the chromatin by binding to and thereby inhibiting the histone deacetylase, ultimately repressing transcription and curbing the cancer cell proliferation. Next slide, please. So when the availability of nutrients is reduced, cancer cells cannot easily adapt, in contrast to normal cells. So which may render them more vulnerable to damaging agents, a condition termed differential stress sensitization. So tumor cells that have difficulties in adapting to nutritional preconditioning conditions and normal cells that go into defense mode and can already result in tumor shrinkage by the nutritional preconditioning regimen. Next slide, please. So we will talk about how amino acids, this plays an important role and they starve the cancer cells to death. So this pathway talks about commonly import of amino acids from the bloodstream. Amino acids is deprived and micropinocytosis this contribute to internal amino acid pool. So these are used for energy production macromolecular biosynthesis like the proteins, nucleic acids, lipids, and glutathione, and methylation processes. So this tight balance between the amino acid uptake, biosynthesis, and catabolism is controlled by mammalian target of rapamycin complex 1 and general control non-depressible 2. This MTORC1 facilitates amino acid metabolism in response to amino acid availability. So this includes a global shutdown of the translation, bringing cells into quiescence and in order to able to survive the nutrient shortage. So if these stress conditions persist, apoptosis is induced. So to fulfill the enhanced demand for amino acids, cancer cells often upregulate amino acid homeostasis and metabolism. So here in the picture, you can see these are marked with red, and this involves mutations in commonly mutated cancer genes, but also these genes directly implicated within the pathways of amino acid homeostasis and metabolism. Next slide, please. So what is the goal of this nutritional therapy? So we prevent or resolve the nutritional deficiencies, preserve the lean body mass of the cancer patients, help patients to better tolerate treatment, minimize nutrition-related side effects and complication, maintain strength and their energy, protect immune function and decrease the rush of infection, aid in recovery and healing, hence maximizing the quality of life of the cancer patients. Next slide, please. Please enter. Next slide. Now, what the studies suggest? Malnutrition is not only about not being able to get nutrition, but it is also about taking the right nutrition. For example, if a person is getting food and this is diabetes, cancer, or all these diabetes, cancer, or all diseases crop up because there is no sufficient amount of nutrition. So nutritional therapy cannot cure cancer, but can bring the optimal outcome of the drugs, which has been used to treat cancer. Different types of cancer needs different nutritional interventions, like nutritional preconditioning, which means the body is gearing up chemotherapy. Next slide, please. Now, most of the cancer patients are coming out at later stage, and a significant number of cancer-related deaths happen because of malnutrition. So unintentional weight loss, often combined with progressive skeletal muscle atrophy, is commonly reported during chemotherapy or radiotherapy treatment. So during active cancer treatment, maintaining the caloric balance is the most important nutritional goal. The need for caloric intake is usually increased during cancer treatment. There has been loss of lean body mass, digestive difficulties, and fatigue are usually temporary but sometimes persist. So especially in India, complementary cancer therapy can bring the optimal outcome of the drugs which has been used to treat cancer. So during cancer treatment, all the chemotherapy agents that are cytotoxic kill the cancer cells as well as the normal cells, thus the patient becomes weak. So if the patient is provided with correct nutrition, this makes the patient more stronger. It will reach the normal cells as well as the cancer cells or tumor cells, but within the period of time, it will help to proliferate the normal cells. So our EON formula is to give the nutrient to the cancer patient, and that nutrients that do not benefit the cancer cells, but only the normal cells. So that's how cancer cells are starved and they are weakened. Hence, we have seen that it gives the adjuvant therapy with the chemotherapy and radiotherapy during the whole cancer treatment. Thank you. Next slide, please. Thank you. Thank you, everyone.
Thank you, Dr. Sajida. So we talk about losing weight during treatment, and that has an impact on the survival. So there are a few patients who are going to gain weight. So because of chemotherapy, because of hormonal disturbance during the treatment of cancer. So what is your take on that? So does it also have a survival impact like losing weight?
Sir, actually, we have seen not all the cancer patients are being given EON therapy, but the patients with lung cancer, if you see, or head and neck cancers, if we talk about, we have seen that these patients are suffering from cachexia mostly, and they are malnourished. So due to some patients get a high amount of stress as well as their physical life is compromised, their family relationship gets compromised, they don't take the ample amount of diet. So they are not able to focus, and and we have also seen that loss of appetite happens in this number of patients. So in that reason we give this ion therapy. So
Thank you so much. So now we move to the quiz. Siddharth, please get him. So everybody appreciated the Kolkata tea, and thanks to that gentleman. So big clap for them. आइए. हमारे तरफ से. Thank you so much. धन्यवाद. So now, I can call upon Sri Gopal, Amit, Prakash, Ganesh, so who are all the judges and prepared. So please, yeah. कहाँ है? क्या नेला पेपर टाइट? Please come over the stage. So ultimately we had 8 quiz groups, and after the first round, so 5 were selected for the finals today. So the first prize is a 15,000 cash, second is 10,000, and third is 5,000. So we'll start from the third. So it's Sam Hospital, Dr. Santosh and Dr. Sushil. So big clap. Thank you. Thank you, Santosh, Sushil. Second prize. Rudra, come over the stage. But you are not the winner. So second is from the Acharya Harrier, Dr. Manas Ranjan Senapati and Abhishek Sadangi. So big clap for them. अब चलते हैं पहली पदाम पर. So 15,000 cash. Winners are from the Sam Hospital, Abhishek and Antara. Sigopal. Thank you so much, our judges, quiz masters. There have been a great effort. So you can see a multi-talented girl. So Antara, she sang so well yesterday. Please stay back, stay back. And today you can see she is also a winner. So now we move to the posters, e-posters, oral presentations. So lots of efforts by Dr. Sri Gopal, who is a new entrant DM medical oncologist coming back to home. So a big clap for Sri Gopal, Amit and Sudham, Ganesh and also Prakash. So we had 126 entries, and out of which could select 69 e-posters and 21 oral posters. Ganesh, please. Aja, dod ke, please. So among the e-posters, so from the judges, I could get that information that it was very tough to choose one. And it was Dr. Sumitra De of Bose Institute. So polyphenol rich fraction of Bergenia ligulata sensitizes colorectal and breast cancer with high specificity, a mechanistic insight. So congratulations, Sumita. So that was from a virtual. So she will be sent the mementos through a courier. Now coming to the oral presentations. The first was C.K. Kirtana from Rajiv Gandhi Institute of Technology. The presentation was deciphering atorside B mediated modulation of critical signaling pathways in hepatocellular cancers. So congratulations, Kirtana. Thank you so much. So that brings us to the validatory. So after this, so you can please proceed to the lunch. The lunch is being there. And we have come all the way to the end of 4th Indo Oncology Summit. So I understand that there have been a lacunae. So as a part of organization, I take sole responsibility with all my team members. So hopefully when we meet next, so we'll at least make over, close over all those loopholes we have created. That may not be intentional, but maybe it needs to be more matured. There are lots of informations, communications that have been lacking and that we understand, and that has costed us also because of giving us so much of effort in a scientific, but still we could not make it. So next time we should have a foolproof planning. If there is no foolproof planning, then we should not do such. So this meeting you have seen so many new faces starting from left, right and center. So right, so Dr. Romila, so I thought that is the best way to introduce her, and she has been really a fantastic host. So all big clap for her. And as I said, so many of our new colleagues have been introduced to this August gathering. And I thank Ranjan and his team, Saroj Babu and his team, and mainly Jyoti and Majumdar from the Padmaja people group. And everybody said the food part, the venue part. So venue and menu has been a 5-star, 5 out of 5 or 10 out of 10 you can say. So our chef is also in the back. So Mr. Sipu, all a big clap for our chef. So without their efforts, so I don't think that it would have been a, if I call it a success or a failure, so it is there. And really, and all those, my colleagues in the Healing Touch group, so who has always been a backbone. And to name a few, so they have been really super. So be it Siddharth, Shubhasish, Tushar, Biswarup, Satya. So there are n numbers. So I can, and you can see the girl. So Avilipsha, so she has been a strong, a lady going back at 10 o'clock at night. So that is the dedication. So we cannot take away those good part of certain people. So they have been associated, and so that's what matter at the end of the day. So you count blessings, you count good wishes of your colleagues. So that was a phenomenal journey, and all my dear students, So from whom I have been learning rather than they are learning from me, because the medical curriculum which was there 22 years back is totally different. We are in that cancer journey where things that the books are rewritten at this moment. So lots of things are happening. So before we end and meet next time, so stay safe, take care. So there is a viral flu everywhere. So with so much of close approximation in last 3 days, so everybody is going to get back the viral. So get immune. Thank you so much. So Romila, if you say something.
Thank you. Wish I could say something. I'm sorry for my bad throat. Thanking sir, thanking the organizers to having me here. It was a wonderful 3 days spent. Lot of knowledge, lot of interaction, knowing people. Thank you, sir. Thank you, Dr. Viswas. Over to you.
Thank you, everyone. And I think we had a very emotional valedictory session and address by the Honorable Organizing Secretary and the Master of Ceremony as well. I greet everyone for your support. This conference, I believe, is not a organizer-centric conference. It's also a participant and organizer-centric conference, because at certain times and point we have received maximum cooperation for everyone, from our industrial partners, from our speakers, faculties, organizing committee, everyone at times of need, everyone contributed their effort. And these type of activities and knowledge-centric activities is very much important, because we believe education should not be confounded within the walls of the campuses and colleges. So with this, with his leadership of Dr. Viswas sir, these type of activities are being done so that the current updates in the field of cancer sciences could be imparted to students, young researchers, so that we would make ourselves ready for the next generation with all modern technologies and know-hows. I wish everyone all the best, and thank you very much.
Any comments, Amit?
I don't think it's a failure by any means. I mean, this is a fantastic journey. I mean, for 3 days we learned a lot from you, sir, and from all the sessions. And only thing we can go from here is even we can attain further heights from the next year onwards. Yeah.
Sudham.
This is the 4th time, but I have attended. This is the first time such big, huge conference with many participants all over the country. Like poster presentation and paper presentation was from all over the country. And it was a really good thing to know different branches, not only from allopathy, homeopathy, nutritionist, everybody participated in a huge number. So it is a good start for this type of presentation all over the India. So I think the 5th will be more better than this one. Hope.
So for me, after coming back to my own state after 7 years of journey outside, it's really a pleasure for me to be a part of this conference. Special thanks to Ghanshyam sir and all organizers for giving this opportunity. And really, I feel very happy that we are organizing a conference in our own soil and state. We will definitely try harder in the next coming sessions and conferences to do it much better also. And I would thank Ghanshyam sir, and I can see everything is organized very well. All this credit goes to sir and Rudra and all other organizers. Thank you all for great participation.
Actually, my personal growth is much more here rather than conference point of view. I have been for a panelist for a judge. I became judge and speaker and all things I have done to this conference. So personal growth is much more. I have seen conferences all over India, but in Bhubaneswar like this, this conferences is a huge success. So everybody from all over India, I always take the feedback like sir. I was moving in and around. All people are actually happy. So things, my conference like should go on, and as per Rudra, the knowledge should not be focused on only campuses, and this should be shared and shared so that patients get the maximum benefits.
Thank you, Ganesh. So while I was busy for the conference, he is the man who took care of the patients at Spurs. So thank you. So I'll call upon these gentlemen, these ladies, so who has helped us during this conference, please. And Jyoti, so Jyoti is the man, so I know him for last 14 years. So Mr. Babu, please ask him, Mr. Babu. Please, Rudra.
Care units. The 10-bedded emergency and triage unit backed by dedicated intensive care units for brain stroke, cardiac and trauma cases makes the hospital first port of call in case of any emergency. Apollo Hospitals Bhubaneswar meets the demand for neonatology at a various level with 3-level NICU, which is equipped with advanced ventilators and other equipments. The hospital is a teaching institution too, being recognized for postgraduate courses and other various specialities. To meet the growing incidence of cancer, Apollo Hospital Bhubaneswar has also added another feather, the state-of-the-art Cancer Care Center within same premises. The Apollo Cancer Center has Odisha's first and the most advanced linear accelerated radiation machine, the variant TrueBeam STX, to offer the most precise radiation therapy treatment. The center also has a Siemens 64-slice PET CT machine and is equipped with all modern facilities to do every type of PET CT, including PET-guided biopsies. The center is in the front runner in providing organ-specific cancer care in the state of Odisha and has a multidisciplinary tumor board committee. Currently, all departments of oncology is running, including medical oncology, radiation oncology, surgical oncology, and nuclear medicine. It is a big part for Apollo to host this 4th Indo Oncology Summit, which was going from 11th to 13th, and we are glad to have you all. So I welcome you all on behalf of Apollo. Now I have to introduce a man who doesn't need any introduction. The man who is internationally renowned figure, and we are luckiest to get some time from learning from the pioneer who has not only taught various students, but also gave inspiration to lot like us. Professor Dilip Kumar Parida, sir. Currently, he is the professor and head of the Department of Radiation Oncology in All India Institute of Medical Sciences. Sir has bagged a lot of international accolades, and he has done a lot of professional training outside, like in Osaka University, Yonbeam Center, Japan, University of Mannheim, Germany, and lot of hospitals like ISRO Fellowship at Denmark, Ion Beam Center, Haigo, Japan, and lot many more, which is not able to be finished in this short span. Sir has a lot of interest in brachytherapy, total skin election radiation, stereotactic and conformal radiotherapy, radiation cell biology, and cancer genetic. Sir has a very eventful period also in Mumbai to 2008 and the terror attack. So sir has already been an inspiration to all, and we are very lucky to hear you, sir. So I'd like to welcome you, sir, on the stage today. He's going to introduce us to advanced radiotherapy techniques. Sir, please.
Sir, लाइट लाइट पूरा लाइट
Good afternoon. Thanks, Dr. Stiti and Sukuman. This is our home, so I don't know. We don't, in fact, need any kind of introduction like this. But anyway, as she told, actually, I always say, actually, I am having 360-degree kind of experience, professional, non-professional also. And the last introduction she gave me, I always actually say it proudly because nobody else will compete with me for that experience. That rest everything, everybody will try to compete, but not for the last one. So I am a proud possessor of the last one. But anyway, God is very kind, and so that we are actually meeting. And I think 2 days before I was in Delhi, I was talking to somebody. He was saying, why you are not coming to Mumbai? I told him, it may be a coincidence. After that, not a single time I have gone throughout the country, but not to Mumbai. So anyway, I am having the actually pleasant duty of starting the conference. So SRS is the focused one. So I will give you the 360-degree technical advances in radiation oncology, and then followed by Professor Senapati and the other dignitaries will take you to the focused workshop. So we have actually traveled from 1895-96 from the discovery of X-rays and radium to the linear accelerator, and as our previous doctors and speakers told, the most advanced linear accelerators. So for the students, we ask in the every examination, what is the difference between cobalt 60 machine and linear accelerator? But now the question is actually, what is the difference between linear accelerator and most advanced linear accelerator? So the path was not very smooth, but still we have continued the journey of development. And the 1-point agenda I tell students to pass the MD examinations, whether you are watching 100 movies in that period of 3 years or going to 500 picnics, does not matter. But if you are passing the examination and not passing the examination, that is the point. So what is the point in our radiation oncology? That is the how much dose we are giving and how much cells we are killing, the therapeutic ratio. So if you are killing the cells with less dose, we are producing less side effect. If we are killing the cells with more dose, it is our aim and objective to reduce the side effect, which actually the objective of the present today's workshop by doing SRS, large dose, that is actually extreme hypofractionation, SRS, large dose, single fraction. But the objective always remains how much cell we are killing. So anyway, the first journey actually, we are all taught from 2D era, the extreme right one. And right now, we are in the extreme left one. So this is again the scale. So started from the deep X-ray to protons and the most advanced this thing. So these are the actually individual advances you can see. The advances are not in a single field and not in the field of radiation oncology. It is a combination. So there are actually the individual ones, and This gentleman actually, the red revolution and innovation in IT. Without IT, these left-hand advances will be actually the sole advances in their own field. But the revolution in IT sector has integrated each and individual innovations to one, which has given us the advantage to do such kind of procedure like SRS and SDI. Suppose there would not have been actually innovation in the IT field, then again individually, like actually all doctors sitting in the individual clinics, seeing 20 patients, and each individual doctors combining the 20 patients data, it becomes a big data. So the credit goes to IT. So these are actually the, if we can, from 2D, 3D, 4D, what is 4D? 4D is the motion. If you track the motion, control the motion, and deliver the treatment adequately, optimally during that motion period, it becomes the best optimized kind of radiation. So these are the different procedures by which you can track the organ motion and deliver your radiation very safely only to the tumor, not to the other organs. So these are different procedures, how, and this is the example. Normal breathing, your heart comes, this is the breast planning, and the with ABC, you are saving your critical organs. So how this is actually, you track your breathing motions. So now the question comes, how? There is, I told you, there is immense development in the field of actually diagnostic radiation also, diagnostic radiology also. And when we acquire those images and combine to our treatment planning and guided through images, the delivery of radiation through images, that is called image guided, and image guided today is the best possible kind of conformal radiotherapy. Respiratory, I have already told, and these actually facilities are to the comfort and convenience of radiation oncologists when they plan particularly the conformal radiation. The latest is the surface guided radiotherapy, where actually the patient positioning and the internal movement tracking is done very precise. So this is surface guided radiation, where the patient surface is totally the coordinates enter into the machine, and the minimum imbalance and this thing positioning problems in the on the couch, that SCRT tracks it. So these are the different advances in our radiotherapy delivery technology. There are the technological improvement to the machines as well as the procedures. So this is the topic of today's workshop, stereotactic, and as I told you, stereotactic radiotherapy is the most extreme hypofractionation kind of radiotherapy, single dose, highest dose, and single dose, for which the immobilization becomes actually very important. If the patient is not properly positioned, patient is not immobilized properly, any kind of actually little movement produces more side effect than the effect. So when we are discussing about actually the conformal and the extreme conformal radiotherapy like SBRT and SRS and SRT, then the immobilization patient position becomes extreme importance. So until unless you are having actually very specific kind of patient immobilization and patient positioning is very strict this thing. So you should not actually try to go into the SRS and SVRT kind of technique. So proton beam, though actually it has become very common outside of India, but still I am happy at least now I think there are already 3 installations and Apollo is the number 1 pioneer in this proton filters. Plus radiotherapy is also there, but I think in our country we have not started yet. But technologies is okay, but in our country the dichotomy is we get patients with all advanced kind of disease. So in the morning we were discussing with Srivastava also. Patient selection and the use of technology is the dichotomy in our country still. So we have to see a balance between this thing. The MR Linac is also a recent one, and for treating soft tissue tumor inside, the MR Linac is the better one than the simple Linac. This is intraoperative one. So inside OT also, after once the surgeon takes out, we can deliver radiotherapy very precisely to the tumor bed with electrons. Now coming to the imaging facility, the PET has actually made our life much more better because we see the functionality of the tumor. Once we decide and see the functionality of the tumor, then we can target the tumor cell in a better way. So these days, for any kind of conformal radiotherapy, we fuse the CT, MR, and PET to get the best possible optimization. Now we are moving more towards the biological side. Mostly technology actually is having its own curve. So now I think we have attained almost the peak of the technological development in other areas. And when the technology peak and attain a plateau, the biological cell biology is the only way to proceed further. Artificial intelligence is the future. So now we are actually talking about the machine and form of radiation. So MR guided image brachytherapy we can do now, and we can practice integrated brachytherapy unit also. And see, as I told you, actually technology has already peaked and going to be plateaued. This is again our future. So right now we want to see, already we have entered the molecular this thing in so many tumors like brain, uterus, this lungs. That's why the immunomodulators have come, immunotherapy, and for our radiation oncology students and this thing, so radiomics and radiogenomics. Which actually try to target the non-DNA related. Actually, radiation is known to cause cell kill by damaging DNA, but there are also non-DNA kind of cell kill. So the research is into this field, how we can increase that also to take care of the hypoxic component of the tumor. I'm also confused, you will also be confused. So future, nobody knows where which direction to go and where we will reach. So basically the many of our treatment protocols are market driven and technology driven. Radiotherapy हम लोग बोलते हैं कि इंस्टीट्यूट का हाथी है, and the maximum invested department, and this will be a scare for Mr. Swift also, because right now, previously actually whatever actually doctors were saying, patients were believing. But next 5 years, patients will say
doctor has to deliver. Patient will come to the doctor, doctor, do you have this facility or not? Finished. So I think, stop here. So thanks again, Dr. Sthiti and Sushma. So with this, I stop and let the workshop continue. Thank you.
I don't know what the last question. Thank you, sir. It was such an informative session. So I would beg you everyone to round applause for sir. I hope he is clear, so there is no question for you, sir. Now I request...
They can ask.
Any questions? No, sir, they're clear. Now I request our respective CEO and DMS, Dr. Alok Srivastava, sir, to felicitate our chief speaker today. Thank you, sir. Next, I would like to invite very famous and eminent personality, Dr. Surendra Nath Senapati, Professor and Head of the Department of Radiation Oncology at Acharya Hariha Regional Cancer Center, Cuttack. He is an eminent radiation oncologist in Orissa and is also credited with many unique work in the field of radiation therapy. We are glad to have you, sir, here.
Doctor, you stand corrected. It's not just in Orissa, across country.
Yes, I said internationally renowned.
Thank you.
Start pointer touch. Either pointer touch, it will click. It is only this.
Thank you. So, at the outset, I'd like to thank Dr. Sthiti and also the team of Apollo Hospital, because as far as my knowledge goes, this is the first SRS meeting in our state. So, we all are proceeding towards the modern technology. So, this is the need of the hour in our state. I'm happy that Dr. Shankar is there, and I know him from very long period. And I think I will utilize his services in our state for further development. Just I was asking him, Dr. Shankar, can you tell me that whether the content inside the cranium, does it move? What is the opinion of the audience? Does it move or not? Because everything is contained in a cranial cavity. Does it move? How many are in favor of that? Yes, it moves. Please raise the hand. Majority is opinion that it usually don't move. I had also the same impression. But the cranial content also moves. And he is having a nice paper and he will also present on today. So, it is the need of our state that we are also equipped with so many techniques. And during my journey of last 30 years, as a chairman of Indian College of Radiation Oncology or as the secretary of the Indian College of Radiation Oncology for 8 years, we have tried to disseminate the knowledge among the young budding radiation oncologists. I know a lot of young budding radiation oncologists are here, and on whom we have to also give the response because they are our future torch bearers. And all the techniques, we can have the equipments, but how best we can utilize that equipments for more precision of radiotherapy. So, coming 6 years, I am in the field of ARI, because I am being elected as the president of Association of Radiation Oncology. So, hope Shankar will be with me, and also he will update my budding youngster radiation oncologist. So my topic, I have been assigned a topic that from frame-based to frameless radiosurgery. So what is this? When we discuss about thing, the stereotactic radiotherapy, two things comes to our mind. What we can apply? One, cranial, and another is extracranial. So the cranial mostly either if you are going for a single fraction, then this is SRS. And if we are going for the multiple fractionation, then it is SRT. Extracranial, the SBRT and SABR. I am not covering this thing. Now comes, what are the indications of SRS and SRT and SBRT? Because why I am covering, because a lot of youngsters are there. So the indications are cranial. Let us discuss the cranial one. The first one is AVM. Then comes the acoustic tumor. Then comes the meningioma. Then comes the pituitary adenoma, meningioma. Then trigeminal neuralgia, functional aspect, epilepsy, trigeminal neuralgia. Besides this, very important, it is the metastasis. Once upon a time, in so many forums, people criticize that if the patient will survive for 3 months, why are you going for the SRS, SRT? And patient has to spend so much money. No, the science has changed. And it's not here, this is international report, and so I'll cover that. So there is an established role of metastasis. Besides this, the skull-based tumor, spinal metastasis, spinal hemangioma, as well as for the body, the non-small cell lung cancer, hepatocellular carcinoma, carcinoma of the pancreas, cholangiocarcinoma, and also the carcinoma of prostate. But if this is a situation, who are the candidate? The candidate, it should have a small target. It should have a, sorry. Yes, it should have a small target, sharply defined target. That should be accurate radiation delivery, high conformity, and the very important vital structure should be away from the target. I will just give you a model. Let us think that here either Dr. or Dr. Sthiti, Dr. Shankar, or Dr. Sthiti, or Dr. Sanjay, the young, the most dynamic radiation oncologist. See, the man behind the machine is very important. We can have so many armamentarium in our hand, but how best you can utilize this gun, that is important. So, if this is a 10-meter rifle gun, that is equivalent to a modern Linux. Then you can have the mass diameter here for precision, exact localization. So we can also consider it as the bone being city that is mounted on the machine. Then comes, yes, then comes the target. Our target is very precision. Sorry. So our target is very precise. Ideally, it should be less than or equal to 3 centimeters. So this is our target. Okay. Then comes, there is something, the target should be on the couch, and ideal situation for this SRSS is a support couch. But the target should be immobilized. It should be peace. See this young bird may fly. So we have to catch her. So that is something that is called play. We can also fix the target so that it cannot fly. Even also, the target is on the plant. It may also move. Because what I was talking about, does the intracranial content moves? Yes, it also moves. So for that we also give some margin. And for the SRS, ideally it is 1 millimeter. Okay? So if we are going 1 millimeter or more, and if we are going to higher, then there may be more chance of the radiation necrosis. But if this is a situation, if we have cut the bar in the frame, but beside that, how to localize the bar here? So there is also max grade growth on side. Because I went through the internet, I asked my son, sir, can you tell me what are the different parts of the 10 meter cycle? And he has given this picture to me. So this is the equivalent to our coordinate system. But the little modification, coordination system is around the target, but here it is on the message. So this is a philosophy of frame versus frameless. So my topic is on today that how best we can utilize this frame. Can we manage with the frame or without the frame? This is a picture we can see here. We can use the frame for the proper immobilization of the cranium so that there will be no miss of the target. Besides that, we also use some of the guiding devices, that is coordinate system, so that we can best deliver the radiation to the target. So this immobilization system may be either it is invasive one, it is called frame, and if it is non-invasive one, we usually talk the frameless. So our topic of concern today, whether it is frame or frameless. Now, what I was talking about the guiding system, that is it is a coordinate system where it is X, Y, and Z coordinate that guides us that how precisely we can hit the target. The X and the Y axis correspond to the lateral and frontal side of the frame, and Z axis to the craniocaudal direction. Now question is, first we will discuss about the frame. Frame helps us in defining the images in a coordinate system with the help of fiducial point, and there is accurate positioning of the patient at the time of treatment. So the frame may be either SRS frame, that is Lexel frame in gamma 9, or BRW frame in X9, or there may be relocatable frames, that is the GTC frame. So this is in a diagrammatic way. So this is the Cosman Robert Wells CRW frame, and this is Brown Robert Wells frame, and also this is GTC, Gill, Thomas and Cosman frame. And this is the Lexel stereotactic frame. So how it developed? Basically, what Dr. Dilip also highlighted, the technology, IT technology. The first frame, stereotactic frame, was developed in 1906. Subsequently, in 1937, Spiegel and Wysis, they developed the frame-based stereotaxy. Then, Lexel, he combined this frame with that of the radiotherapy. So that is his contribution. And subsequently, what happened, there is a lot of changes on the linear axis. Okay? And this is the man, the last lecture. It is his contribution, the first one, to combine stereotactic methodology with the radiation therapy. So this is the basic principles, and these are the different versions of gamma knife. But what is the drawback with the frame? This frame needs expertise by the neurosurgeon. It has to fix on the skull. It is inconvenience to the patient due to because it is a used frame, it has to fix to the skull or cranium. It needs to account prior cranial surgery during pin placement. Let us think that there is some bifrontal skull and there is operational there. So it's not possible to fix the frame there. There is slippage of the frame during the process. It also needs simulation, imaging, planning, QA, and treatment has to be completed on the same day. Because the patient has to be within the frame. We cannot take out the frame unless until we complete our surgical procedures. So the whole procedure has to be completed on the same day. And fractionated treatment is practically not possible because we are treating the whole procedure in one day. So if these are the drawbacks, and also there is some chances of bleeding and infection. So this is almost an invasive procedure. During the whole treatment procedure, from first step to the last step, stereotactic frame must remain on the patient's call because we have to complete the procedure. So can we shift ourselves from the from the frame to non-frame technology or frameless technology? Now a lot of developments have been made with the LINAC, like onboard imaging. Like onboard imaging and alternate fixation devices. Though it's not completely replace the frame, but there are some alternative options. That alternative fixation devices is not the complete replacement, again I will repeat. And the hexapod gauge. So this is the situation which helps us that can you move from the frame to frameless. So these are the different frameless devices. Now come to the sorry. Okay. Now let us come to the whether if we are using the frameless devices, does it match the that of the what we use on using the different frames? The clinical study that has been highlighted that this is with the pinpoint, and here the just read the mean interfunctional motion over all fractions with pinpoint was 0.62 and 0.45 respectively for the hyperfractional SRT and SRS. But in fact, as compared with the other technique like CRW frame, and GTC, orphic and uniframe. Just see, the mean interfractional motion were only 0.3 with the CRW. With GTC, it is 0.54, but with orphic it is 0.73 and uniframe it is 0.76. Definitely, it is the CRW is better or GTC better. But what we see, this is in acceptable range. So we can also consider of the frameless technology. And this is the comparison of the different moments like lateral moment. Two things that comes to the picture, that is translational displacement, and here the lateral, superior, inferior, and also anteroposterior. But if you see here, the frame was definitely superior than that of the frameless. But the deviation that we get are mostly in acceptable range. The other studies, can you think for the zero center margin mask process frame immobilization during gamma night? Usually they give 1 millimeter margin. But can you avoid the margin? So this is the report by the Kutek et al. And also Manish Mehta is also in this group. And here, what we can see, the outcome is comparable in both the groups, whether we give margin or give margin. So omitting a safety margin and thus PT margin, when we use the mask immobilization, if you are using a mask, we can also omit the 1 centimeter margin. So the other studies by the Green metal, they have highlighted, they have used the mask and also frame. And the center margin in mask, they have given 1 millimeter margin, and also frame, there is no margin. But if you see the local control rate, with mask, the 6 months local control rate is 100%, and 1 year it is around, yes, it is 92%. So there is no difference, and but if you are going for the frame, it is 92% and 1 year it is 80.9%. So there is no difference in local control. The other study by Werner also, there is no much difference in these two. So we can also omit the safety margin with the mass. The other study, single fraction frameless stereotactic radiation gamma knife icon for patient with brain metastasis, and it is time to abandon. And here, in this study by the Wagner et al., there is no significant difference in survival by immobilization method, whether it is frame or without frame. So, and also if you see the local control rate, there is no difference with the stereotactic frame versus without frame. So this is also two Indian study by Dr. Kataria, and in their opinion that both invasive frame-based SRS and non-invasive SRT showed error in terms of sub-millimeter, which is also acceptable. This is also another publication, and her conclusion was that the setup accuracy for frame-based SRS matches that of frameless SRS. With recent advances, we can also determine as well as the correct deviation in all 6 dimensions and select the frameless SRS. So this is also another study where a comparison of clinical and radiological outcome between frame-based and frameless stereotactic radiography for brain and metastasis. And here, the actual 6 months local failure rate was 7.2% in with the frame-based versus 12.6% in frameless. And also this is not statistically significant. And also the 12 months local failure rate was 13.5% versus 26.8%. This is also not statistically significant. So, with this evidence, we can also think, yes, we can switch over from the frame to frameless. So what is the advantage of the frame? Frame-based SRS advantage that workflow has little variance. Any lesion in cranial blood can be treated. Conscious sedation is possible, and also angiography is possible. But what is the drawback? Pain-related artifacts is a major issue. It's more invasive, and avoid pin site at prior craniotomy site. Conscious sedation cannot be discharged patient on same day. But what is the advantage of the frameless? It's pinless and also well tolerated. Ideal for repeat procedures. We can go for repeat procedures. High definition, faster imaging on use of multi-channel head coil. Suitable in case of bifrontal craniotomy, but no suitable pin location is feasible. Pre-planning can reduce overall treatment time on day of treatment and enhance planning quality. The disadvantage, not suitable for targets at extreme location. Not suitable for anxious or claustrophobic patient. Not suitable for patient with obese, large abdomen and large breast. No gamma available at the extreme region. So this is the accuracy that we can get with the invasive frame. The accuracy is almost less than 1 mm with the invasive, but with the non-invasive and the frameless, it's around 1.22. But our aim should be less than 1 millimeter. So this is the workflow of the frame versus frameless. So before I conclude, only point that we can compare that in frame the method is mostly invasive, but frameless it is non-invasive. Patient comfort, it is discomfort due to the pin fixation, but there is no discomfort with the frame. Sedation or anesthesia, yes, it is with the frame, but not in patient without frame. Prior cranial surgery, yes, we have to be taken into account, but usually not. Multiple sitting of treatment, usually not feasible with frame, but it is feasible with the frame. Risk or infection of bleeding, usually not. It usually with the brain, but not without brain. So man behind all these techniques mostly neurosurgeon and also radiation oncologist. But here mostly the radiation oncologist, but also we have to take the help of neurosurgeon. Interfraction error is less here and it is somehow more, but it is acceptable range. So this is only possible with the advancing technology like onboard imaging, extracorporeal, and also the image guidance. So this is in nutshell about the brain and families.
Thank you so much, sir.
Second topic.
Yes, sir. We'll move on to sir's next topic, which reads as evidence-based treatment protocol in stereotaxy.
So my next topic is that, see, we are all in learning stage. We are also developing our technology. Some lot of centers in our state are also going to start the SRS and also SRT. But I am just giving a glimpse that what is the evidence of the low schedule or protocol in different sites. So the different protocols in stereotaxy. Just I am skipping this slide, it is the repetition of the previous slide. But I will confine myself to the only cranial content, SRS and SRT. So the ideal situation for the SRS and SRT, the lesion should be less than 3 centimeter. And elopement area, what is the elopement area? So for the motor, it is primary motor cortex, premotor, or internal capsule or the motor tract. And sensory, it is primary, somatosensory. For the speech, it is Broca's area, and beside that also Wernicke's area, and arcuate fasciculus. Or memory, it is also hippocampus. So these are the elopement area. Tumor volume, SRS was not recommended for lesion, ideally, more than 4 centimeter. Proximity to the cranial nerve is very important, because the fractionated artery should be considered. So fractionated artery, okay. Fractionated radiotherapy should be considered when the lesion is adjacent to the cranial nerve 2 and 8, because they are more sensitive to radiation injury. SRS is avoided if the maximum dose delivered to the optic nerve exceeds 10 gray. So we can think of the fractionated radiotherapy there. The same thing indications of SRS and SRT. Just I am skipping this slide. I have already covered. Now we have to come to the few sites like APM. So in APM, what are the indications of RT? Small volume, it is less than or equal to 10 cubic centimeter, and large volume more than 10 cubic centimeter. The indications that if it is small lesion and lobar location, ideally we can, when it's accessible, can go for surgery. And if there is a residual lesion, then can go for repeat resection or can go for radiosurgery. But if it is deeply located, then that's a good case for the radiosurgery. Besides this, if there is large volume and local location, the options are either observation, embolization, or radiosurgery. And besides this, if it is a large volume and deep location, and that's an ideal case for the, we have to go for the radiosurgery. Besides that, the patient choice is also one of the important factors. This is the study by the Christopher, and according to his study, the obliteration rate with SRS is in a tune of around 80%. Okay? But the incidence of hemorrhage are only 6%. Total obliteration rate was around 78%. So this is the obliteration rate, it ranges from 50 to 60%. So for the ISRS practice guideline says that SRS is safe and efficacious treatment for grade 1 and grade 2 AVM. SRS may be preferred as primary therapy in grade 1 and 2 AVM with eloquent location and deep venous drainage or other unfavorable features. SRS may be preferred in grade 1 and 2 AVM following incomplete primary resection or patient with medical comorbidity. And what should be the dose? You will see the dose. The estimated probability of total obliteration rate are in a tune of 65 to 75% if we are delivering the dose of 15 grade. And if we are going to up to 18 grade, it is in a tune of 75 to 80%. And if it is 20 to 25 grade, it is in a tune of 85 to 90%. Sometimes what happens? Okay, right. Now we have to discuss the meningioma in two sides, cavernous sinus meningioma or the other sides. Just I am going a little louder. Any of the posters? Oh, it has been mentioned. So, do not get side. Okay, good. So, in case of cavernous sinus meningioma, what the ISRS guidelines said, the recommendation is like this, that SRS or SRP is recommended as primary or upfront treatment option for an asymptomatic or mildly symptomatic cavernous sinus meningioma. The recurrence rate is not appreciably different between primary or the adjuvant therapy for cavernous sinus meningioma. And if you see that at the time of when no residual tumor is observed, or only a small tumor lining of the dura of the cavernous sinus exists post-operatively, serial neuroimaging study is not unreasonable. Again, it is not unreasonable. At the time of recurrence or progression of the residual tumor, and SRS SRT should be considered in that situation. So, how much dose has to be given? In SRS, using single section, marginal doses of 11 to 16 grade offers a local tumor control rate of 90% or higher at 5 years of post-SRS period. Now this is about the non-cavernous sinus meningioma. And here the outcome is that the 10 years local control rate ranges from 71 to 100%. And 10 years progression-free survival ranges from 55 to 97%. And what is the precision dose? It ranges from the typically between 12 to 15 grade. So this is also the ISRS recommendation. And only important is that the single fraction of SRS with a dose of 12 to 15 grade appears to be sufficient to manage benign intracranial meningioma. A precision dose of at least 14 grade would be advisable. And the recommended level 3 is even also 3 if we are going for the fractionated SRT, then you can also think for a 25 grade in high fraction. Okay. Now comes, this is in nutshell, just I am skipping this slide to running short of time. So with the meningioma, the take home message is like this. The mean dose, it ranges from 16 to 24 grade, depending on the location, with more than 20 grade associated with higher rates of local control. Maximal dose for cavernous sinus meningioma is 11 to 16 grade, with doses more than 18 grade associated with unacceptable toxicity. Fractionated SRS with BD more than 50 grade may decrease toxicity rate per patient in a critical structure limit SRS dose. So 5.5 is the common protocol. Most SRS series report excellent local control with 10 years rate ranging from more than 90% for WHO grade 1 to more than 60% of the WHO grade 2 and grade 3. Now comes about the acoustic tumor. Okay. So, in decision making, very important key point that we have to take into consideration that when we can consider for the SRS in vestibular neuroma or the acoustic tumor, if the lesion is less than or equal to 1.5 centimeter, and if it's an aged person, and if that is a recurrent lesion. So these are the absolute indications that we can consider. So the algorithm, I think our subsequent speaker will cover this, so I am keeping this slide, but only thing that we should know what is the course grading. So this is the course grading. Okay. So one, it is intracanalular, two, outside the canalular, and just it has tossed the brainstem, and or it has already compressed the brainstem. Because the treatment policy also depends on that. And this is also the ISRS practice guideline, and what it said that the 5 years tumor control rate with gamma knife radial surgery with single fraction linear or fractionated stereotactic radial therapy are in a range of 81 to 100%. This single fraction radial surgery series, this is very important because women treat, but at that side a lot of vital structures are there. So the tumor marginal dose between 12 to 14 gray reveal 5 plus tumor control rate are in a tune of 90 to 99%. But here in preservation rate are 41 to 79%. Patient of preservation rate are 95 to 100%. And trigeminal preservation rate is 79 to 99%. So the dose protocol is very important in this side. And when we are going for single fraction, then we can think for 12 to 14 grade to the GT margin. But if we are going for hypofractional radiotherapy, then the different options are 5 into 5, or 3 into 10, or 4 into 10, or 6 into 3. But again, I think I just need to move on. Lung-committed pituitary adenoma. So here, the same as guideline, the 5 years random effect local control estimate after SRS was in a tune of 94 to 97%. The 10 years local control random effect estimate after SRS was 83%. So what the guideline says? The guideline says patient, those who are medically inoperable or acute resection can be considered for SRS as the primary definitive treatment. And the dose protocol, single fraction SRS preferred than that of the hyperfraction SRS. Sorry. A precision dose of 14 to 16 gray is recommended for patient treated in a definitive setting. A precision dose of 14 to 16 is recommended for patient with residual or recurrent lesion. So the take-home message here, SRS is preferred due to faster time to hormone normalization or to patient convenience. Fractionality if tumor is more than 3 cm or less than 3 to 5 mm from charisma due to a risk of visual repair. The dose for SRS is 15 gray for non-secretory tumor and 16 to 25 gray for the secretory tumor. And for the fractionated SRS, we can go for 21 gray in 3 fractions. So this is about the trigeminal neuralgia. And we can also consider that the success rate are in a tune of 70 to 100%, and here the dose is from 70 to 90 gray. So what the ISRS recommendation is that the single fraction radiosurgery is better than the hypofractional radiosurgery. The minimal effective dose is 70 gray. And anterior target as compared to posterior has higher brain needle rate on a long-term basis. Dr. Shantala will cover in detail, so I am just skipping this slide. The maximal effective dose is 90 gray. Beyond 90 gray, the efficacy rate remains similar, but with a higher complication rate. Brain metastasis, your student, this slide is very important because this is our bread and butter, very commonly also we come across. Yesterday also we were discussing that meeting. So, what is the guidelines say? The ASCO, ESMO, and also ASCO guideline. When to go for surgery? The indication that surgery in brain metastasis diagnose primary or large tumor with mass effect, then we can go for surgery. If surgery is considered, no consensus on type of resection, whether in piecemeal or angular. No recommendation for or against the laser interstitial thermal therapy. Now comes in asymptomatic brain metastasis. In asymptomatic brain metastasis, see if the patient is having symptomatic brain metastasis, we can consider for local therapy. But in asymptomatic brain metastasis, local therapy differ or delay until evidence of intracranial progression. Asymptomatic brain metastasis from EGFR mutant non-small cell lung cancer, we can go for osimertinib. So the where there is targeted therapy are available and patient is asymptomatic, just go. And we can consider for the targeted therapy. I think Saurabh will agree with me. Because earlier there was a fight among the no. We are very crazy to give the radiation. And the scope of SRS or the scope of SRS and for the radiotherapy. Radiotherapy should not be applied to asymptomatic brain metastasis when there is some systemic therapy available. Brain metastasis 1 to 4 and tumor less than 3 to 4 cm in diameter, we can consider SRS alone. Again I am repeating, because our aim was that is brain metastasis, go for immediate whole brain artery. So there we can go for the SRS alone as opposed to whole brain artery. 1 or 2 resected brain metastasis, SRS if surgical cavity is safely resected. More than 4 unresected and more than 2 resected brain metastasis, Carnosic perfusions more than 70. We can go for SRS for brain artery and SRS plus for brain artery. SRS preferred in patients with better prognosis or other systemic therapy that is active in CNS is available. Is there any role of radiation sensitizing agent? The answer is simply no. So this is the study. Is there any advantage of addition of temozolomide and elotinib? And what the study says that yes, the addition of temozolomide to whole brain artery plus SRS in non-small cell lung cancer patient with 1 to 3 brain metastasis did not improve survival and possibly had a deleterious effect. So don't add the temozolomide with that of the SRS. And how much dose that has to be delivered? The maximum tumor dimension and also maximum tolerated dose. If it is small region, then some of the dose is higher. If it is less than 20 millimeter, then we can go for 24 gray. 21 to 30 millimeter, we can go for 18 gray. 31 to 40 millimeter, we can go for 15 gray. And cavity radiation. Yes, there is established role of radiation to the cavity. So, what is the SRS consensus regarding brain metastasis? Single brain metastasis, SRS alone, if surgery is not required, whole brain artery is reserved for the salvage. 2 to 4 brain metastasis, SRS alone, if surgery is not required, whole brain artery is reserved for salvage. Larger lesion, more than 3 cm, surgical resection should be considered. If surgery is not offered, may consider SRS. There is emerging data, multi-session of this stage SRS as a more visible or favorable treatment options. So this is in nutshell the take-home message for the brain metastasis. Brain metastasis 1 to 4, tumor size less than 3 to 4 cm diameter, go for SRS alone if patient is symptomatic. Resected brain metastasis, SRS if surgical cavity is safely resected. 4 unresected or more than 2 resected brain metastasis, then you can go for the SRS plus whole brain artery. And SRS preferred in patients with better prognosis or where systemic therapy that is active in CNS is applicable. Dosing is performed for actinogen 9005 that I covered 25 gray, it is less than 2 cm. Then 2 to 3 cm 18 gray and 3 to 4 cm it is more than 15 gray. Just I am skipping this slide. And my take-home message here, the dose for the different sites, APM, added 15 to 25 gray. Acoustic neuroma, Go to cutting gray, it is single fraction. And if you are going for multifractional, it is 5 into 5. For meningioma, sorry, for pituitary adenoma, if it is functional, we can go for this 16 to 25 gray. Non-functional, we can go for 15 gray. Or we can go for 7 into 3. For meningioma, if it is cavernous sinus meningioma, go for 11 to 16 gray. Non-cavernous sinus, it is 16 to 24 gray. For the trigeminal neuralgia, we can go up to 70 to 90 gray. And for the metastasis, I can share the slides. Still can share the slides. I know when I am a student at your age, I am very interested how I can get the slides. Okay. Because whatever we hear, then we forget on the next day. So I request Siti to share the slides so that people remember Siti. And for the metastasis, if it is but we have to take the information from all the because that is our principle improve. So if it is less than 2 centimeter, we can go for 24 gray. 2 to 3 centimeter, it is 18 gray. And 3 to 4 centimeter, it is 15 gray. And this protocol is based on what is the evidence, APM, it is ISRS guideline, and send the dose protocol. So this is the different guidelines, and this is dose protocol for the different sites that commonly peptides in case of granular. Thank you. Thank you.
Thank you. That was a very loud round of applause for sir because it was very informative. Anyone have any questions? Yeah.
So, sir, I have a question for both you and Dr. Sandra. Is it not time to do away with this size criteria, where only one dimension 4 centimeter is seen, and move to volume criteria where we have integration of MRI, PET? So, we have to
Absolutely, because that is just ISRS guideline. But we always consider for the volume. Without volume, how we can carry back
volume cutoff? Which volume, like
So, Professor's talk really reminds me of the semi-final match which has happened recently in the T20. You know, the England guy comes, just the openers wrap up the entire stuff. I mean, Professor's talk is just really what all the radiation oncologists, budding radiation oncologists need to know about. Phenomenally presented evidence, and that is precisely what I have practiced over the last 2 decades. I have done nearly 3,400 radio surgeries for the last 2 decades, and what Sir told exactly is what I do. And of course, there is a lot of learning which has happened in the process, which I'll be showing in one of my slides. And as Dr. alluded to, volume is something which we are absolutely critical about. You know, 2 dimensions, we should never think about it. Because at times, you know, I'll be speaking on the volume part in my presentation, because that is where we actually err as radiation oncologists and increase the complication rates also. So what imaging nuances we need to keep in mind to ensure that the volume is rightly depicted is what will be the crux of the imaging part which I will discuss. So once you are done with that lecture, you will be much wiser.
So recently actually there was a patient who had HER2 positive metastatic breast cancer. So he has recurrence only in the brain. So initially surgery was done and then an SRS was done for that. Subsequently she has a recurrence within around 1.5 years, almost near the same site. So can we still go for SRS or no SRS?
So Doctor, very good question. In brain failure, whenever it happens, we need to keep in mind the brain mets velocity. So typically, when you say within one particular period, right? Let's say we have done the radio surgery today, and there has been a marginal failure. That is what you are alluding to, right? So if the patient has a marginal failure, which is symptomatic, say 1 year down the line, right, and there is only one MEX. So the brain MEX velocity is 1 by 1. Okay, now whenever the brain MEX velocity is more than 0.3, you 0.3 to 0.5, that's a clinically acceptable range between, then the breathing radiosurgery can be contemplated. Yes, we can definitely do it, provided the performance status is good, no extracranial disease, and in-brain failure, typically if the patient has 4 meds, say after 2 years, that's an ideal class scenario. And you're having, she's HER2 positive, and you have drugs which actually, the latest drugs which actually penetrate.
For this patient, what is recommended if at all SRS? Why I'm saying is that because he has been asked to take proton.
No, it's okay. Yeah, I mean, proton is a bigger debate. Not even debate, it doesn't stand because proton has its own disadvantage. See, whenever you hear about proton doctor, what happens is you only hear about bragg peak. Bragg peak is like sudden vertical drop of the dose fall. Now, the advantage you get with the bragg peak is offset by the lateral penumbra. Let's say if I'm dropping here perfectly, but on the sides, I don't drop perfectly. So if this lateral penumbra is close to the critical areas, mark my words, it's not a case for proton. And the evidence for proton is not really robust for reducing.
So I can say I also some of the
Anyone can manage.
I mean, I do not know. Why is this as the size increases, the dose reduces?
Yeah, that is very, that was a question which just stuck my brain 2 decades back. Why, I mean, sir will answer. Yeah. So whenever the volume increases, let's not speak about size, the volume increases, the problem is there is an adjacent critical area which is absolutely normal. You know, this, see, brain has mitotic cells, neurons are mitotic. They don't, what you get in your birth in uterus is the maximum. After that, you will have synaptic pruning, and therefore your neurons actually decrease. So in brain, there are around 84 billion neurons, and non-neuron cells are another 84 billion. So total there are around 170 billion neurons or the brain cells. Now, whenever you're speaking about radiosurgery or anything, you have to focus on the doses on the adjacent normal areas. It is not just on the tumor. Now, the beauty of radiosurgery, as doctor has already alluded to, professor has already alluded to, is you can get a heterogeneity in the tumor. Let's say this is the normal area and this is the tumor area. Now, the dose fall-off which gets with radiosurgery, keeping this mitotic cells within acceptable limits, it is really beautiful. Now, the thing is, we have to take care of this normal guys. If the volume keeps on increasing, the radiosurgery, the big issue is you can't use a single fraction, right? For a larger volume, you tend to fractionate it so that we respect this normal guy. And that's precisely is what was told by Professor, you know, that is a crux of this meeting, you know, how to choose your battles wisely and carefully. That is something which is dynamic, and I'm sure everyone will learn from that. You know, we keep making errors and we keep improvising. That's it. Thank you. Yeah.
The bar is 3 centimeter. Because surrounding area, that also we take 1 millimeter. But the incidence of radionecrosis, because we are more concerned about the radionecrosis. If we are giving it that volume with that amount of dose, the incidence of radionecrosis will be more. Because very beautiful slide that Dilip also highlighted, the second slide. It is the therapeutic outcome or therapeutic ratio. It is the tumor control probability versus the normal tissue complication. So a good radiation oncologist like we people here, so their therapeutic ratio is always more than 1. So that there is good tumor control probability and also less normal tissue toxicity. So it is not the armamentarium, it is the man behind the armamentarium who is responsible for the therapeutic ratio more than 1. Thank you.
Thank you very much, sir. Now I'd request our business head, Mr. Sukumar sir, to felicitate sir on behalf of Apollo family. Light. A round of applause for sir. Thank you, sir.
We can wrap up the rest of the conference because sir told whatever is needed in these slides, nothing else is pending. I think everything is good.
Now I would request our very own Mr. S. Rangasamy, who is the Senior Medical Physicist, RSO, Apollo Cancer Center, Bhubaneswar, to elaborate us on tools for intracranial radiosurgery basics.
Start with introduction.
Okay, good afternoon to everyone. And as Dr. Shankar said, almost Professor Senabe sir has covered almost everything, 50 to 60% of my topic, which I am going to discuss here. I was thinking that...
Final take-home message of every presentation is put there.
Yes. I was thinking that at the end of his first presentation, I thought, okay, at least some 50% is remaining for me to take it over. But at the end of the second one, I'm still hoping that something which I can discuss. The same repetitions will be there, and I will just quickly skip on those slides and mainly will focus on the treatment planning and evaluation and quality assurance, which is, yes. Yes. Yeah. Okay. Yeah, sure. Definitely agree with you, sir. Yeah, I have a previous experience with sir in Acharya area also. Like 4 or 5 years before, I was with Electromedical Systems. Then I went sir and worked with sir to build up that center there. It was a nice experience with working with you, sir. And also with Dr. Shankar, it was my long association with him from Electra era and also with Apollo, also now together working here. Yeah. Slides, right? Okay, and today's topic which I am going to discuss is the tools for the intracranial radiosurgery. The most of the things which we have already discussed here, the same thing which I am going to tell you. The history we have seen, Dr. Dilip has already covered it. And then the evolution of stereotactic frames. Yeah, right now we are seeing frameless frames and everything, and most of the people would not have an idea of seeing the old things which we had used in the history. And then available treatment delivery and modalities, and what are the primary and essential requirements in the stereotactic radiosurgery, and the criteria, treatment planning, and last, the dosimetry and summary. And in the history, the first SRS was done at 1940 by Lars Sexel with the ortho-voltage X-rays. The moment we say Lars Sexel, everyone is coming into mind as a gamma knife. But he hadn't done with the gamma knife first, he had done only with the ortho-voltage X-rays. Then later, with actually very good story with the cyclotrons, before going into gamma knife, and he had tried all his exercise with synchrocyclotron. What he has to do is, he will be fixing up his frame, and he had to run for one hour from his clinic to a cyclotron facility to deliver the treatment. At the time only he thought of, and in mind, the gamma knife ideas came in, and the cobalt-60 sources was employed and used in the in-house gamma knife systems. And later the X-rays have come into picture. Then first 3D treatment with the X-rays was done in 1948. And with this revolutionary introduction only, later the Lexellus combined the X-ray unit with three-dimensional radiotherapy in the year of 1950. And this is a famous quote which I just come across when I was preparing the slides. The stereotaxy technique, everyone, which right now we are talking about is, sorry, it's an century-old technique, and first it was in, yeah, sorry. Just, can you help me with this? Oh, okay. Yeah, no problem. Now I know. Sorry. Yeah, it is a year-old century which is done by the Horsley and Clark. The mainly he has done with the accurate insertion of the electrode in the given structure of the brain. The later, in 1950s, the Lexellus reinvented the same technique, and he has brought now into the narrow needle into the narrow beams, which we are talking right now for after this invention from 1951 to 2022. And this is the first frame, stereotaxic frame, which he had devised and used here, and so many revolutions has come up now. And the first one which you see in the picture is at 1918, the first stereotactic frame looks like this. And then after that, the second one, which is devised by the Lexell exclusive for the neurosurgical procedures. And the last one is, we have seen in the few more slides earlier as well, and this is what currently it's been practiced. And not this stereotactic frame, but the target localization. Still, we have not removed out of this target localization, which is in the stereotactic coordinates. And these are the pictures of some of the frames which we come across in the history. And this is a complete set of accessories which we are talking about in the stereotactic world. It's not only from the linear accelerator, which is on this side, and stereotactic cones also plays a vital role in terms of the functional SRS treatments, and also the frameless masks and the target localization box, which is very much significant, which comes into play of the treatment at the last. And then, as we discussed earlier, the entire procedure of the patient fixation to this one, it takes up about 3 hours, and the procedure for a particular day, and which has significantly changed after the introduction of the frameless radiosurgery here. And available treatment modalities, the machine which we have is the variant true beam at our hospital, which is having with the highly sophisticated HTMLC of 2.5 millimeter, which is a basic and primary one whenever we are doing with the linear accelerator. And then second one is another type of Linax with a cyber knife, which we can able to treat with the micro MLC as well as the cones, which has an added advantage. The same cones can also be incorporated into the Linax, which is recently we are doing it. And just a small knowledge actually here. As we are talking about the linear accelerator, and 20-30 years before, we have treating with the cones only the radiosurgeries. And then the introduction of the micro MLC, which has helped us to treat the various kind of intracranial tumors. And then now we are again going back into focus with using the stereotactic cones for the functional imaging, so functional treatment. And last but not the one, and the accuracy of the treatment, which is always a superior and gold standard treatment, it's in the gamma knife. And the cross-sectional diagram of the gamma knife with a very complicated solution, which is again started by the Lexell, and it had undergone a series of inventions. First it was looking at a football, and then later it has been revolutionized with a new cone beam CT, which is added over here. And in this, totally 201 sources are there. And previously, there's a gamma knife which had a different collimator with the different helmets, like a 4 millimeter, 2 millimeter, 5, 6. And in the single machine, they have incorporated all the collimators. And now, one single stretch, the different type of collimation can be achieved, and the treatment can be finished faster. And what are the primary requirements? The stereotactic frame. The stereotactic frame which I mean here is not the invasive frame. The frame which I am talking about here is the localization frame, which is very, very significant when we are talking about the millimeters of accuracy which is expected. And then imaging equipments, the center should have all the imaging equipments cited here, high resolution CT, MRI, and the DSA for the functional SRS. And the target localization software, which is also very much significant. And the treatment planning is also one of the important area where we will discuss about this. And then criteria, and we have seen in so many slides, and Dr. Senapati has also pointed out many criteria, and foremost criteria which is the multidisciplinary team of neurosurgeon, radiation oncologist, medical physicist, therapist, and radiologist is very much important. And everyone's role here is from the one to the last is very significant to attain the goal of the radiotherapy. And I will just keep these two informations, the planning targets and the dose we have seen in very detail. And the requirements, the last one is requirements for positional and numerical accuracy. And this looks very simple. What is a positional and numerical accuracy? The position means you say like we have fitted the frame and that is not going to move. But that's not the case. We will see in detail about that. And appropriate quality assurance systems. And what are the physical requirements for the radiosurgery? The accurate determination of the target and its localization with the stereotactic techniques. When I'm talking about this accurate determination, okay, I know all the doctors are going to draw accurately only, but it's not that one. How the software is going to give the accuracy. And that we have to do an end-to-end test, which we have to make sure that whether the delineation of the target in the MRI and DSA is properly coming into the CT for the treatment planning and delivery. And the calculation of 3D dose distributions inside and outside the target. This is a place where the treatment planning system plays a major role with advanced dose calculation algorithms like Monte Carlo and superposition convolution algorithms, which gives us enough freedom to plan, as Dr. Shankar said, the heterogeneity which we need to achieve to save the organ at risk outside of the target. And the calculation of the robust DVH, which is also one of the vital parameter. So that we can able to confine this, the dose distribution and confirm the target shape that we have already discussed. And not only that, and the direct superposition, there are many planning systems in earlier doesn't have the option like to superimpose the imaging doses to the supportive images to make sure that we are rightly delivering there. And now we have these additional things and which we are all following it here. And what are the clinical requirements? We have seen this information, the accurate knowledge. It doesn't mean that everyone is having a knowledge, but everyone will have the same knowledge who are all included in the process so that we can able to safely deliver the treatment. Accurate positional and delivery dose. Actually this topic we have already saw many slides like Sarah's rightly pointed out, hexapod couch and all these things which we had technical advancements in this year, which ultimately removed the stereotactic frames which we are using as an invasive procedure. And then the numerical accuracy of the dose distribution, this is where the point of the quality assurance were coming into the picture that we will see in detail. And then low dose to this. And the last one, only 2 or 3 more slides to go. Then evaluation, in previous days, how the stereotaxy plans were evaluated. Just by seeing this rapid dose follow-up is there, okay, and required 80% or 90% or 70% to some cases the dose coverage is there or not. But with the increase in advancement of the systems like revolution in the IT and all these things, now DVH have come into main play. And next one is the ratio of maximum target dose to the prescription dose. That's a rapid dose follow-up or gradient index measures which we follow here. And the ratio of prescription isodose volume to the target volume. Like a heterogeneity index and a homogeneity index also one of the crucial parameter when we are looking into the SRS and SRT or functional SRS treatments. And then plan trade-off. For a single side of the treatment, we can have many plans, but at the end of the day, like what is the plan which we are going to take it for the clinical treatment? It's again a clinical discussion with the radiation oncologist and the treatment planner to find out what is the best plan which we are going to deliver. Okay, I think that's all the thing which we are going to discuss and everything. The quality assurance is the one which is going to happen in the background of the system. And this is the foremost important. When Dr. Senapati sir has rightly pointed out how much margin we can take it. Like sir told 1 millimeter. Yes, that's the required one, but how far we are into it to consider only the 1 millimeter. It's not that 2 millimeter or 3 millimeter. That is the end-to-end test which we have to carry out and that's a physicist's job. They have to make sure that definitely we are delivering the right place with the 1 millimeter margin. And I just pointed out there are 3 types of QAs we have. One is the equipment specific QA, and another one is the procedure specific QA, and the last one we will see there. And this is a guideline which I have taken from the AAPM and the Radiosurgery Safety Society from the US. And they're clearly pointing out that daily, monthly, and annually. And this for me, it looks like what I'm doing daily here. And the laser have to be localized very well within a millimeter. And then colorimeter, we have to be checked very frequently if we are using the stereotactic cones. And then foremost important one is the radiation isosensor test. And this test, we used to do it a day before the treatment and also the day before the treatment, just before that, to make sure that we are able to mainly achieve this 1 millimeter for SRS and 1.5 for the SBRT, this one. And then IGRT and positioning, that is also going to play in the major role. And then exopod couch and 60 robotic couch, which plays a major thing. And as the technology is advancing, we have more things to scrutinize and make sure that our systems are in place and effectively working. And in addition to add, at the end of this, all the protocols, they add an end-to-end localization assessment. This end-to-end localization assessment is right from the simulation of the patient to the end of the delivery of the system. We have to make contouring and simulation, immobilization, contouring, treatment planning, and then delivery of the treatment. We have to have an end-to-end test and before starting off any radiosurgery procedure or any kind of stereotactic procedure. Second one is the patient-specific QA, and how do we achieve it? Really, can we able to do the patient-specific QA with devices which we are applicable? Right now, we are doing with the radiographcomic film. That is the gold standard, but not all the centers are having this one to do it. They have with the new technological advancement with the phantoms, which is have about 0.4 millimeter of film class resolution and 0 pixel spacing and no interpolation was there. And prior to this equipments, we are ideally using the most of the time the radiographic films, which is a gold standard and it's giving a very good accuracy when we are working on the heterogeneity kind of dose distribution. And then now there's just a picture of the diode chambers which we use for the point dose determination. And then the procedure specific QA, which I was talking earlier, the workflows to perform the stereotactic procedures as defined the SOP of the department, which is very, very significant. And staffing level with appropriate knowledge and staff training and continuous training available and appropriate. And a summary, it's a multidisciplinary team and right choice of the equipment is always necessary. And robust clinical workflow to be verified and implemented and continuous knowledge transfer to the staff and adapt the new technologies. Thank you. I think no questions. We are already late for the lunch.
Can I give a comment?
Yes, please.
Only a minute. So, students need to understand that whenever you're practicing radiosurgery, it's not just you who is integral. It is the team which is integral. The physics needs to be mentally prepared to start the program, and the technologists need to be mentally prepared to do that. When I returned from Pittsburgh and started the first radiosurgery case, no one was ready. Physics was not ready, the technology was not ready. So it's very important that you need to take everyone into confidence, sit with them, tell them what is it you are planning to do, and then take the floor. Otherwise, it's better not to start the program. The physics team and the technologists, you need to guide them. And you can guide them only if you attend conferences like this.
Yeah, thank you, sir. Rightly pointed out. And one more thing, like interfraction imaging, one of the imaging technique which we are talking about right now, but in early 2015 or 14, when it was launched, and Dr. Shankar is one of the early adapter, and he was given his valuable inputs to improve the things when we are for the SRS and SRS treatments. Earlier, before that, you just start the treatment and you fire some 2,000, 10,000 MUs, and then you're done. And what is going in between that one, that was not there. And once the facility has come up, I was working with sir to get the inputs and send it to the factory and research development team, and it has helped us a lot for the revolutionized technique. Thank you. Thank you, sir, for your words.
Thank you. It was very informative. I welcome Professor Dr. Vidhu Kalyan Mohanty, sir. He is amongst the gathering with us. So I extend you a warm welcome, sir. Now I request Mr. Sukumar, sir, to felicitate a very informative speaker, Mr. S. Rangasan. A round of applause, please. I know it's a little delay and we all are hungry, so we will take a break for lunch now. I welcome you all back again, post a short lunch break. Now, we have our ears to hear to Dr. Shankar Vangipuram, sir. He completed his master's degree in radiation oncology in 2000. From a very renowned medical college in Hyderabad, following which he did his neuro-oncology fellowship at a well-known hospital in Mumbai. With over 18 years post-MD experience, Dr. Shankar's area of specialization includes high-precision radiation therapy, total skin electron beam therapy for mycosis, then intracranial radiosurgery for benign intracranial tumors like pituitary adenomas, meningiomas. In terms of extracranial surgery, he specializes in lungs, liver, pancreas, spine, and prostate cancer. This is very interesting. The most attractive point is Dr. Shankar is credited for achieving a world record of completing the fastest surgery for trigeminal neuralgia in under 23 minutes. So big round of applause for you, sir. I'll give you the dice. Sir, please. Yes.
Thank you so very much, Dr. Pallavi. So let me just kickstart. How many students are there in this? I presume all had a good lunch, right? Be little. No one is hypoglycemic. That's it. That is what the spirit I really look for. Anyhow, without much ado, friends, what we will be discussing over the next 30 odd minutes is, we have learned wonderfully the evidence, what Professor Senapati has alluded to, but what here we will be focusing is how to achieve those goals, in the sense, how imaging is more important for us. So, what I will be discussing is the imaging basics, and in the context of various indications, how do we apply those particular imaging modalities, specifically so in benign, malignant, and functional indications. Can I have this light off, please? Yeah. So, this is the holy grail of radiation therapy. When I say holy grail, you can only imagine for it. We are not really sure whether we are going to achieve it or not. And that is the therapeutic ratio. Since morning, there has been so much that we have heard about therapeutic ratio. So when you say therapeutic ratio, friends, it's about increasing the tumor control while minimizing the toxicity, normal tissue complications. Now we should thank our physics and the engineering department. If this is what we are way back in 1940s, this is what we are today. We have actually closed a gap of century of paucity of evidence-based medicine practice, I would say. Now, when the technology has advanced so much, you need to understand what advantage it has given to us. The advantage it has given is we are able to decrease the margin. Now let's hypothetically say this is the volume which we are radiating. If I increase the radius from 1 millimeter to 2 millimeters, what happens to the margin? It increases by 8 times, and that is depositing on the normal tissue. So therefore, we need to understand that margin is the most important thing which we need to consider when we are shooting surgical doses of radiation. Since morning, as Professor Parida and Professor Senapati have alluded to, hexapod is something which we constantly keep listening, and that's what we practice. Now, many a times you need to understand when exactly hexapod is critical for us. Correcting the 6 dimensions is critical for us. If we are dealing with a spherical target, correcting isolated spherical target, don't worry about correcting the 6th dimension. Of course, if it is close to the critical, that's the point where I really worry about. If it is irregular, always apply 6 DOF corrections. And whenever you're treating multiple lesions, apply 6 DOF corrections. These are all the ground rules that every budding radiation oncologist should know. When exactly to use 6 DOF corrections and when not to use. Right. Now, to give you a bird's eye view about radiosurgery, there are 2 types. One is primary radiosurgery, where the classic findings are imaging based and the pathology is unknown. So whenever you're shooting a patient of acoustic schwannoma, meningioma, or whatever indication that we will be speaking in the next couple of hours, these findings are more imaging based, and that is primary SRS. Secondary SRS is all the post-op situation where we are aware of the pathology of the disease we are dealing with. Now, whenever you have a diagnostic dilemma, don't do radiosurgery. That is the most important thing everyone needs to know. We have all these indications across the benign, malignant, and functional, which we have been listening since morning. All these surgical doses that we are treating, the end point is to give a complication and to arrest the growth. This complication is supposed to arrest the growth. Now, when you are hitting with this endpoint, your system needs to be absolutely robust and precise. It needs to be accurate as well. It needs to give a steep dose gradient. And more importantly, the dose delivery system needs to be high dose. So to match this particular endpoints, there are several commercial platforms you see in the marketplace, ranging from Gamma Knife and Linac-based systems. Now, these are the platforms which we use to play the games of sub-millimeter accuracy. As Professor Senapati already alluded to, the goal of the precisions, what we are looking for, is sub-millimeter. You also need to keep in mind, it needs to be sub-degree. Beyond sub-millimeter, you need to have sub-degree precision. When I say degree, it is UVW axis, the roll, pitch, and yaw axis. Now, these tools have given us that flexibility to deliver single session close skull radiation with absolute confidence. Now, having said that, you need to understand that we are dealing with a chain of uncertainties. When you are dealing with radiosurgery, you have a lot of uncertainties. Now, that starts right from the imaging, target definition, target localization. I'm sure Rangaswamy already alluded to end-to-end testing is very important. That is for the delivery platforms. But more importantly, what we need to understand is the weakest link in the entire system is the target definition. That is where we actually fall short. That is the weakest link. And if you look into the existing evidence, the highest amount of uncertainty comes from target definition. The machine and all, it is very less. But target definition is the most important thing that we need to keep in mind. Now, we are radiation oncologists. We just bask on the surrogates, imaging surrogates. We are not surgeons. We are not seeing and doing it. We are basking on those images and PET, CT, whatever we use, we see in the discussions. Now, one tool has an advantage over others. What we'll be seeing in the next few minutes is which tool needs to be ideally selected when you're doing complex radiosurgeries. It is not just the MRI, but what sequences in MRI really matter to us. When should we integrate the angiographies in AVMs and all the stuff? So when we are looking into imaging in radiosurgery, it will be in the context of diagnosis, treatment planning, treatment verification, and of course clinical follow-up. So I'll be touching base on the respective indication and running you through all the things. Now, whenever you're speaking about imaging, there are three things which are very absolutely important. Number one is the spatial localization or the resolution. Number two is the temporal resolution. Number three is the geometric integrity of the registration, what we are speaking about, and the tissue contrast. So these four parameters need to be perfectly optimized when you're shooting surgical doses. Now, which tool needs to be integrated is what I have learned over the last 2 decades of my practice of radiosurgery. Now, having said that, we need to understand MRI is something which is commonly used for radiosurgery. Now, I realized, in fact, I stopped using 3 Tesla MRI for routine radiosurgical treatment. I'll give you the reasons why we don't use 3 Tesla. But having said that, we need to keep in mind that there are several things which radiation oncologists need, which diagnostic radiologists do not need. Now, one of the most important things is the zero spacing. We give zero spacing, thin slices, and all these images need to be corrected for distortions. In fact, whenever students go to the MR unit, please go check these things before you acquire your images, because that is where the real problem comes. So these things you need to keep in mind. Of course, bandwidth also is important, which I'll be explaining later. Now, many a times we hear about flat carbon couch in MR. Our MR unit doesn't have it. Now, you need to keep in mind that even flat carbon inserts which are put in MRI, they cause some signal noise. Now, this signal noise in the latest MRIs, which have multi-transmit technologies, that has been decreased. But we need to understand, if I just draw your attention to these images, this is how you see the noise. That is where the noise is actually built up. So the multi-transmit technologies have reduced it significantly, but not totally pressed it off. So what you're seeing is actually not the true image. You need to keep this in your mind when you are doing radiosurgery. The second important thing which all of you really need to know, and this is precisely the reason why I don't use 3 Tesla for radiosurgery applications, is intrinsic image distortions. Now, you can see these image distortions really affect the signal intensity of a given voxel. Now, when you're trying to register 2 image data sets, you will have problem if these distortions are not corrected. So, whenever the B0 is high, the magnetization is high, the distortions are high. So keep that in your mind. So don't just say, oh, 3 Tesla is there, wonderful system. Stop using 3 Tesla. You don't need 3 Tesla. There are only specific indications when we use 3 Tesla units, specifically in the context of neuroimaging. Now, we need to understand why this distortions happen. There are 2 types. One is because of geometric distortions, and the number 2 is patient-specific distortions. Now, this system-dependent distortions are due to B0, and they are more so high in the gradient sequences. So whenever you're acquiring SPGR, that's a common thing which we hear about, that's the gradient sequence. And there actually, if you're acquiring SPGR on 3 Tesla, your targets are 100% wrong. And the other important thing is we are using a shared MRI. It's not a dedicated MRI. And I'm sure physics has to highlight that part, which is doing the QA for the MR. That's more important. So that QA for MR is not done routinely in our clinics. So therefore, we need to be extra cautious when you're doing all these things. Because there was a very interesting study which was presented, which was published, where you see the GTV volume actually increased by almost 35 to 40% in a small sample of 28 patients. And that variations due to distortions you can see. See, whenever we are planning radiosurgery, how do you differ a good plan versus a bad plan? That's a very simple thing that all of us need to know. Number one is the intermediate dose pillage. The intermediate dose pillage is the most important differentiating factor. Because this intermediate dose pillage is happening right in the heart of the normal tissues. So if you want to say, okay, physics will give us 2-3 plans, you have to approve the best plan. Look into the intermediate dose pillage. Of course, low dose pillage is also very important. I have attended this year Astro, and there is a lot of discussion which is happening on low dose pillage, because that is where the immune potentiation happens, and there is enough evidence which is emerging for it. So intermediate dose pillage is absolutely very critical for us to understand why it is important. The third important part in MR, I wanted all the residents to go whenever you're going for MR, keep these things in your mind. Until and unless you start applying in your clinic, as Professor alluded to already, you will forget it tomorrow. These are the things even I do today also. Every day I go to MRI, I check, okay, this is done. Even if it is a protocol, just go counter check, because if the technician changes and they don't follow this protocol, our errors gets compounded. Now, bandwidth also is equally important, because it is essentially the range of frequencies which are actually represented in the images. Now, if the range of bandwidth is larger, what happens is you have higher number of frequencies per pixel, and that actually will cause some water fat shift, which is much more different. Now, this is very important for periventricular lesion in the context of brain. You need to keep this in your mind. So if you see, this is how just altering the range of bandwidth, you will have so much of alterations in the image quality. So you have to choose an optimum bandwidth. Typically, I choose around 64 bandwidth. That corresponds ideally with whatever we are doing in the clinic. Now, therefore, you need to insist repeatedly your physics. Whenever you're starting a radiosurgery program, do proper QA of the machine, because we are shooting dangerous doses of radiation, and these doses will give a lot of complications. Our imaging surrogates need to be powerful and robust. They are all vulnerable for errors. We say every time, oh, we have true beam, we have false beam, or XYZ beams, whatever beams. All said and done, the biggest problem is not with the beam. It is with the person who is shooting the beam. And that person needs to be aware with what is exactly need to be done, the QA part of this physics. So we need to repeatedly insist our physics team, please do this, please share the results to ensure that things are falling normal. Now, what I will be doing is, with this basics, flying you through the different indications and how do we apply this imaging into our practice. Now, it's very important we need to know the pros and cons of different imaging tools we have. All of us have heard about AVM, right? What AVM is, is just it's a bunch of blood vessels which you see between the artery and veins, and there are no intervening capillaries. Now, what happens if there are no capillaries? The pressure from the artery goes directly into the vein. So therefore, this particular bunch of blood vessels is more vulnerable for hemorrhage. Now, this is the basic problem. That is the reason, there are multiple reasons which are given for the pathogenesis. I don't want to discuss on that. But when you're speaking about hemorrhage, you need to keep in mind that there are few things which are absolutely important when you're discussing with the patient. Number one is the prior hemorrhage itself is very risky. Now, whenever the patient has bled once, is a big risk. Number two is a deep location, extensive deep venous drainage and associated aneurysm. These are the four important things. This will actually result in an annual hemorrhage rate of around 2.2 in an unruptured AVM, 2.2% per this thing. The ideal formula, what everyone, routinely if you sit in the clinic, it is 106 minus age of the patient. That will give you the hemorrhage risk which is there. Now, when you are having one risk factor, three things are absolutely important. Again, I am telling for the benefit of residents. It is the initial hemorrhage, the deep venous drainage, and the deep location. If we have no risk factor, then the bleeding risk is 1%. Two risk factors, it is 10 to 15. And if it is three risk factors, it is more than 30%. I say all the patients who come to us, they have high bleeding risk. As Professor Senapati already alluded to, there are only two indications which are important for radiosurgery in AVM. Number one is a deep location, and number two is eloquent location. Deep we do because the surgeons don't get the operative corridors to remove it. So therefore, they are very, and embolization also is very risky because these vessels are typically the end arteries. And when they are the end arteries, you will cause infarcts in that particular area. So embolization is not done in an eloquent location and deep location. So when you are speaking about eloquent location, let's say we are treating a motor strip, how do we identify the motor strip? If you are speaking about somatosensory area, visual cortex, exactly, all of us know the segment numbers of the brain and all. But having said that, you need to understand how do we map it on the patient. Now, before I start my discussion for AVM, two things are absolutely important. Number one is a spatial resolution, and number two is temporal resolution. Because as I said, a nidus as an artery, whenever you're speaking about AVM, you're speaking about artery, nidus, and the vein, venous drainage. So this temporal resolution is very important when you are speaking in the context of AVM radiation. That temporal resolution is the ability to accurately locate the structure or the events at a particular instant time. It's like time-stamped image you get. Simple like 4D CT or 4D MR or 4D PET, which we do, the image data set is time-stamped. So when you have a time-stamped image, you generate a MIP image, and then you will get the ITV. It is as simple as that. So when you say ITV, here you are able to get a clear demarcation of the feeding artery, of the draining vein, and the nidus. It is as simple as that. The concept is essentially same. The second one is a spatial resolution. Now you have a nidus. Where exactly in the brain it is sitting is what I am interested. And what is the indication? For me, every strip of small normal neurons, not for me, for every one of us, it matters a lot because that is where the success of the outcomes which we give are totally dependent. So if you look into the spatial resolution, I'm sure of all the available tools, MR is the best. You can at least say, okay, this is where the lesion is present. But if you look into the temporal resolution, MR is the worst. What we do in our clinic is just do a MR scan, top sequence, contrast enhance or anything, and then we do. The problem is when you're delineating the nidus, it is very important we localize the nidus properly, exclude the draining vein, get out the feeding artery. So it's equally important we need to understand how to integrate image data sets which have better spatial and temporal resolution. See, that is the goal of whatever treatments we do. For an unruptured AVM, typically it's a non-contrast scan as you see, which is very important. And for a ruptured AVM, of course with a hemorrhage as you can see, this patient has an intraventricular hemorrhage. and you do a DSA, you can see a corpus callosal genu AVM. Similarly, for an unruptured AVM, you can see some curvilinear hyperdense lesions here. And these curvilinear hyperdense lesions could be nidus. Could be nidus. There is no guarantee that it is going to be. So obviously, you need to do a DSA to know that. And the other important thing which we routinely do in our clinic is CT angiography. Now the problem with CT angiography, again, it gives us an idea about what we do, about the localization of the nidus. But again, as I said, the temporal resolution is not better. You have to see the draining veins properly. You have to see the feeding artery properly and nidus properly. So initially there were days when I used CT angiography, MR angiography and fused and did it. But later on I realized my mistake and started improvising my practice. What is really important to deliver good outcomes is not the knowledge about the evidence. It's the knowledge about how we do it in a way to get the results, what is needed, what could be easily delivered. In fact, if we address that particular part, we will have a greater knowledge. So we stopped using CT angiography for all the patients. What we use is time-resolved CT angiography. Now when you're doing time-resolved CT angiography, you are stamping your data set. And when you're, it's simple 4D CT concept what we are using. You have 10 bins, you single loop them, and then you get the MIP sequence or MINIP for the liver, that's what we use. But in the context of brain, CT angiography, 4D time resolved, it's really very good. And I would strongly, advise you to discuss it with your radiologist and start implementing this 4D angiography for all this. In fact, we apply this 4D CTA images for all our planning purposes. So we do 4D CTA whenever we are doing CT imaging. The second important is the conventional MRI. You know, all of us, the beauty of MR is it has wonderful spatial resolution. Now, when you are speaking about spatial resolution, it's precise anatomic location of the tumor. And the second important thing, it is very good tool to differentiate subacute chronic hemorrhages and the gliotic changes which happen adjacent. As I said earlier, 1.5, 3 Tesla, there is always a debate, you know, whenever a diagnostic radiologist is asked, please, 3 Tesla is much better because of better image quality, vessel delineation. But again, as I said, this is, if you deal with a high turbulence force, you know, whenever you're dealing with AVMs, specifically more if you have small AVMs, the turbulence inside the AVMs is very high. And therefore, that will result in some error in the saturation effects and error in the delineation of the nidus. So we need to keep all these things, and essentially we don't use 3 Tesla for any of our brain imaging. Only for follow-up I use 3 Tesla because we have 4D MRI scan in our 3 Tesla unit, and from which we get the flow metrics. So we extract the pre-treatment flow metrics, and post-radiosurgery we do the 4D MR of the entire AVM. So it gives us a better idea about how to put the gear in use. So when you are speaking about MR, typically you can find the AVM in the sulcus, you can find it in the gyrus, or you can find it in the sulcus and gyrus. The only thing which we need to understand for the benefit of the residents is when you're dealing with a sulcal AVM, it is typically pyramidal shaped. You can see here, it's more pyramidal in shape. But when you are dealing with a gyral AVM, it is more spherical, and whenever it expands inside the gyrus. And a mixed sulcogyral, you can see it's very diffuse. What you really need to understand is when you are acquiring MRI, many a times You might have heard, your seniors telling, take a TOF MRI. I mean, TOF MRI is good for visualization of small nidus, but again, we don't use TOF MRI that frequently. Of course, that's one of the imaging sequences that we acquire, but TOF sometimes misses the arteriovenous shunting. So you need to do what is called as ASL imaging. So all these are very important when you're trying to understand the underlying hemodynamic changes which are happening within the AVM. Sometimes we use a contrast-enhanced MRI as well. And when you are using this, you need to understand that contrast-enhanced MRI is specifically more used for slow AVMs, and that gives us a proper delineation. So we have all this information in our table. One is 4D CTA, next either TOF MRI or contrast-enhanced MRI. And of course, T2 sequence is a standard acquisition. And third is the angiography. Now, many a times, you are speaking about angiography, of course, you need to use it on a cath lab. Now, if you ask AVMs, the best, I would say, gold, not I would say, the literature is redundant, replete with the evidence that the gold standard imaging tool for AVM is angiography. It is DSA, digital subtraction angiography. Now, when you are speaking about DSA, there are two things which are important. One is biplane cath labs and single plane cath labs. I'm telling all this because all of you need to understand when you're starting a radiosurgery program, what are the things that you are supposed to look at first? That's more important. It's not about just seeing it somewhere and going and shooting it. That is absolutely dangerous because I have seen so many patients who have landed up with complications and, of course, complications of different nature just because, the tools which we have are not properly integrated. Now, having said that, if we integrate all these things properly, the chances that we make the errors are less. It's not totally zeroed out. So when you're using cath lab, you need to understand, use a biplane cath lab, not a single plane cath lab. What do you mean by biplane cath lab? It will have two sources and two detectors. So image acquisition will be faster and the spatial resolution is very good. And the third important thing is you can acquire it in 3D space. The problem with DSA, as you see, is it's just two orthogonal images. If you look into any gamma knife institution, what they practice, they just do a 2D DSA, orthogonal DSA, try to pull that. Now, that is not representative of the 3D image. The true 3D image has to be viewed like this, in different planes. So, therefore, the best way to integrate is to do rotational angiography. This is again cone beam CT. So, all our AVM patients, we do 3D rotational angiography for nidus delineation. Now, when you're doing rotational angiography, you need to understand, let me just pull out, this rotational angiography gives images, nidus delineation, which is just really beautiful. You can see how this extra strip, which is not needed, is actually not included. So all the patients of AVM, we have to insist on doing rotational angiography and not just do a 2D angiography. And this can be done on a biplane cath lab, which I'm sure your interventional radiologist will show you. Now you can see the blue one is a MR-defined image, and the red one is a rotational angiography defined image. Look at the differences in the volumes. And those extra unwanted area, it's actually the doses are getting deposited inside the normal tissue. Now, the third important thing that we need to keep in mind, we are treating brain. It has totally neurons and white tracks, gray matter and white matter. Now, when you are shooting surgical doses, you are damaging the white matter also. Now when you're damaging it, you need to understand the white matter tracks, though you can see them in T2 images little bit, you have to learn to integrate this diffusion tensor imaging, what you see, into our system. Now, when you are speaking about white matter, it's axons which are actually entering from the cortex of the cerebral hemispheres across, there are different types of, these are essentially the association fibers that we see. Now, when you do a DTI, everything is color-coded, red, green, and blue. When you say red, it is right to left. When it is blue, it is dorsoventral. And when it is green, it is anterior-posterior. Now, what we do is we acquire the DTI, fuse it here, and then you can actually look into it. So try to develop the habit of integrating this particular information also when you're doing. You have to practice this in your clinic. I would suggest this is what I do. I have done the mistakes and I have seen it. And my humble submission is, please try to integrate all these tools which are there available with us, and it will give us a great amount of confidence. And you can see, you should always try to look beyond the gray matter using DTI and different ways to do it. This is interestingly, one of the AVMs, as you see, very close to the arcuate fasciculus. What is arcuate fasciculus? Okay, anyhow, you have for the language, the motor area and the sensory area. Motor is Broca's and sensory is Wernicke's. Both these two are connected with arcuate fasciculus. Now, when you are depositing high doses of radiation, what happens? The arcuate fasciculus is disrupted and the patient will have global aphasia. Global aphasia. Therefore, whenever you are doing any radiosurgery which is deep-seated, you are very close to the arcuate fasciculus, try to develop the habit of protecting the arcuate fasciculus. So these DTI images are always mapped on the T2 flare sequences to get a better understanding of what we are doing. You can see this patient, how we actually protected the arcuate fasciculus, pre-treatment and post-treatment, how beautifully they respond. This is yet another patient where that yellow one, what you're seeing there, that is a Broca's area. That is the motor speech area. Now this is done by fMRI. So this is what is called as DTI-based radiosurgery or fMRI-based radiosurgery. Now when you're speaking about fMRI, you principally use it for all the eloquent areas. Why the surgeon is referring this patient to me? This is being referred because it's very close to the premotor area, and it's in the premotor area very close to the speech area. We know it's in the superior temporal gyrus anteriorly, but you need to define it properly. How do we define it? Through fMRI. Now the problem is, this Broca's is connected with my Wernicke's through arcuate fasciculus. How do I get those fibers? Through diffusion tensor imaging. So what you see here is a Broca unoptimized plan. What we did is we mapped this Broca area and then we optimize our radiation doses based on the Broca's area. Similarly, you can see here, I would like to draw your attention, this is the arcuate fasciculus, the small blue area. If that is not optimized, the patient, there is no advantage of saving the Broca's area because the connection is lost and the aphasia becomes global. The beauty of integrating this advanced neuroimaging tools is we are mitigating whatever complications we are speaking about. This was one of the patients, very close to the motor strip. That was pre-motor strip, this is motor strip. You can see with fMRI, we have delineated the hand area, mapped that particular area on the T2 flare, protected it from the high dose gradient. So integrating these tools are essentially very important. This is another case which was absolutely very shocking for me. I mean, these are the surprises you have when you start using, if a patient is referred to me like this, big sensory motor area, and they ask me to do, okay, radiosurgery. I said, just hold on. This is in the dominant lobe. I'll be roasting every critical area. We did fMRI, and look at the beauty. Every important eloquent area was swapped to the contralateral lobe. This is what is called as plasticity of the brain. And this brain plasticity, once you are sure that the eloquent areas are all swapped to the opposite side, you are absolutely confident you can go shoot and come. This is how you get confidence. And we are showing some of the examples where you have a lot of things. This was an 8-year-old kid with Weibben-Masson syndrome. Weibben-Masson is deep-seated AVMs, multiple AVMs. Here it was in the thalamic area. And you can see we have integrated the DTI for all this kid. Because these are all curable lesions. We can't keep any residual damage 10 years, 20 years down the line. See, something is going to happen, it's bound to happen, but at least let it not be iatrogenic, because we have those tools which will make us much wiser. Now, whenever you're dealing with spinal AVMs, we have treated a good series. In fact, I'm writing a paper on spinal AVMs, typically the glomus type 3. Now, you need to understand, these are all the lessons that I've learned. Whenever you're dealing any lesion which is in the cervical cord, always make sure we run a 4D MR scan on this. When you do 4D MR scan, you can see the small, subtle spinal cord motion. Professor, I told you, not only brain, even spine also shows motion. That is more important. Now, where it shows, it is along the cervical curvature and the lumbar curvature. Because the CSF flow velocity, when it is more changing. And we have written papers on that also. This is called the random cord motion. So when you're treating a patient of cervical AVM, spinal cord AVM, cervical cord, spinal cord AVM, you need to keep in mind that this motion also needs to be factored. Otherwise, the patients will have a lot of problems in the future. And this is pre-treatment. This patient is 10 years post-treatment, absolutely fine. DSA, everything is normal. Now, whenever you're dealing with large AVMs, you have large AVMs, you have only two options. Many a times, most of the patients who are referred for AVM radiosurgery, they are surgical rejects. The surgeons say, okay, this is not, we are not interested in doing too. How do we deal these particular large AVMs? Through two modalities. Number one is volume stage and the second one is dose stage. Now when you're doing a volume stage radiosurgery, doing it with DSA is absolutely mandatory. Absolutely mandatory. You have to define, okay, this particular area of the nidus is supplied by anterior cerebral, this particular area is supplied by middle cerebral, and therefore initially I will shoot the anterior cerebral nidus, and then in the second stage I'll shoot the middle cerebral. The thing is, that is very important, but many a times we also can plan for dose stage radiosurgery, and that is how we essentially practice. When you do this kind of patients, this patient was, we have done a volume stage radiosurgery because it was pretty large, corpus callosal AVM. You can see 30 months post-treatment, the nidus totally obliterated. This was a patient whom we have done dose stage radiosurgery, large sensory motor cortex AVM, and we have done dose stage radiosurgery. At the end of 3 years, the patient had a good response. So when you are doing all this imaging, you need to identify certain weak points. You know, angio-architecturally, what are my weak points? Where the chances of bleed is increasing. See, this is the beauty of the imaging which is there with us. And we need to understand that in little depth before we start implementing into our clinic. So when you are speaking about arterial pathology, it is the aneurysms and the end passage type of feeders which have increased risk of bleeding. If you're looking into the nidal components, a large nidus, I mean, these are all supposed, you know, there is no, it can still be debated whether large nidus is really a cause for bleed or not. because we have seen a good number of patients with large nidus, no bleeds at all. And the last one is the venous stenosis and varix. These also have a higher risk. So essentially, you need to sit with your interventional radiologist or the interventional vascular neurosurgeon, discuss with them, and then learn. And everything as I speak, every day I keep discussing with all these people and I keep learning. So the other important indication, vascular indication, is what is called as the dural venous fistulas, DVFs. Now these dural venous fistulas, surgery is not done. Surgery is out. The only two treatment options, embolization or radiosurgery. If it is vascular access is easy, then you do embolization. The vascular access is difficult, then you do radiosurgery. And this is one of the patients whom we have treated almost a few years back, celebrity, and sigmoid transverse sinus dural venous fistula. And you can see how this particular thing changes. Now, the second important thing in AVM space is the vestibular schwannoma. I'm sure Dr. Stuti will explain this to you in great detail. But what I would like to draw your attention is try to incorporate this advanced imaging, which includes the DTI of the facial nerve. You know, one of the reasons why we do radiosurgery for schwannoma, not one of the reasons, important reasons are: number one is the facial nerve preservation. Number two is a hearing preservation. These are the two reasons why we advise for radiosurgery. That's very important. So always have an idea about the seventh nerve when we are speaking. Always keep in mind the pseudo-progression which could happen. You also need to be aware of the different changes which happen in the radiosurgery along the pre-treatment, post-treatment, the temporary enlargement, the transient loss. Need to wrap it up. Important announcement. Yeah, so please go ahead.
Yeah, so I'm so sorry for pausing this, sir. I apologize. So it's a pleasure for us to inform all of you that we have Dr. Ghanshyam Biswas with us. Sir is actually the person who has been behind this conference for the last 3 days, and he's so tied up that I really don't want to hold him back. So I hand over to Dr.
No issues,
for a
please.
2-minute introduction and then felicitation.
A man who needs no introduction with us, amongst us, is a noted oncologist, Dr. Ghanshyam Biswas, who did his MBBS from SCB Medical College, Cuttack, MD in General Medicine from MKCG Medical College, Barampur, DM in Medical Oncology from TMH, Mumbai, European Certified Medical Oncologist. His professional experience starts from as a senior resident in Department of Medical Oncology, TMH, Mumbai, as observer in BMT unit, leukemia and lymphoma services, head and neck thoracic services in MDAC, Texas, USA, specialized registrar in the Department of Medical Oncology, TMH, from 2005 to 2007. He is also a life member of various associations. He is a life member of ICON, associate member of ASCO, member of ESMO, and life member of ISMPO and ISHTM. A man who needs no introduction. He has always believed on the 3 C's of cancer care: compassion and cure. Let me invite Dr. Ghanshyam Biswas to the dais and let us felicitate him. Without him, this program wouldn't have been successful today, and we are really, really very thankful to him.
Thank you, sir. It's okay. That's fine. Please switch off the lights. Okay, so next 10 minutes we wrap it up. I'm sorry for keeping you holding, sir. Yeah, so we need to keep in mind when you're doing radiosurgery, what are the different kind of imaging presentations happen? The dose is same. It's 12 gray. You know, majority of the benign tumors in the brain, they respond to 12 gray. That should be the least good mark. Of course, it depends on the heterogeneity you give based on the indication, whatever we are discussing. But we need to understand this dose has a bizarre presentation in different tumors based on the heterogeneity, the pseudo progression, which is pretty common in females and post-op setting. And all these things we need to keep in mind. In addition, there are gliatic changes. If this is interestingly one of the patients who was treated elsewhere, and you can see the kind of gliatic changes which are seen inside the cerebellum, and that's something which we should avoid. You know, that is something which we should kind of avoid very easily. We also need to keep in mind the delayed regrowth which happens post-treatment. And all these patients, we do ADC, diffusion weighted imaging is very important. Always do diffusion weighted imaging for acoustic schwannomas. Now that will give us, because whenever you're thinking about histology, there are two types. One is Antony A and Antony B. And Antony A and B, they are based on the cell densities. So if you are having a higher cell density, the diffusion is less, therefore the ADC value falls down. And there is enough evidence which gives us that if your ADC values cutoff limit is 800 into, this is what you can get from your radiology colleagues, you can see if that is higher, then you have lower density and it is failing. So you can use it as a predictive tool as well. So we also need to understand, I'm sure Mohanty sir will explain in detail about this, adenomas functioning and non-functioning. One thing you need to keep in mind is imaging-based response and hormonal control. Hormonal control is fast-based to imaging-based controls. I'm sure Mohanty sir will explain in greater detail. The third important thing is meningiomas. I'm sure Professor Senapati sir has already alluded to. Use radiosurgery for grade 1 meningiomas, not for grade 3. Use it cautiously for grade 2. Now, whenever you are seeing a meningioma patient, you need to define radiologically the grade. You know, it's difficult. Nevertheless, every tool has its own limitations we need to understand. But we need to at least make an attempt to say hypothetically what should be the grade. Whenever you are seeing a grade transformation, you can see more edema there, more heterogeneous contrast enhancement, and more importantly, the loss of fat planes between the tumor and the normal vein. These are few important imaging criteria that I use when I am sitting in the clinic. I look whether this patient is ideal for radiosurgery or not. You know, you always learn to choose your battles very, very wisely, because if we don't choose our battles wisely, you will definitely fail. And this is what I have learned over the last 2 decades. So, as I said, ADC is very important. The more the cellularity, your ADC falls. So, always you can see grade 1, it is less, and grade 2, it is more. So, the other important thing is vascularity index. These are all very simple things which you can sit in your OPD, open the packs, see the images and find out. See, here we basically compare it with the enhancement you see in the superior vessel sinus and the pituitary. You make a comparison of the lesion with this particular signal intensities. You will get some vascular scores and you can find out. We also define, particularly as sir already alluded to, the dural tail is very important in meningiomas. How do we define it properly? One of the mechanisms is through gallium DOTA specs, because these particular tumors, they have those receptors which are important for SSTR. You know, that's very important. So the other important thing you need to keep in mind is this particular tool will also give us an idea about the grade of the meningioma. Now, I'm interested in knowing the grade to define the outcomes. For those post-op is okay, you get the grade. But if it is not any primary radiosurgery, grade is absolutely very critical. Like cavernous meningioma, no surgeon will go and do the surgery confidently. Similarly, optic as for meningioma, you are doing something which are more relevant in the context of grading, which defines the outcomes totally. Have a proper understanding, do the imaging in a better way to ensure that we have that information. And of course, you have this MR spectroscopy. There is not much difference in the grades, so don't say look for those spectral patterns to identify the grades. The best tool is ADC, the DTI, and as I said, the gallium DOTA scan to define the grade of the tumor. And sometimes when you're dealing with a para-false sign meningioma, always keep in mind venous preservation is more important. Because once this is roasted up, these patients will have more of edema, and that will be dangerous. These are all refractory edemas. They don't subside less. And the second important thing is in the malignant indications, radionecrosis is something which all of us deal routinely. We need to avoid these particular complications. There are different high-tech pool protocols which are very important for us. And as you can see, this is a pseudo-progression of the brain tumor, which later on subsides after 6 months after a short course of steroids. And apparently this was a patient who is a true progression. So how do we differentiate between this is absolutely very important. One of the tools that I use routinely in my clinic is the T1-T2 mismatch and the lesion quotient. Every resident should know this. The T1-T2 mismatch is basically, as you see, you look into the T1 post-contrast and the T2 sequence, and if this is not matching, for example, this is the contrast enhanced, but in T2 it is not matching properly. So when you're dealing with a T1-T2 mismatch, histopathology has proved that it is necrosis, not tumor. When the T1 post-contrast image is matching perfectly, like you can see in this one, it is just matching perfectly in the T1 and T2. That is T1-T2 match, and if you do a biopsy there, it reveals a tumor, not a radionecrosis. So keep this in your mind. Whenever you're sitting in a clinic, having a doubt, look at the T1 post-contrast, T2 sequences, and you will get the answer. Similarly, you have another condition, another parameter, which is called as lesion quotient. And lesion quotient typically is something which we look into the hypointense nodule on the T2 weighted and the area of the T1 weighted image sequence. And you can see if it is more than 0.6, you can see it's a recurrent tumor, less than 0.3, it's a radionecrosis. The third important thing is dynamic scans. Now, routinely, my medical oncologists, they always say, Shankar, treat this patient again. He has a recurrence. I said, just hold on, sir. Let us do a proper imaging. And once because you know what you have done. And once you diagnose its radionecrosis, your line of management totally differs. So therefore, you need to do perfusion scans, because in a RCBB, you get the microvessel density. In relative, you have a percentage signal intensity recovery. See, this is something you need to remember. I'm sure once you sit with your radiologist, you'll understand. Whenever you give a contrast, there is something which is called as percentage signal recovery, which happens slowly. The contrast levels increase. This recovery is what is something which you need to map it out when you're doing dynamic perfusion scans. And if this percentage signal recovery, RCBB, there are a set of values that you always need to keep this in your mind. In fact, I would suggest my resident, they have their pocket diary books, they write everything, and they make a comparison. Do it in 5-10 cases. 11th case, you will know automatically whether it is tumor or a recurrence. Of course, this is one of the patient whom we have treated. You look at the perfusion scans. There is no perfusion at all. Keep this patient on a short course of steroid and they respond. And of course, FDG PET is also used, MR spectroscopy is also used. You can see if there is a large necrosis, there is no significant glucose metabolism. As you can see here, there is no glucose metabolism, and that is necrosis. And when you see a glucose metabolism, obviously it is recurrence. And many a times, try to develop the habit of integrating DTIs and new advanced neuroimaging. As you can see here, this was one of the thalamic meds, and we were more compelled to protect the corticospinal tracts. So we integrated the DTI, mapped those tracts, and then protected it from high dose gradient. You know, this is particularly relevant when you are doing radiosurgical thalamotomies, which I'll be discussing in my functional radiosurgery lecture, and you can integrate these particular tools. Similarly, in high parietal mets, you need to localize the arcuate fasciculus. And of course, radiosurgery, necrosis management, all of us know steroids, and those not responding to steroids, we put them on VEGF inhibitors. And if VEGF inhibitors fail, that's the time you actually advise the patient surgery. This was the first time that I've seen, you know, necrosis, how it looks. It looks like a white tennis ball. White tennis ball, you know. When my neurosurgery was doing, of course, this was a patient whom I have not treated elsewhere. This patient was given probably 20 gray, 24 gray or something for one of the meds. You can see the frontal meds. And the patient actually developed radionecrosis. And this patient, I kept them on VEGF inhibitors after a short course of steroids, didn't respond, then we advised for radiosurgery. The first time that I've seen radionecrosis where it becomes a white ball. And the other important thing which I would like to draw your attention to is, we also do for pain, cancer pain, radiosurgical hypophyseectomy. What we do is we just shoot down the pituitary stalk, and once you shoot down the pituitary stalk, there is an increase in the endorphin levels inside the hypothalamus. So when the endorphin levels inside the hypothalamus increases, it activates a descending pain pathway, including the locus coeruleus, the substantia nigra, and all the areas. Then you will have a very good pain relief. In fact, this is something which I use for all those refractory patients, and just 80 gray shot is more than suffice to the small target which will hit the pituitary stalk. And we have also treated few patients with celiac plexus refractory pain, the pancreatic pain. And lastly, let me just focus on functional radiosurgery. Here, as I said, the main indications are neuralgia, tremors, and sometimes we do for epilepsy also. So when you are doing it in the context of MVD, you use tractography and CT cysternography. This is very important. You know, whenever we plan to do it, don't do anything on MRI. You know, I try to do without MRI. In fact, contouring nowadays, we are just trying to do it on a plain CT. You know, we have very good plain CT, which is 620 slice CT scanner with a very good spatial resolution. So we use just the CT scan to localize the nerve and just shoot down. In fact, we stopped the practice of doing MRI for trigeminal radiosurgery. And this was, whenever we do MRI for trigeminal, it will be more for tractography to extract the pre-treatment fractional anisotropy values. And look at this patient. He has such severe cutaneous triggers, and this is just immediately post-treatment, how beautifully the patient responds to the treatment. And all these patients, as I said, we do the DTI-based imaging, and pre-treatment, post-treatment, we look at the FA values, and if the drop is more than 30%, you can stop the medications. We start the tapering immediately the next day, but once the FA drops, so you have an objective criteria to define how it responds, and this is the better way to do it. And as I said, use DTI whenever you're doing radiosurgical thalamotomy, and These tracks actually give us exactly, they take us to the nucleus which we are targeting. So understanding the brain anatomy also is very important. And lastly, epilepsy is also one important indication. I will deal it with this particular aspect when I speak on functional radiosurgery. Thank you so very much for your patient listening. I would be happy to take any questions if there are any.
Since you said the AV malformations are most of the cases referred to you or rather rejected by your neurosurgeon colleagues. Yes.
Yeah.
So what are the red flags when you see the patient and the profile? When will you not touch? Or maybe what is like your selection criteria for your
So now essentially there are only two indications and really we are actually coming with it. One is deep seated nature and the second one is allopathia. So if we are,
they will not touch.
Yeah, they will never touch it. Yes. So when you are dealing with any eloquent area, you have to define how proximity is that eloquent area to the nerves. Now, if you are able to deliver 50% less dose than what you are giving on the nerves, you can definitely go and take it. So the best way to do is you map that area. And therefore, FMRI and DPI will assume much more significance. So that is one thing which I always look at. And of course, as I said, the augmentation rates do not depend on the size of the lung. It doesn't depend on the other angular architectural factors. It depends, the hemorrhage rates are more dependent on the history of previous SH, the deep location, and the deep venous drainage. If I'm seeing deep venous drainage, I'll be really worried about it because they develop purpose acutes with these.
And how has your experience been a follow-up?
Oh, I have been doing this since 18 years now. So, in fact, I'm writing a paper on integrating all this high-end with the FMRI function information. So we have done probably integrating FMRI, DDI, we have done nearly 75 odd cases, and we have a long-term follow-up as well. Usually, the median follow-up which I have was something around 2.5 years, and I would say around 70% of them have actually operated it. I'm just waiting for some more time, but the remaining is operated. That's what none of the patient had any complications. And we have given out surgical doses, full surgical doses, no compromise. Based on the volume stage radiosurgery, as I said, we have defined the vascular territories and then shot it in 2-stage sessions. So we need to keep all these things in mind before we address that particular issue.
Thank you, sir. Now, I would introduce, it's my pleasure to introduce Dr. Bidu Kalyan Mahanti, sir. He has done his MBBS graduation from MKCG Medical College, Berhampur, and completed his MD Radiotherapy from PGIMR, Chandigarh in 1983. He has a rich experience over 30 years to his credit. Dr. B.K. Mahanti has worked at some of the best hospitals in India, like All India Institute of Medical Sciences, New Delhi, and Kidwai Memorial Institute of Oncology in Bangalore. Dr. B.K. Mahanti has also worked with the Royal Hospital Muscat Women to establish the first radiotherapy department and set up patient care at the National Oncology Center from March 2004 to 2006. He was the director and head of the department Radiation Oncology at Fortis Hospital, Gurgaon, before joining as director of KIMS Cancer Center, KIT University, Bhubaneswar. We are glad to welcome you, sir, here and listen from you, sir.
afternoon to all of you. And I should thank Dr. Titi, Dr. Mishra, Dr. Sanapati, Dr. Shankar, Dr. Lucy Patnaik, and maybe you all must excuse me that I don't know most of you, which is okay, I think, with all of you, and Ranga. What am I doing here on a Sunday afternoon? And I think the best part that I liked was about this brain plasticity. Ideally, I should be, oh, Saroj is here. Ideally, I should be sleeping on a Sunday afternoon or reading a novel. And Saroj knows that Saturday afternoon onwards, Sunday, I'm usually a very private person. Those who have worked with me. But then, it's 85. I think I started in 1985 as a faculty, and this is my 38th year. And unfortunately for most of us, Saturday, Sunday are the medical conferences. And that's a big bug for me. I'm extremely reluctant, more so for the last 10 years or so. More so after I took a voluntary retirement from AIMS, Delhi, and I'm extremely reluctant to travel, extremely reluctant to use my Sunday, because slowly over the last 7 to 10 years, I'm more moved to non-medical readings on weekends. And I spend my Friday evening onwards till about Sunday afternoon, my non-medical reading. But then I was caught with these words. We are committed to the achievement and maintenance of excellence in education, research, and healthcare for the benefit of humanity. And I unquote Dr. P.C. Reddy, Chairman, Apollo Group of Hospitals. And this is something which I request all of you to keep it as your owners. We are here for the society. There would be transitions. There would be time where you will question whether being a doctor or a nurse is a nice thing in the society at the present, which is okay. Which is okay in the sense that society will not live without disease. So when society will have diseases, there will be someone to take care of that disease. That's for sure. So you and I, or my next generation, will be here. Now I will start with what Dr. Shankar time and again said, that I will tell some of these things. I will not tell much. I usually don't tell much. So about 2 years back, I returned back to Odisha, and I'm totally unknown to Odisha. I'm an unknown entity as much as unknown entities like Ranga or Dr. Shankar here, and I'm here for setting up this cancer center within the KIT University. In the coming 3-4 months' time, this will be a sub-storage center where, as part of the commitment for a university, it will have the facilities more towards the academic components and the research components, plus also it will have the clinical services. And we have started slowly with the cancer surgery and the medical oncology and palliative care, and we'll be adding the other things in the coming 3-4 months' time. How do I go forward? Okay. So let's begin with the anatomy and the radiology. This is the anatomy of the cellular and para. I think somewhere you might have read in the program that it is cellular and supracellular. I don't much think that there is much about supracellular except for the pediatric group of benign tumors. It's largely cellular and paracellular for the adult. And this is the anatomy that you see for your coronal and for your sagittal. And this is what I have deliberately kept, a diffuse meningioma over the cellular paracellular area, an MRI of a diffuse meningioma. So what exactly is cellular and paracellular? I always tell that it's a crossroad. When I start to tell about the anatomy or the radiology of it, I usually tell that it's the crossroad region of the brain to harbor and present to you various different disease spectrum. It will present to you infectious diseases, vascular diseases, benign and malignant diseases. And you have to learn how to quickly understand these differences. But for us today is the pituitary tumor, craniopharyngioma, and meningioma. And there are other like the cavernous sinus, optic glioma, chordoma, hemangiopathy, and in fact, Rathke's cyst, and various metastatic lesions that we will see often and often. What I'm going to tell you is what for about last 7-8 years I have engaged with my colleagues. For this particular region, I have engaged with my colleagues. So this data is largely from my colleagues, and I must name them: Dr. Munshi, Dr. Ganesh, Viplav Sarkar, and few other colleagues you will see along. So what we do is we decide right from the beginning what kind of a setup you should have and what kind of a practice, dimensional practice that we will do, whether it should be a 3D or a VMAT, and what kind of a practice we will do for our parent. And we try to see right from the beginning of our mold preparation to our delivery, we see the setup and the shift and the imaging and the positional corrections. These 4 things that we see as our gamut of things. I was looking at Dr. Shankar's 8 rings, and I will add 3 more rings to it. It is 11 rings. You had put 3 rings, 8 rings, and I will add that 1 ring before that is your clinical evaluation of the patient. 1 ring in between is your post-table evaluation of the images or review, and 1 ring of that particular chain is your post-treatment first 3 months follow-up of your SRS patients. So what we do as our practice steps and what we do is we do a very careful neurological, neuro-ophthalmologic, neuroendocrine, and what kind of a RT dose patient had received if we are doing a re-irradiation. And more or less we have moved this practice, although frame-based practice sometimes is helpful, more so for the pediatric group of patients. And we use a triple layered, and patient is CT scanned in the localizer box, and box is also generated, transmitted for our TPS, also to see the stereotactic center along with the anatomy and the Lionac isocenter. We have not, I'm not showing you anything about the gamma knife based practice, which earlier we did at AIIM. Whatever I'm showing you is for the last 7-8 years, what we have done. And then, for the different techniques, whether it is single fraction SRS or SRT for the larger tumor, or the fractional SRT for still larger beyond the 4 centimeter, we usually define the traditional OARs, then what we call as our recent, and we did certain works related to those recent cochlear, scalp, and hippocampus. And then, as Dr. Shankar said, our emerging areas when we do the SRS for the functional areas and the tracts. Of course, I have left it blank, but we have also from time and again discussed what should be within our team, our future areas of work. And then, of course, the story ended that I have left that place, so that future is blank for me, isn't it? And you can't say that. Okay. What exactly is radiosurgery for the cellular or paracellular? Remember that SRS for the brain is non-coplanar largely. And try to sink it in your mind. It is a non-coplanar. So when you are defining your target, if target center is at the machine isotope, only coordinate rotation is required to achieve the desired angle. I will show to you what works we have done regarding this for the different axes. Okay. Imagine that SRS is almost like astronomy. Many times we discussed within our team that it is a Galilean kind of looking at a star. Into a Galilean way of looking at astronomy for the star with what you call the so-called mythological Euclid space. So this is where, like say, for the cellular area, you have to define all the parameters, 6 parameters for yourself. And at each of these, you have to carefully see in all axes before you decide. And this is again, I am showing you for the paracellular area. And as Dr. Shankar has said, that you have to be extremely careful when you are doing your contouring, how you are taking out the OAR like a brain stem here or an optic nerve there. And you have to be extremely careful about this, how you can do that. So what we did is we wanted to convert a 6D into conventional 3D for our day-to-day practice. And we wanted to see that how quickly our technologists can adapt to their day-to-day practice. And it helped us for just using the table position from these 2 or 3 CVCTs that we can achieve. But interestingly, one of my colleagues found out and that this is out of patients. She found out that we had certain deviations were definitely coming up for concern. So within such kind of a pre and post table corrections, one has to also keep in mind these factors, more so for the OARs, like optic nerve, left optic nerve, for a particular group of patients, 21 patients, for a small group of patients evaluated, and this was coming. So our question is about our risk margin, and do your internal audit for intraclinical evaluation. Each of us should evaluate each other's work. Otherwise, take a safe liberal margin, and we take conventional margin of 1 millimeter for all cranial stereotaxia. And for the brain, when we are doing it nearer to that crossroad region of the cellular and paracellular, we must also keep in mind the optic nerve region. This is one of the patients for which, as I told you that what were our future, one of this was our future. How we should evaluate the visual aspects, pre and post visual. And as you can see, the patient's right eye, right optic nerve, and then we found how the right vision improved, the visual field improved over a period of time. And these are important not for you from imaging or dose or your OAR limits, or these are important for the patient, remember it. The cochlea, the optic nerve, the vision, the hearing, these are very important for the patients. The speech, like Broca's area, Dr. Shankar was talking about. For you and I, you are only wanting to play with technology with millimeters. For patient, it hardly matters whether you are doing it with millimeters or centimeters. What counts for him or her is the vision. Has it improved? The hearing, has it improved? My gait, has it improved? Isn't it? And that should sink into you. These information should sink into you when you are doing your work. I think that I would say is that the radiobiology, a lot of us give a lot of importance to our technological components. I would say that technology is only a small part unless you are using your doses properly, whether for the target or the tumor or for the normal tissues. And you should, like what Jack Fowler used to say, that if you don't know what dose you want to give, don't be a radiation oncologist. Although he was a radiobiologist, but I used to love his words, that he used to say, if you don't know what dose you want to give, don't be a radiation oncologist. So you should know your equivalent dose for 2 gray and convert that. For example, Dr. Shankar time and again said about 12 gray. Or how do you convert this 12 gray to 30 gray fractions and see it for most of your benign tumors for alpha beta 3. And this is what I usually say, that for a benign tumor, if you want to give between 50 to 54 gray and you want to convert this to 12 gray, you want to convert this to 30 gray in 5 fractions, you will remember these parameters and whether these parameters are fitting into your practice rightly or not. More or less, we know that pituitary, it's almost 14 to 16 gray in 1 fractions or 25 gray in 5 fractions. More so when it is more than 3 centimeters, better to give 25 gray in fractions. And on that, for functional pituitary, and can somebody say, out of all pituitary adenomas, what proportion are functional and what proportion are non-functional? Any idea? So, ideally we say it is 70-30, right? Ideally we say it is 70-30, but then always do a few hormones, even if you see it as non-secretory, and keep that as a baseline information, right? One good thing is that with this, the control is between 85 to 90% at 5 years or more, and the hormones decrease in about 50 to 70% of the patients. But then remember, if you are treating somebody in the young adult age, 10 to 15% will have their long-term hormone deficiencies unless you are monitoring them properly. Then come the meningiomas. I think the meningiomas amongst all are, I call it to my neurosurgery colleagues, and I don't know about Dr. Sankar's neurosurgery colleagues, but my neurosurgery colleagues at AIMS or later on at Fortis or Manipal were a bunch of people who wanted to see that if I don't do surgery and if you are treating this patient, how good you are. They were secretly trying to they would like to know after 3 months or 6 months, okay, Vidhu, Rana is a close friend, Rana Pata is a close friend, and Misra is a close friend, and Ashok Mahapatra is a close friend. They all will say. So, one thing that you must do is, more so for the paracellular, keep the optic dose when you are doing single fraction below 9. And if you are able to do it, keep the optic nerve at least 2 to 3 millimeter away from the target. And if it is nearing the target, don't give 100% to that area. Give 80 to 85% to that area. We give it differentially. And they have excellent control even for about 7 cc or more, and 90% control at 5 to 10 years time. And this is a large data, systemic data. Craniopharyngioma is a little different, and you have to give a little different dose for, say, solid or cystic or mixed. Don't give similar kind of a dose. And sometimes it is good to fractionate if it is a mixed type. And one thing that you should know is that sometimes you might get carried away by a cystic or a mixed, thinking that they will do better. They don't do better. When you carefully look at your MRI, they don't do better. Rather, the solid ones do better than the mixed. So, this is one thing from our data analysis of about 600 odd patients. Of course, these were all primary and metastasis together. And Anusil, I'm thankful to Anusil for sending me this slide about 2-3 days back. I had forgotten about this. It's done some 2-3 years back. And our mean for all patients was this. 1 to 5 sessions we had kept as this, 12 cc. Our median was this for all patients and this for those odd patients, out of which I think 110 were probably meningiomas and 108 were other paracellular lesions. So Kartika Purnima kebe hitila? Monday, no? Monday was Kartika Purnima. So I stayed in housing society, and there is a basketball court, and I got this photograph from someone who is of similar to my age. Okay? I loved this photograph. I kept it on my mobile, and while fiddling with my mobile, I thought that I should bring this for this talk. The science and art of technology and dexterity. Science is not exactly something that you have to think as highly intoxicating. Science is something that you have to see as highly exciting. I hope you understand the difference between excitement and intoxication. Am I right? Am I right? Okay, I will close here. Love you all.
I must say that was a very enriching talk. My fond memories of Biddu Kalyan sir started in 2014 when I joined Fortis as in a fellowship program for advanced radiation therapy techniques for SRS and SBRT. I must say our radiation oncologist par excellence, his super cool demeanor, witty humorous sayings actually enriched me, and all throughout 2014, I have been a very big fan of him. And what a day today is. The journey which started in 2014 has culminated into this day, where we have been conducting the first of its kind SRS workshop today. And what a day, where we have received this legendary speaker, Biddu Kalyan sir, today at our premises. And today, as it's my birthday also, and it's no greater gift to invite him for this lecture, and he has given his valuable time for us today. Please welcome Biddu Kalyan sir for his felicitation. Please, sir. Yes, sir. Please, sir, please come to the dais, sir. Sanjay bhai, please come. Sir, Senapati sir. Sir, Saroj sir. Saroj sir, Senapati sir, Lucy di. Shankar sir, please. You also, sir.
Dr. Mishra was asking me, this photo is from, no, this photo is in the housing society where I live. And this photograph is only 6 days old. Sir, please. Short and crisp.
Next car again.
Let me tell you, the best lecture that I have heard. The best lecture that I have heard is of a person, as you go back and you read about childhood leukemia. One name which will come up is Donald Pinkle. So Donald Pinkle was the one who was involved for about 30 odd years for the leukemia research from late 1960s till early 1990s. And somewhere in 93 or 94 I heard a lecture, and he must be similar to me. By that time, the person who is reluctant to speak, the person who has very little of knowledge compared to a few, and who is always nervous in front of the young people because he has probably fallen behind the wedges. And you know what is falling behind the wedges is. He had only 5 slides. And what were those 5 slides? The first slide was in 1960s when he saw what is the leukemia cell. And the second slide was about a child with leukemia, and with that, at that particular time, the CBC of the 1970s. And the third slide was about the drugs being used in 70s and 80s, and the results being received in 70s and 80s. And the fourth slide was about the works that the team had done between the 1970s to 1990s. And the fifth slide was, obviously by that time, in the 1990s, the cytogenetics had come for cytogenetics to bring to the day, which we have known now in the last 25-30 years' time, like the minimal residual disease. It was not known, believe me, when I was studying, we didn't know anything called MRT. So I'm talking about 30 years back, where the team was thinking about why some children are fail. So it's like this that as I must say that when you age and you are unsure about your knowledge, you bring less and less slides to speak. Because you don't know whether people will accept what you are talking about. That's the experience.
Thank you, sir. Now, it's my pleasure to introduce our beloved sir, Dr. Sanjay Kumar Mishra, sir, who is very known to everyone. He's a leading radiation oncologist with an exemplary experience of more than 16 years. Dr. Mishra has worked with the top cancer centers and oncologists in India. He has joined as a senior consultant radiation oncology at Apollo Cancer Center, Bhubaneswar. Sir, we would request you to deliver your speech. Sir, please.
The most fit radiation oncologist.
Sir. Yeah, so it's already late, and I think most of the slides have been covered by many faculties. So, introduction I'll skip, it is already covered. Frames to frameless already Sinapati sir has covered. These are variant proving mistakes. So indications have already been covered. So I'll directly go to the role of SRS in AVM. So before that, let's know what is arteriovenous malformation for the juniors. Congenital abnormality of the cerebrovascular system with poorly formed blood vessels that shunt blood directly from arterial to the venous system, bypassing the capillary network. And 2.2% annual hemorrhage risk in unruptured cases and 4.5% risk in previously ruptured cases. So what are the risk factors in AVM? Deep location, deep venous drainage, associated aneurysm, nidus for a single vessel connected by one to the several fistulas with risk of rupture. Overall prevalence is low, approximately 18 in 1 lakh individual. Age at presentation mostly between 20 to 40. The late the age, the prognosis is poor. Approximately 50% of patients present with hemorrhage and 50% present with non-focal symptoms like headache and nausea, and some are incidentally found in a focal neurologic deficit. Risk of death per bleeding is in the range of 10%. So it need to be treated. 30% have serious morbidity associated with each bleeding. How to diagnose it first? By angiography. This is the best modality because you can stage it, you can grade it as per the Spezler-Martin scale, so which can tell us the predictive of hemorrhage risk. And MRI, MR angiography, CT angiography are the non-invasive technologies along with BSA. So angiogram will somehow look like this. Already Dr. Shankar has shown many of the pictures. So Spezler-Martin grading is based on the size, which is the most important factor, less than 3, 3 to 6 centimeter, and more than 6, 1, 2, 3 points. So higher the point, poorer the prognosis. Venous drainage, whether superficial drip, that has already been told. Eloquence, already sir has presented. So close to eloquence area, the prognosis is bad. So from 1 to 5, we grade them, and based on that, class A, class B, class C with higher grade, poor prognosis. Lower the score, better outcome. So management is basically include starting from observation. If it is non-symptomatic, in certain cases we need not treat them. Surgical resection, embolization to reduce the size of the AVM, and then stereotactic radiosurgery. The goal of any therapy for AVM is to completely obliterate the nidus. Partial obliteration of the nidus doesn't decrease the bleeding risk. So complete surgical excision provides immediate cure, but carries a risk of intraoperative bleeding, ischemic cerebrovascular accidents, infection, and that can lead to death. Endovascular therapy like embolization is not curative, but may be used to decrease the risk of intraoperative bleeding or to decrease the size of the nidus before planned radiotherapy or radiosurgery. So the treatment algorithm, intracranial AVM, ruptured or unruptured. Ruptured if it is Spezler-Martin grade 1, 2, SRS versus microsurgery. If it is, the score is 3, SRS versus hypofractionated stereotactic radiotherapy plus minus surgery or embolization. And if it is SM grade 4 or 5, volume stage SRS, already explained by Dr. Shankar, because when the volume is bigger, it is very difficult to treat with a single fraction. So they give a space of 3 to 4 months and 2 stereotactic radiotherapy planned, almost in the range of 15 to 18 grain in a fraction. In an unruptured case, SM grade 1, 2, 3, asymptomatic follow-up versus stereotactic radiosurgery, symptomatic stereotactic radiosurgery versus surgery, plus or minus of embolization depending on the size of the AVM. And SM grade 4 or 5, asymptomatic follow-up because these are bigger tumors, and symptomatic volume stage SRS or hypofractionated stereotactic radiosurgery alone or in combination with embolization or surgery. So how it helps? Stereotactic radiosurgery obliterates the AVM nidus, approximately 75% of patients within 3 years of procedure. So once it is done, we need to wait till 3 years to get the optimal response. Local obliteration rate varies from 50 to 88%. AVM obliteration rates optimized are 23 to 26 when it is done with a frame. Frameless, as already Senapati sir has told, the dose varies from 15 to 24 gray. So low doses are selected for most patients to minimize the complications. So with higher doses, complications are more. SRS is indicated mostly for lesions in deep or eloquent regions of the brain and is particularly safe and successful for lesions that are less than 3 centimeter. So volume is the most predictive factor. Less than 3 centimeter, obliteration rates are very high. More than 3, it decreases significantly. So University of Pittsburgh's data shows the correlation between the dose rate and nidus obliteration. They said that once the dose increases, at certain point beyond 20 to 22 gray, it becomes plateau, so there is no benefit adding more dose. 22 gray, the obliteration rate is 85%, 26 gray, it is 88%. Beyond there is no benefit. So we have to wisely choose the dose while planning for stereotactic radiotherapy. So time to obliteration ranges from 1 to 4 years after SRS. So Mariamma et al. They have demonstrated that bleeding risk is not completely eliminated, but reduced in the range of 88%, which is significant. And overall, the obliteration rate is 80% by 3 year for lesions less than 3 centimeter. For larger lesions, angiographic obliteration varies, it may range in the range of 66%, more than 5 centimeter, even poorer prognosis. So management of large AVM is presently difficult because of the radiosurgery may be associated with high complication risk, as already Dr. Shankar has told, the reason being more of the normal tissue being irradiated. And improvement in embolization with liquid glue or onyx polymer can sometimes help to reduce the target volume so that we can deliver higher doses for better results. So stage radiosurgery in which large AVM are treated, has already explained on that with a gap of 4 to 6 months, 2 to 3 sessions. Prescribed dose has already been told by sir, somewhere in the range of 21 to 22 gray. If it's a framed radiotherapy, 50% isodose line. And when it is a linac-based SRS, it is 16 to 24 gray. For spinal AVMs, 20 to 22 gray in 2 fractions. So the outcome says in all the trial, if the distance from eloquent area is more than 2.5 centimeter, then the results are superior. If the volume is small, less than 3 centimeter or below 15 ml, then the results are superior, which is obvious from all the trials. So the last trial where the volume is more than 5 centimeter or 46.84 millimeter in average volume, the obliteration rates are 0. So which is obvious that the size is the biggest prognostic factor in all these prognostic factor group. And when you compare the recent evidences, gamma knife based radiosurgery versus linac radiosurgery, they have been found the doses prescribed in linac radiosurgery as lesser and results are superior than gamma knife based radiosurgery. You can see the data. Coming to re-irradiation, when we do re-irradiation, after 3 years of completion of one stereotactic radiotherapy or radiosurgery, when there is still presence of AVM, we can re-irradiate almost in the same dose, and the obliteration rates are in the range of 61 to 80%. Stage SRS for large AVMs already covered by Shankar sir. So toxicities, coming to the toxicities is very important. We should know what are the toxicities. The risk of neurologic sequelae from radiosurgery is approximately 3%. Neurologic sequelae depends on treatment volume, dose and location. So re-irradiation we do after 3 years with acceptable morbidity. And what are the common post-SRS complications? Cerebral edema, radiation necrosis, arterial stenosis, delayed cyst formation, organizing hematoma. So what are the possible mechanisms? Direct radiation injury. Direct radiation injury to the adjacent white matter seems to damage the oligodendrocytes following reactions of other glial cells such as microglia and astrocytes, which may be related to brain edema, necrosis and delayed cyst formation. And the second factor is hemodynamic changes. Radiation effects on arteries or draining veins involve damage to the endothelial cells, followed by reactions of the microscopic and macroscopic vascular wall, which may cause arterial stenosis, encapsulated hematoma, and hemorrhage after nidus obliteration. Incidence rate of radiological post-radiosurgical complication is in the range of 30 to 40%, though all are not symptomatic. So symptomatic complication varies from 8 to 11%. 3.4% of delayed cyst formation, 1.7% of increased seizure activity, and 0.4% of white matter signal change on MRI. So the rate of latent period hemorrhage after SRS varies from 2.6 to 10%. Risk of latent period hemorrhage higher in older age, larger AVMs, and lower when used with higher radiation dose. Prior rupture of AVM before stereotactic radiosurgery is not a predictor of post-SRS hemorrhage, and treatment for this is corticosteroid, and 34% of complete resolution of symptom, 49% of partial resolution of the symptom. And how to do the prediction of toxicity post-SRS? There is a 12 gray volume, which is normal brain area received over 12 gray, already explained by Shankar sir. The lesion was associated with symptomatic post-SRS image if the higher the dose of being delivered 12 gray, beyond 12 gray volume. So if the volume is 0.1 centimeter cube, brainstem and thalamus toxicity is in the range of 11 to 11% and 5%. And as the volume increases to 40 centimeter cube, the brainstem and thalamus gets nearly 92% and 84%. So that correlates with the toxicity. So when we are treating, we need to dose the dose volume histogram, and the volume dose constraints for optic path less than 0.2 cc should get maximum volume of 8 gray and maximum point dose of 10 gray. Cochlea, maximum point dose 9 gray. Brainstem, less than 0.5 cc should get volume maximum dose of 10 gray and maximum point dose of 15 gray. Spinal cord and medulla 0.3 cc, 0.35 cc, maximum volume of 10 gray and maximum point dose of 14 gray. Spinal cord and subvolume less than 10% of volume should get volume maximum dose of 10 gray and maximum point dose of 14 gray. Treatment rating algorithm already Rangosamy has discussed. So the parameters for plan evaluation are like target dose coverage, target dose heterogeneity, conformity index, high dose pillage, and dose gradient index. So that's all. Thank you.
Thank you, sir. Now I request our business head, Mr. Shukumar, to felicitate Sanjay, sir. Now I would request Dr. Shankar Vangipuram, sir, to give us his lecture on radiosurgery for meningiomas.
So what I will do in short of time, let Dr. Sticky complete a presentation. I just, meningioma, I wrap up in 2-3 minutes and then take to functionalities. It's already 5 minutes.
Sticky.
So I think, shall I start?
Yes.
I just come to completely function. I think that would make sense. Rather than let's skip this particular topic. You want me to skip meningioma or? Huh? Present. It will get late. I mean, I'm good to present the whole day, not a problem. But what I will do, I'll focus more on the functional part now. Let me just, can you just plug in into this? So, this is the same topic that I presented last week in the NIMANS conference. Can you please switch off this light? Yeah, thanks. So, I'm sure meningioma, I'm just trying to skip because all of us have been blasted since morning the indications for radiosurgery. If a patient of meningioma comes to you, usually they don't come, but if they come to you, it is only surgical rejects. It should be medically inoperable. First treatment is surgery. Please remember this. Now, if you find a convexity meningioma very close to parafalcine or parasurgical area, and in an elderly patient, that's the time we do primary radiosurgery. There are two radiosurgeries, primary and adjuvant. In primary radiosurgery, it is taken as a first shot. Now, whenever surgery is done, it can be grade 1, 2, and 3. Right? It can be grade 1, 2, and 3. If it is grade 1, then we need to look whether it is subtotally resected or grossly resected. If it is grossly resected, you can keep the patient on follow-up. If it is subtotally resected, less than 3 centimeters, that's an ideal indication for radiosurgery. Right? Grade 1, resected, no evidence of disease, you can keep the patient on follow-up. Grade 2, grade 1, subtotal resected, less than 3 centimeters, radiosurgery. Right? Now, let's swap the gears. Grade 2 is there. The surgeon has done the surgery. The histopathology has come as grade 2. So what do you do at that time? You have to give adjuvant radiation therapy based on the mitotic rate. You know, basically grade 2 and 3 and 1, the difference is the mitotic rate. If it is 4 to 19, it is grade 2. More than 20, it is grade 3. Grade 3, regardless of whatever findings are there, you have to give post-op treatment. Ma'am, shall I continue if you don't mind? Yeah, yours will be the last lecture. So I'm skipping the meningioma part. I'm just wrapping up in 2 minutes, giving the residents the bird's eye view of the management. Not going into evidence and all this stuff because sir has already come. I'll be done in just 20 minutes, 25 minutes. For the functional part. Okay, so grade 3 you have to do radiation. Grade 2 you have to look into the histologic features and then decide. And typically for grade 2 I don't use radiosurgery. That is controversial. Use conventional radiation. Conventionally fractionated radiation therapy is the best option. That is where the evidence is going more towards. Grade 3 it has to be conventional. For grade 2 it is 54 to 60 grade. For grade 3 it has to be 60 to 66 grade. Get the heterogeneity into the system. Don't stop for meningiomas at 50 grade. That will be a disaster. I have treated good number of patients post 50 grade with recurrences. So please don't stop at 50 grade. You have to get from your imaging findings what is the grade. You know, in the initial presentation I told you when do you think the grade transformation has happened. What are the features? Number 1 is the stromal edema, the vascularity index, and the hyperostosis which you see. All these are the classical imaging findings of high-grade meningiomas. They're not low-grade. So based on that, you can decide what doses to be shot. So if you ask me which meningiomas you do radiosurgery, it is grade 1. Post-op less than 3 ideal. Otherwise, it is 3 to 5. I would still use hypofractionated radiosurgery, which is 3 to 5 sessions. So, yeah. Yeah, observation is a choice. That's what I told, no, sir. Grade 1, no, grossly resected. You don't need to do anything. You can wait and watch. Okay. All got the concept for meningioma? Any doubts? No doubts. Okay, now let's change the gears and I'll take you to a different world which is called radiosurgery for functional indications. So again, this is Ernest Sachs is the father of neurosurgery, right? So this was a adage he has given way back in 1949. I feel sure that certain brain lesions which today are treated inadequately will be removed successfully, or if not removed, will be destroyed by other means. I mean, this is a wonderful prediction from a noble person who is the father of neurosurgery. And as I told earlier, we have mastered playing the games of sub-millimeter accuracy. If someone comes and says, okay, doctor, what are you doing? Oh, I play sub-millimeter games. That's wonderful. And what tools do you use? Either gamma knife or X-rays. X-rays on the CyberKnife or the Linac-based stuff. So we have both the options there, and this is very, very important that you need to know. Many a times, once you get seriously involved into intracranial radiosurgery, your neurosurgeons will ask you these questions. What is the big difference between gamma knife and CyberKnife or X-knife? So in gamma knife, typically the older versions we use 190 cobalt sources. The newer one we use 201 cobalt sources. So these sources are actually fixed. So if you want to shoot any beam, it has to go through that particular collimator. You can't change the collimator. So therefore, you have a flexibility to shoot a target from 200 angles. That's it. You don't have much option there. Now, the second important part, of course, the icon has been released recently, is a frame-based approach. Only in India, the other day I have seen, in NIMHANS they have icon. Remaining all places, it is frame-based radiosurgery that is used. And the third important thing is that the algorithm which is used for dose calculation. I have a big problem there. They use a TMR algorithm. TMR was something which we have used almost 3 decades back. I mean, when I started my career, we were still not gone into Monte Carlo, but we were using that other simplified, what is it? What is that algorithm that we were using? Not the AAA algorithm. AAA algorithm, yeah. That is what was there existing there at that point of time. I mean, we have not used TMR. The biggest problem with TMR is density corrections do not happen. So, frame-based TMR, restriction on the number of beams which we are using, all these are limitations of gamma knife. Compare it with CyberKnife for a LINAC-based system. Of course, LINAC, you have a limitation with regards to the non-coplanar approach, but in CT, you don't have that problem. There are 1400 angles which can be used to shoot down. One biggest asset in LINAC or CyberKnife is we use unflat beams. Unflat beams are very important for us to deliver the treatment in the shortest time. And this is very important to, in fact, we have written papers on how it alters the outcomes as well. Now, unflat beams, typically if we do, in fact, the trigeminal, if you are asked to do any function radiosurgery on a gamma knife or a CyberKnife system, the time will be at least 1 to 1.5 hours. 1 hour it will take. We have done end-to-end radiosurgery completed in just 15 minutes. That was the shortest time we could wrap it up. But again, you have to do all the presets upfront prior to doing the radiosurgery. Now, whenever you are doing functional radiosurgery, I'm sure there are few technical things that you need to keep in mind. Number one, stereotactic cones. Cones are absolutely very important when you have to do functional radiosurgery. Don't do it with MLC. We have done it with MLC, but I learned from that mistake. But given a choice, if you have an option between MLC and cones, do it with cones, not with MLC. You have to see that there are fixed collimators, there are variable collimators. Now the first thing, this is what I was telling to, the physics has to be ready for this particular treatment mentioned. Because the doses which we shoot, even radiobiology also cannot justify that. If we give 12 gray, the BED dose is around 60 gray. You are shooting 85 gray here. What is the BED? You can't even apply the LQ model there. If you look into apply the LQ model, theoretically, it is. So honestly, yes, we can't shoot, but when you are attempting to shoot such lethal doses, then you have to do a very good physics requirement. And when we started the practice, in fact, every point which I was discussing, we have published all these papers. So we first attempted to do it with MLC. When you're looking at MLC, there are two things which are very important. Number one is the penumbra, and the second one is MLC reproducibility. Suppose if I open the jaw 5 millimeters, it has to go, the MLC has to go and stop exactly at 5 millimeters. There will be a shortfall or an overthrow. That should not happen, because that will change my entire penumbra. So when we are doing this, we have looked into the penumbra first. For a 5 millimeters cones, the penumbra which we got was 2 millimeters. That is what cones also give. So we're pretty happy there. The second one is the field dimension. You know, the physics was showing us film dosimetry is very important. Now let me tell you one thing, film dosimetry, if you are using for high definition, higher dosage, the unflagged beams, you can't do the regular film dosimetry. You have to use high definition graph chromic film dosimetry. That's very important. In fact, we were struggling. When we started the functional radiosurgery program, we had the very tough period. You know, we were not, I have done everything on the gamma knife, but honestly, to get that on the Linux system, I was finding it a little trouble because the QA needs to be robust. So we looked into both the penumbra and the leaf reproducibility rate. It was perfectly matching. We were very happy. Then we looked into the immobilization. And when we are looking into the immobilization, there are several options which have come from Electa. Number one is a double reinforced stereotactic mask and with a mouth bite. So we were wondering whether we will be doing it in an improper way. So we did a study first. We looked into the reproducibility pattern and the positioning error. We have just randomly chosen around 15 patients of brain tumors, and we have done the online image guidance, and we looked into the different positioning errors in the translation and rotation planes. And we have met the dosimetric requirement for stereotaxy, which is sub-millimeter and sub-degree. So you need to keep these two things in your mind. Number one, use unflagged beams. Number two, use cones. Number three, use double reinforced stereotactic mask. That is good. If you are using a mouth bite, like what you see here, these patients, you are using non-coplanar beams. So the exit doses, we are not really sure whether from which dose. You always look at the intermediate dose pillage. You don't look at 5 gray or 3 gray or 2 gray, right? So sometimes when you're treating skull-based lesions, your exit doses will be through the mouth, and you will have a cutaneous reaction, oral reactions, mucositis will come. So we stopped using mouth bite systems. We always use double reinforced mask. With this brief technical introduction, let me just fly you through the different indications. We have treated almost every indication, what I have shown here, including neuralgias are the most common, which is trigeminal, glossopharyngeal, sphenopalatine neuralgia, or cluster headache. We have done for epilepsy. We have done for tremors. In fact, next week I have a tremor radiosurgery. And of course, psychoradiosurgery for OCDs also. See, please, you have to understand, these are all uncharted territories. Not many people will venture into this. But when you are venturing into this, you have to have very strong fundamentals so that, many a times it so happens, Dr. Shankar, you're taking away my food and my bread and butter. I mean, after my talk is completed, they say you're not competing with us in the first place. So let's be honest, more calm and composed, and try to take things in an inclusive manner rather than a confrontive manner. So let me just fly you through the trigeminal neuralgia. You need to be, patient selection is the most important thing whenever you're trying to do all these high-end things. Number one, if the patient is more than 60 years with medical comorbidities, surgery is never an option, they will say. So then what we do, we target the trigeminal nerve in the prepontine cistern, as you see here, and that is like 4 millimeters away from the brain stem surface. The dosing paradigm which we use is between 80 to 85 gray. I started at 70, and today as I speak, we have done around 236 trigeminal radiosurgery, which is highest in the country on frameless systems, not on gamma knife, on Linac and cyberknife. Only these two systems I work, and we have done the highest in the country. In fact, I'm publishing that one as The dosing paradigm which I have used was around 85 gray. Now I go at 85 gray. I never shoot doses beyond 90 gray because the painful dysesthesias become permanent. And when you're looking at the target placement, it is either distal, retrogessarian, or it can be proximal, which is called OR point or offset-inner point, that's what we say. The retrogessarian point is called Martial point. You can see this is the metal scale. And just beyond that point, you're going to place a 80 gray shot. And that is the kind of dosing paradigm we use. So when you are shooting 85 gray on the nerve, your brainstem is just 4 millimeters away. How much is the dose follow-up which can happen at that point? So we have, because we have a very large series, we evaluated. We looked at the responses for 30% isodose curve. This is actually kissing the brainstem. The 25% isodose curve and 20%. We looked at the long-term pain outcomes. 30% isodose curves have given good responses. Now I will explain you the reason why this is very important, because many a times radiosurgery, how it works, the neurosurgeons keep on asking us this question. What the neurosurgeons do is they place a Teflon pad, microvascular decompression, between the vessel and the nerve. What we are doing is an ablative procedure. How is it altering the pain dynamics? You know, this is a very simple question which we keep on, once you start getting involved in radiosurgery, you keep on getting it. You have to understand the mechanism by which the pain comes. You have the artery, you have the nerve. They have a resonance. Every organ inside the body has a resonance. I will show you in that particular slide where the motion is there. Now, whenever the artery and the nerve, the resonance matches, the patient will have pain stabs. This is the basic pathophysiology. The resonance is actually matching. Now, you do any ablative procedure, forget about radiosurgery, you do radiofrequency or glycerol or alcohol ablation, whatever you want to do. What we are doing is altering the resonance. So when you alter the resonance, number one, you are decreasing the pain stabs. That is peripheral way of action. The second is we need to understand neurovascular conflict is present only in 60% of patients, not all the 100% of patients. So 40% do not have. So there what I do, I keep more of doses to the trigeminal principal sensory nucleus, which I will show in the next slides. There you give more dose. Like I go up to 5 gray to the trigeminal principal sensory nucleus, and you have very good response. So basically, we need to understand the pathophysiology for all these patients. As I said, what we cause, this is very important. You know, at 60 gray, what is happening? Nothing is happening to the nerve. This was a baboon study, right? They have shot 60 gray in one baboon, 80 gray in one baboon, and 100 gray in one baboon. And then they have done the surgery and looked at the trigeminal nerve. At 60 gray, nothing happened to the nerve. At 80 gray, there were myelin sheaths which were collapsed. So what is happening to the myelin sheaths. At 100 gray, then you will see that there is dissolution of the axons. Now, our prescription of 80, 85 gray, whatever we are seeing, we are just altering the myelin sheaths. That's it. And later on, these myelin sheaths recover. You know, body has its own mechanism. Because, as I said, neurons are amitotic, not oligodendrocytes, not astroglial cells. Supporting neurons are amitotic. So, myelin sheath, I will show you how we track this myelin. So, this is a paper which I think I have written very. When we shot 80 gray, I was little worried about the patient. I was never trained for 80 gray in my, Subramaniam sir never taught me all these things in the first place. So when I returned from Pittsburgh, I was wondering, 85 gray on a nerve, what will be the morphologic changes which can be picked up on imaging? So we have done a radiosurgery, post-radiosurgery imaging. As you can see, we have done it 72 hours. We have done it 1 week, 1 month, and 3 months. If we do any post-treatment follow-up, usually we do at 3 months. I have selected 72 hours because any injury which happens, the macrophages will reach that particular point after 72 hours. So when the macrophages come to the radiosurgical insult site, what are the alterations which happened is what I have checked. What I have seen is a small focal enhancement on the nerve. You can see this. That is a small focal enhancement. And at 1 week, that is the time when you have the immunologic system getting activated. You know, we keep all these patients on steroids, right? Why do we keep on the steroids? We need to suppress the immune system. Otherwise, because of this lethal surgical doses, the immune reaction gets triggered to a very high levels because the immune system wants to repair the damage that you have done. So we checked what is going to happen in 1 week. There was brainstem edema. I mean, this was one of the first paper in the world that we have written, and probably it has educated many, many people. Right? I got a lot of compliments for this paper. And the second important thing is the changes which happen at 1 month. That is what you're going to see at 3 months. So I take it till 70%. Yeah. So this is 80 gray. The marginal dose which I give is around 70 gray, sir. At the ISO center, you will find around 85 gray. Marginal dose is what I essentially look into. And now the most important thing is the targeting accuracy. Every point, every slide is a paper that we have written. And we were actually worried, you know, post-treatment, how these changes happen. We have looked in 3-dimensional planes. That is a Euclidean space variation. It was always less than 0.5 millimeters. So our targeting system with which we are actually working today, I worked on an Electa system, but I'm sure even variant system, if the principles are properly followed, will deliver the same kind of results. I'm pretty confident about it. Now the other important thing is I found around 0.5 millimeters difference. That was the maximum I got in 2-3 patients. We were analyzing what really is the problem. Why are we getting 0.5 millimeters? What we realized in the frameless system is the patient actually swallows during the treatment. Now if the patient actually swallows, I would like to draw your attention. Look at that small subtle variation which is happening there. The head is moving like this. These patients are actually put on a small vacuum pillow, and that pillow is put on an extension. So when the patient actually swallows, the intraoral pressure increases, and the patient swallows, there is one certain variation. So probably that could be the reason why we were thinking 0.5 millimeter ka difference kyun aaya hai. So we were worried, yaar, let's figure out how it impacted dosimetrically. So what we did, we acquired intrafraction imaging at every 4,000 monitor units, 4,000, 8,000, 12,000, 18,000, and then deformably walked the doses from the planning CT to the cone beam CT. So from the planning CT, we mapped all those voxels to the cone beam CT. Of course, the density corrections was already done. And what we have seen is not much difference. So we looked into the alignment accuracy, we looked into the intrafraction motion analysis of the frameless, and we were quite confident with the system what we are working. I mean, many a times when you speak with neurosurgeons, they'll say, Dr. Shankar, hey, the best system we use only gamma knife and all shit. But please understand, there is so much of homework which has gone through it. We are not speaking nonsense. We have done sufficient research on the systems what we are doing. Now, this is a point which, I mean, not many neurosurgeons will access. We buy a gamma knife very newly. The dose rate is very high. Gamma knife, cobalt sources, all of us know, they have a half-life of 5.2 years. After 5.2 years, to deliver the same 80 gray, it will take 1 hour. After 11 years, it will take 2 hours. Every 1 half-life, your treatment time gets doubled. So, the higher the dose rate, the lower the response lag time. There is evidence for it. Now, this is one of the compelling impetus for me to get a better system on place. So this is the point where we thought, okay, let's start using unflat beams. Now, the unflat beams have come into the market 2008, 9, after image guidance, the next technical advance was in unflat beams, 2008 or 9. So we first have done a dosimetric study comparing the flat and unflat beams on the trigeminal dosimetry. We are pretty happy with the dosimetry. We have treated good number of patients, but incidentally what we noticed is the response lag time of unflat beams was faster compared to flat beams. This is something which we have noticed, and that is matching with what the gamma knife paper was saying. Now we thought why this could happen. Why a faster treatment is giving us less suffering to the patient. So you need to understand one thing. This is where this paper is very important. Where we are targeting the prepontine system near the pons, and you can see the brain actually in motion. All the motion which you see is in the central structure. So this was one of the papers that we have published, and we have actually, this is one of the most interesting stuff. And why do you see this motion? It synchronizes with the cardiac system. The carotids beat, and along the carotids you see all this basilar vertebral artery. The motion is predominant in the central brain structures. Now, this ranges anywhere between 0.1 to 0.5 millimeters. Now, this is very important because trigeminal neuralgia is a disease of elderly, not of young patient. If you find a young patient with trigeminal neuralgia, the differential diagnosis is multiple sclerosis. Keep this in your mind. If some young patient, 25 years old, comes to you, says, "Sir, मेरे को यहाँ पे बहुत pain होता है, shock मारता है," so please exclude multiple sclerosis. So trigeminal neuralgia is a disease of elderly patients which has brain atrophy. And because of brain atrophy, you see the prepontine system actually opened up bigger. Now what happens, the resonance issue, what I told, it appears more often. What we are doing, essentially, as you see, when you are targeting it there with the, when you are targeting the trigeminal nerve for the motion which you are seeing here, right? If I am treating for 1.5 hour, let's say hypothetically, your targeting accuracy decreases. If I am doing it in 15 minutes, your targeting accuracy is fast. It's a much more accurate. So therefore, the clinically relevant fibers which come into the surgical shot, it will be very high. So therefore, that supports the preliminary observation of what we have made, where unflat beam trigeminal radiosurgery gives us a bigger advantage compared to flat beams. And now the second important, not second, I think third or fourth, is how do we predict the outcomes of trigeminal radiosurgery? This is very important because majority of the functional diseases, they are called orphan diseases. You find a pain specialist, he says, I am your father, you come near me, I'll treat you. You see a neurosurgeon, there is a 100% success rate, I give it. I never give 100% success. I never give it. I mean, none of us should give it. We shouldn't speak lies to the patients. Number one, I have seen good number of contemporary specialists who actually give foolproof guarantees. That is absolute farce. Nobody does it. So how do we document it? Number one, we do trigeminal tractography for all the patients. Now, when you're looking at trigeminal tractography, there are 4 parameters which are very important. Number one is the FA value. Please keep this in your mind. FA value is actually representative of the myelin damage which happens. Number 2 is axonal degeneration. That is extracted from RD and AD values. So when you are doing radiosurgery, as you see here, these are the pre-treatment and post-treatment. So we have the pre-treatment FA value and post-treatment FA value. So we are interested in the myelin erosion. You can see the FA value, the larger the drop, the faster is the pain response. This is very important. So we are actually having an objective way to define how the outcomes would be post-treatment. So because we have done a very large series of 235 patients, and this advanced imaging probably in the last 5-6 years that I have been using it, ever I started implementing it in my clinic with a median follow-up of 3 years, what I have noticed is the pain control rates are very good in those patients where the FA drop is more than 30%. So the moment the post-treatment imaging scan shows 30% FA drop, I call the neurologist and say, doctor, you please stop this medication. So you have an objective way of dealing with it. And this was actually a patient who underwent gamma knife radiosurgery in probably AIMS or Indo. And the patient came to me for recurrence after 12 years. So we were confused, where the gamma knife surgery was, radiosurgery shot was placed, and I cannot get the dosimetric details from Hinduja. He will never give it. So therefore, what we did, we have looked at the FA values at the nerve entry zone, the midpoint and the distal point, retrogressive point, and use the contralateral nerve as a control. So you can see at the nest point, the drop in the FA values was very high. It was 0.13, against distal is 0.2 and 0.2, so almost 50% drop is there. So I don't place my shot at the nest. I place it little posteriorly, and that is where I have gone. This patient, 2 years post-treatment, pain-free. So the point which I am trying to tell is, we have the tools, wonderful tools there. We need to apply it into our practice, and it works out very well. Now, many a times, patients come to me and say, doctor, this treatment, how will be the outcomes, the long-term outcomes? Long-term outcomes, when I say. Now, as I shown earlier, you have to realize about the brain plasticity. Whenever the pain is very high, there will be plastic changes which happen in the white matter tracts. Now, these plastic changes are concerned with pain modulation, the pain perception, the cognitive system, and motor system. So therefore, if the patient comes to you within 3 years, that's the ideal time you do radiosurgery, because if these plastic changes happen, you do MVD or radiosurgery, nothing is going to work. It will respond temporarily, but it is bound to fail. So therefore, you need to tell your neurologist that, look, I'm seeing the plastic changes in all these pathways, and therefore, the response could be unlikely. So when you are practicing trigeminal or functional radiosurgery, these are all the plastic changes which can be extracted. And the module which we use is called kurtosis imaging, DKI, diffusion kurtosis imaging. And for trigeminal tract, it is tractography. Now, you need to understand one more thing here. So, the trigeminal tract, if you look into, it's from the face, all the nerves. It's the beauty of radiosurgery is, you need to understand, like Professor Senapati has already alluded to, sensory nerves are explicitly sensitive to radiation. Right? Sensory nerves, what are the sensory nerves in our brain? Optic and vestibulocortical. That is what Professor has put in his slides. And number two, the motor are exquisitely sturdy. You throw 100 gray on a motor nerve, not a problem. Not a problem. Trigeminal is a mixed nerve. It's a mixed nerve. It has motor and sensory. Now, when you are doing this, you need to understand the sensations from the periphery. They go upwards, and when they go upwards, they follow a particular path, which is the sensory nucleus, trigeminal sensory, mesencephalic nucleus. They go to the thalamus, and from thalamus they go to insula. So try to look. Many a times, your neurologists say, this is a central pathogenesis path. Central pathways are involved. So this particular imaging will help us define whether the central pathways are active or the peripheral pathways. If the central pathways are active, you do MVD or radiosurgery, temporary relief, patient will fail. So you have that information upfront prior to doing the treatment. So this is a better way of managing these patients. So as I said earlier, all the MVD recurrences, this is the patient, we have to do CT cysternography. And that is very important. How do you delineate it? You see this patient, in MRI we couldn't delineate anything. We can't see the nerve properly. But in cysternography, we have seen the lesion very well, corroborated it with trigeminal tractography, and then shot it down to 83 gray. Patient has, this video I shown earlier, you can see how beautifully the patient responded. See, this is the beauty of what tool we have. We have very powerful tool with us, which is radiation. When I started my career, after taking fellowship from Bhubaneswar, I went to Tata Memorial. There I was with Dr. Sareen and Jalali. They have done few radiosurgeries. From there I went to Pittsburgh. And that was actually the turning point. But essentially to carve a career in radiosurgery is something which I realized much better, almost 2 decades back. And that was the time when nobody has ventured into radiosurgery. Everyone was speaking about IMRT, and then 2004 IGRT has come into practice. So the point which I am telling is, we have these tools here and we can do everything phenomenally. Radiation can be used really very powerfully, not for just cancers, but non-cancerous indications. What I am showing is non-cancerous. Right? This was a patient, as you see, same, all my patients, trigeminals. Interestingly, these patients, you find a T2 hyperintensity band in the pons. When you see the T2 hyperintensity band, the first diagnosis I make is herpes simplex. Central herpes, you find T2 hyperintensity bands. And this is responsible for the disease. So, again, you can't do radiosurgery for the MVD for this indication. So we have done radiosurgery for this patient, and immediately after the treatment, you can see how beautifully these patients, they respond to the treatment. The only thing we need to understand is the pathogenesis before it happens. We fail to understand the pathogenesis properly before we try to treat. And of course, trigeminal schwannoma, everyone would have treated secondary trigeminal neuralgias, these are called. So secondary trigeminal neuralgias, very interesting cases and pretty easily treatable. Doesn't need, we don't even shoot 80 gray on all these lesions.
But yes, for 12 day, 15 day, you will have very good responses. And you can see these are the trigeminal neuralgia. We have done secondary TGN, we have done stage radiosurgery for CT angle and paracellular. I mean, we had this patient 2 years down the line, very good response. Interestingly, sometimes patients have bilateral symptoms as well. Bilateral contract. My wife has neurovascular contract. Someday I have to treat her when she becomes symptomatic. But honestly, yes, these patients, as you can see here, the neurovascular conflict is seen very obvious. These patients have, we can offer them stage reducers. And you'll have very good response. And you know, many a time physics ask me, clinicians, doctor, what are the doses you give to the brainstem? I mean, I really question the brainstem problem, and in fact, good number of publications are coming. We always make sure that the max threshold dose should be less than 12. But threshold dose is 0.03 cc. But max voxel dose, I have gone to 28 gray. Single voxel. You can give that dose. But your system needs to be absolutely robust to deliver 28 gray to the brainstem. In fact, I'm telling with 2 decades of experience, I've not even seen a single side effect for the 28 gray max voxel dose that I have treated in my case. Not even a single side effect. Patients are absolutely, in fact, the second patient that I have treated when I came back from Pittsburgh was a VIP, political chief minister's brother. And almost 16 years post-treatment, absolutely fine. So the point which I'm trying to tell is, we have to have, radiation is a very powerful tool for the youngsters. This is a very good career you have chosen. My request, please, after completing your MD or DND, don't jump to do medical oncology. It is a bullshit job you can never practice. Yeah. So be passionate about the branch which we are dealing. We are doing so many wonderful things beyond oncology, and there is a large opportunity here that can be catered. Okay, so the trigeminal, lot of shit like this you see. So one thing which I would like to draw your attention is, there is one more condition which is called as trigeminal autonomic caplalgia, that is clustered. You can see from this image, the patient is literally dying of retroorbital pain, orbital and retroorbital pain. So in this particular situation, along with autonomic symptoms, in these particular situations, we treat the sphenopalatine ganglion in addition to the trigeminal. So when you shoot down the sphenopalatine ganglion, you can see that the autonomic symptoms respond very well. This was a patient who has hemifacial spasm. You see the blepharospasms in that patient? Blepharospasm is the spasm in the eyelids. Along with that spasm, the patient had severe trigeminal pain like symptoms. And you can see we have done dual targeting of the VCF bundle, vestibulocochleofacial bundle, and the trigeminal dress. Immediately after the treatment, this patient I treated almost 2 years back, absolutely pain-free, no blepharospasms. Patient is a smoker and developed hypopharyngeal cancer, and he is undergoing radiation now. So the point which I am trying to tell you is, it's a very interesting outcomes can be delivered if we do our practice our science in a meticulous way, applying common sense. That's more important. We have the tools there. We have to go and search for it. The problem is we don't effort to search for it. You know, all the things which I'm showing you, even my neurosurgeons are not, even my radiologists at Apollo, they are asking, Dr. Shankar, you are asking things which are there but nobody is using. I said, if nobody is using that, that is an opportunity for us. If somebody is not using it, it's a bigger opportunity for us. We have to keep it to work. We have the tools there, but we have to put them into action. And the point which I'm telling is, it makes more sense. This is one of the earlier part of the paper that we have written. In fact, 224 patients. the median follow-up which we have is around 46 months. 85% of patients, they have excellent to good pain relief. So it's one of the large volumes, and probably by next year we will see the responses. The other important thing is the glossopharyngeal neuralgia. In glossopharyngeal neuralgia, whenever the patient swallows, there will be terrific pain in the ear. So this patient, immediately after the treatment, we have shot the glossopharyngeal nerve in the jugular hiatus. 83 gray was delivered. It is just close to the vagus nerve. I was little wondering, vagus nerve ke paas 83 gray shot. I was little worried about. But all I know is the simple fundamental. It is not a sensory nerve. So I can afford to shoot 80 gray. So I went, shot and came. Immediately after the treatment. 2 years post-treatment, patient is enjoying life, is autotype. So these patients, you can do MVD also. But the problem is the risk is very high if you do something near the skull base. If you touch the jugular hiatus, it will be very risky. People will say, okay, what is there? I can go there and do it. But whenever if there is any trigeminal neuralgia patient or a glossopharyngeal or cluster, refer them to the surgeons who are doing only in high volumes, not 1 or 2 surgeries in a year. That will be the most easiest way of screwing the patient. I have seen low volume neurosurgeons with great failures. Now, the second important functional indication is epilepsy. Does it not make sense? We are practicing all things which are different altogether. It is not cancer. So whenever you are speaking about epilepsy, you have to understand when to select the patient. The number one is it needs to be focal epilepsy or partial epilepsy. It should be disabling and the risk-benefit ratio should be acceptable. These are the important criteria. So I'm not going, focal seizures are more important. Absolute contraindication is whenever there is an underlying disease, epilepsy. It's actually a network disease. Epilepsy is usually not a single focal disease. It's a network disease. The entire brain network actually gets affected. So what you really need to understand is, I'm going directly into the point, how you define the network. Now, getting to the network is the most important thing. Getting to the substrate is the most important thing. How do we define the substrate? So what we do is, in our clinic, we have different methods of doing it. Number one is what you see it as stereo EEG. Stereo EEG, you place the electrodes from the skull into the area of suspected epileptogenic region. And you look at the tracings and you can localize exactly where, which area in the brain is responsible for the focus. Stereo EEG is little costly. They charge, our hospital, they charge 8 lakhs. But again, that is a better option. The alternative option which we have is MEG, the magnetoencephalogram. These only in All India Institute of Medical Sciences and IMHANS, you have MEG. And I usually advise MEG for my patients because in magnetoencephalography, you can actually get this raw data and integrate into our systems. So for your patient, better option to delineate the substrate would be MEG or stereo EEG. I mean, of course, clinical semiology and all the stuff, they are all important. But that gives you an idea, okay, this is the problem in the frontal lobe, this is in the temporal, this is in a high parietal, you can see. See, behavioral changes happen more once the epileptogenic focus is more anteriorly placed, near to the frontal lobe. If it is more posteriorly placed, you find more of somatosensory area. If it is in the middle, it will be more infotile. Simple. So clinical semiology will give us an idea where the epileptogenic focus is. Then you do a video EEG. Of course, PET-CT, you localize the hypometabolism or the interictal spec. So you have different tools. You have to learn to apply all those things. But the best form of localizing the substrate would be either MEG or stereo EEG. That boosts your confidence. If the patient can't afford that money, then probably MEG is a better option. So we have done a series of around 10 patients with MTLE, mesial temporal lobe epilepsy. Now you need to understand, in MTLE, this is a disease of young patients. You don't find 75 years old patients with MTLE, very rare. These are medically refractory seizures in young patients. Someone will be a doctor, someone will be a software engineer. In fact, I treated a doctor's family with 4 family members. Everyone has MTLE and everyone has seizures. I mean, that was the first family. In fact, there will be a case report that I will be writing. So I have done for the doctor the radiosurgical amygdala epicardectomy. You can see how beautifully the location can be localized. So please understand that when you are offering radiosurgery, it is only for the select indications. Just don't go and speak rubbish in front of neurosurgeons. They will throw trash on us. So we have to say, okay, brother, what is first thing you have to do is do a thorough global neurocognitive assessment. And once the neurocognitive assessment shows a good verbal memory and visual memory, then only attempt radiosurgery. Because our goal is to preserve the verbal memory and the visual memory. That is where we score over anterior temporal lobectomy, ATL. Because this will actually give us an advantage. Now, one thing which is very important, I wanted all of you to have a look. These are the patients who have some T2 weighted changes somewhere between 9 to 12 months. They have T2 weighted changes. And once you get those T2 weighted changes, you can see this particular patient. At 12 months, there is intense edema there. Now this edema, once it comes, you can stop medications. I mean, you can start tapering. Till then, the patient has to take medicines, but at decreased doses. But this is one of the imaging surrogate that we use for drug tapering. And in fact, most of my patients, they are all class 1 or class 2 responders. Angel class is what we use for epilepsy responses. And you can see they are all responders. Gelastic seizures are typically common in less than 20 years, hypothalamic hematomas. These are the patients who laugh for no reason. They just keep on laughing, or dacrocystic seizures, they keep on crying continuously, no provocation, nothing. So do a brain scan and you can see hypothalamic hematoma. Hypothalamus is one of the wonderful organ from the nature. I would say just 5 grams, but it controls everything in our body. Everything in the body, say in endocrinology, metabolism, sympathetic, parasympathetic, what else you want? Everything is located in hypothalamus. So anything which is there, you try to go and put a finger and do surgery, you're doing more harm than good. The best way to treat this patient is to do radiosurgery. There is no controversy about it. You have very strong evidence for it. Cavernomas, in the deep-seated cavernomas, you can see the best treatment option would be, again, the radiosurgery. And drop attacks, have you heard about it? Anyone? I treated recently one patient from Coimbatore. Corpus callosotomy we have done for drop attacks. Patients have very good response. So only thing which I am trying to tell is, try to use this technology very, very cautiously. You can see how the LPG metabolism has changed post-corpus callosotomy. So these patients, you have to understand the pathogenesis very properly and then figure out. The last one is a tremor radiosurgery. In fact, next week I have one essential tremor patient. You need to understand that when you are breaking the thalamus, you are actually hitting it at VPI nucleus, ventro-posterior-lateral nucleus of the thalamus. So you need to be really thorough in the brain anatomy when you're doing functional radiosurgery. In fact, my own neurosurgeons, I mean, I really sometimes wonder, I keep reading all these things, updating myself. They just go, operate and come out. I am not really sure the damage which happens. Not many neurosurgeons are cognizant about these things. So the other important point is VPN nucleus, and you can see this is a pre-treatment, post-treatment. How beautifully they respond to the. So the point which I'm making here is we have to use DTI for all these patients. See, whenever you have a patient of medically refractory tremor, you have only two options, not two, three. Number one is deep brain stimulation. You put electrodes to the brain, go to the nucleus, whatever nucleus they are targeting, STN or the VPL nucleus or subthalamic or anything, That is option one. Option two is lesioning due to radiosurgery. And option three is HIFU. MRI HIFU is something which we use. Now that is also a lesioning procedure. See, one of the biggest pitfall of radiosurgery is we don't have a direct information, physiologic verification as the procedure. When the electrodes are placed, when they are placed at the right spot, the tremor stops. So they have a counter-check mechanism. So here we don't have it, but we know to reach that nucleus we don't follow the standard OIO technique which says you go 3 millimeters laterally, 11 millimeters posteriorly, 2 millimeters anteriorly. There are some standard equations which is called OIO technique. What I do is I use tractography to exactly pinpoint which nucleus we are entering. And you can see the lesioning pre and post, how beautifully they respond. And for tremor, typically we shoot doses in the range of 100 gray. That is the 100 to 110 is what I use for tremor. And you can see this is the, when you shoot 100 gray on the brain, see what is going to happen, nothing. You have to keep this in your mind. Earlier when I was doing radiation oncology, if you do 3 gray or 4 gray or 5 gray treatments, people will say, oh, these are all high doses. When I was a student, I was never taught doses beyond 2 gray. 3 gray also was something which we were never taught. So the point which I am trying to tell is, you can go till 100 gray or 110 gray confidently on the brain, but this needs to be a super focused shot. That is more important. This, because the aim, as I told in my earlier, and all this we have long-term follow-ups. I'm not telling you of 1 day, 1 year or 2 years follow-up. I'm telling you of decades of follow-up. So, this is a patient who has dystonia. You can see how everything has changed. This is birth asphyxia related dystonia. We've done pallidotomy, radiosurgical, and how beautifully it responds. The last one is a psychoradiosurgery. You have some specified indications for it, which looks at the Y-box score. 1 minute. Sukumar is telling me, stop your nonsense and get out. Okay, so Sukumar, last minute, that's it. Yeah, so Y-box score is something which we look into when you are doing OCD. So we do bilateral double shot ventral capsulotomy. And again, as I said, something which I really like in imaging is tractography and kurtosis imaging. Understand what changes happen inside the brain. And that is how you really become. Similarly, we do subcortic choroidotomy. I've done for one severe depression patient, and anorexia one I have done, anterior cingulotomy. And that's how we use specialized techniques to deliver the best results. Thank you so very much for your patience. So these are all the new vistas of radiosurgery, which I'm sure every budding radiation oncologist should aim to excel in. And we have a radiosurgery fellowship at Apollo. Anyone interested post-MD can apply for it. We are making a formal announcement probably in the next couple of months. And it's open for the entire country. But I'm sure if anyone is passionate about nurturing a career in radiosurgery, they are most welcome. But it will be only for radiosurgery, not the conventional. Protons we should never use for radiosurgery. Then one of the morning, in fact, you were not there, I think. One of the advantages you get in proton is a brag peak. But one of the disadvantages you get in proton is the lateral penumbra. Most of the advantage you get in brag peak is lost because of, is offset because of lateral penumbra. And if it is adjacent to the critical areas, you never use it, sir. I'm sorry, ma'am.
Thank you, sir. It was a pleasure. Everyone has come to hear you, sir. So, I would request now Surendranath Senapati, sir, to come. Mr. Sukumar, sir. To felicitate, sir. Sthiti ma'am, please join us.
Thanks, Shankar, for the excellent presentation. This is an eye-opener for all of us. Frankly speaking, I had a hard his talk at Dr. Skanu's program, but this is definite eye-opener that besides our malignant lesion, how best we can also use the SRS for the non-malignant lesions. Thank you. It's a nice presentation.
Thank you. Now, I would request Dr. Saroj Kumar Das Majumdar, sir, who is a very eminent radiologist. He is additional professor, Department of Radiation Oncology at AIIMS, Bhubaneswar. We are glad to hear you, sir.
Good evening, and thank you, Dr. Sthiti, for inviting, and Dr. Mishra. My regards to Professor Senapati. I think I enjoyed, I am lucky to come here. I enjoyed Dr. Shankar's lecture. It is pretty new to me. Very great experience in this field. Actually, in 99, I was posted in Gamma Knife in AIIMS. That time, knowing nothing, we were posted to fix the frame, then see the dose like that, then SRT, SRS, all these things. But very sparingly we are using nowadays. So, our examiner is coming today. We have MD exam. I am in hurry. I'll take few minutes just to participate. That, but I had a nice lecture. So thank you for that. All of us, like for residents, this is a cell survival curve for a normal cell. We know everything. It just looks like a curve only. But you go to and see that first part only, you'll see it is not that curve. It's not steep, it is straight. Why this is straight? Because the normal cell has the capacity to repair. So that small area, you can see down the dose are there in x-axis, y-axis is the survival fractions of this cell survival curve. So this, we are dealing with the first part of the graph basically. Fractionation, whatever we are treating in lower dose area, Dr. Shankar is going to higher dose area. So this yeah, this is just normal. We are used to this curve only. We are at this stage. This is cell survival curve. The first part is little flat because of repair, which is seen in normal cell. This is another graph, normal and cancer cell. The red one is the cancer cells. The green one is the normal cells. You will see that low dose area, the green is superior to red. This is what we want actually. Without this, radiotherapy is useless. What they have done, the cell survival is superior in low dose area and the cancer cells are below that. This is what we want actually in our treatment. So this is what we know from our conventional treatment. Then we add the fractionation, how to go higher and higher by doing fractionation. You can see, again the aim of this cartoon is showing that the aim is to keep normal tissue survival superior to the cancer cells. The green is below. You kill all the cancer cells, you protect normal cells. These three graphs. Now, what is the biology about SRS, SRT or hypofractionation like that? Nowadays, SVRT is in common use. This is what today I asked this to our physicists. Just I gave Vijay, I asked, the handwriting is his only. So I asked Vijay, you tell me if I give 16 gray in a single fraction, what is the dose to the normal tissue, what is the dose to the cancer cells like that. So let us see the normal tissue alpha by beta is 2 and 10 is for cancer cells. This is what conventional we accept. And you can see this 16 gray single dose is equivalent to BD, biological equivalent dose is 41.6 gray. It is for the tumor cells. At the same time, 144 gray when alpha by beta is 2. It just changes when the single fraction is 16 gray. Why I have choose this 16 gray? If you give head and neck dose 72 gray by conventional fractionation, it is equivalent to 16 gray. So you can see that how it is coming. Similarly, again, 5.08 gray per fraction into 8 fraction. You can see when alpha by beta is 10, the BED becomes 61.3 gray. And the normal tissue when alpha by beta is 2, it is again 144. The upper one is 144, lower one is also 144. This is the catch. You go for high dose, normal tissue is suffering. So what the mechanism by which we can achieve this? Then comes our small target. The target should be very small. In radiation you will see 27 cc, 30 cc like that, means 3 into 3 into 3. 3 centimeter is the catch. So any tumor less than 4 centimeter or 3 centimeter, you can achieve this. This 144 gray you can make up. How? The small tumor when radiation is coming, dose gradient comes into play. The dose gradient means when we pass from the PTV or GTV, suddenly dose will fall off. So in few millimeters only, suddenly you will see 50% isodose line is touching that. That is what Dr. Shankar was telling about that. So that we can see only when the size of the tumor is small, then only we can do. So for residents, we always ask for SRS tumor, what is the indication, and tumor size should be small only. For if you are going to treat higher size tumor, then you have to fractionate. That is called SRT. So bigger size, Linac based, you can go for SRT, you can increase the size just for this formula only. The LQ model is used, you can see that EQD2 also from this. This is what is there. So for brain tumors, there are graphs are like this. You can just calculate 12 gray single fraction, go to other side, you can see what is the BED like that. So nowadays you have formulas for different category and you can calculate that. But my job is for radiobiology of radiosurgery or high dose perfection. It is same or different. Actually, radiobiology is known by fractionation, conventional radiotherapy, but for hypofractionation or for SRS, radiobiology is not much understood. Like as you see now, 100 gray also can be given. That is why this area is not explored to the maximum. So what we know, 5 hours of radiobiology. This from our residence time also we are doing this. First is redistribution. Redistribution is possible, means the tumor is in different phase of cell cycle, which is not here. You are going to give Monday, Wednesday, Friday, any day, one high dose, we don't know. So this is not a big factor for radiosurgery. Maybe this one then. The next one is reoxygenation. The cartoon in left side is showing that the tumor is there. Tumor is mixed state. One is hypoxic, the periphery was hyperoxygenated or more aerated cancer cells are there. And you can see once radiation is given, the oxygenated cells are destroyed fast. The outer ring is cells are killed, then comes the hypoxic cells. These hypoxic cells again you fractionate in conventional radiation, again some will become oxygenated, others will not. So like this, the hypoxic component is taken care of by fractionated beam radiotherapy. That is why cell killing is there. But in what will happen if the dose per fraction is very high, like radiosurgery, 10 gray, 12 gray, or 18 gray, 24 gray, how it will be there. So this is the reoxygenation. Carlstone was the first to tell about this. He suggested comparing a models where full course of radiotherapy was given to head and neck area versus 18 gray in single fraction to head and neck, or to the prostate cancer single fraction 24 gray. What is concluded that you lose 3 logs of cell killing, means hypoxic area, and you give high dose per fraction, cell killing is actually not that great according to this Carlstone hypothesis and models. But he was contradicted by Brown et al. He calculated and told that by seeing the SBRT cases, and he told it is, the killing is not that reduced if high dose is given. The concept is that maybe immune response, maybe vascular damage, other factors are coming into play. So single high dose per fraction means there are other factors than common 5 Rs. Who are they? So you can see in hypoxic components, hypoxia means cell killing is reduced. So fractionation is required. But when you give high dose, what will happen? In hypoxia, there is angiogenesis, there is neovasculogenesis. Angiogenesis means vessel to vessels formation. Vasculogenesis means due to cytokines, growth factors, and new vessels is generated. This is called vasculogenesis. This model from a mice. What was done? A 10 gray of single fraction was given. 0 is the day when radiation was given, and you calculate the clonogenic cells there. You will see the cell count is reducing and reducing at the second day. So even if you are not treating, only 1 day treatment was given, the cell count is declining. It declines up to certain level, then again start rising, maybe because of proliferation. The repair and the repopulation is for normal cells, not for tumor cells, right? So this is one. Another model also like this, in SRS cases, you can see once you go adding even more doses like 10 gray, 15 gray, 20 gray and 25 gray, and you count the vascular proteins or the cell numbers, what they are remaining. So you see that when the dose per fraction is increasing, the number of cells surviving is less, which conclude that single dose per fraction can overcome hypoxia if you are going for higher doses. There is a dose effect is there. So this is one SRS dose model is there, where high dose is given. You can see the cartoon here or graph, survival fraction versus the dose. As the dose increases, like 30 gray, you can see the survival fractions is reducing. So that is just to tell that hypoxia is compensated by high dose per fraction. SRS has indirect cell killing effect, which is by reducing the vasculature and vascular rupture also. There are different models are there. This is what it is. Quantification of vascular volume is done, where different dose is prescribed to the cells in the animal models, and they have calculated and they have concluded that the plasma proteins, which are vascular markers, are increased after 24 hours when irradiated with 20 gray compared to lower dose. So if you go for 20 gray, 18 gray, there is a vascular damage of this neovascular formation, and the cells are deprived of food and cell killing is more. That is what shortly. Any question, I will be happy to take that. So other are like intrinsic sensitivity and other things yet to understood. Immune response is there, high dose per fraction, it is also there, yes. Thank you.
Thank you, sir. Now I would request Mr. Sukumar sir, Sanjay sir, Lucy ma'am to felicitate sir. Now I got to introduce someone who doesn't need an introduction. She was one of the pillars behind this whole session, Dr. Sthiti Das. She's a leading radiation oncologist with an exemplary experience for more than 13 years. Dr. Das has worked with the top cancer center and oncologists in India and has a valuable decade-long experience in digital linear accelerator setups equipped with 3D CRT, IMRT, IGRT, and VMAT techniques across many reputed institutes. She has received many accolades for her exemplary work and presentation of complex cases in radiotherapy. Awarded Times Award for Iconic Woman for contribution to advanced radiation technique. She is the pioneer for stereotactic radiotherapy and high-end PET-CT guided techniques. She has started stereotactic radiotherapy technique for functional diseases like trigeminal neuralgia and glomerulus tumors and hold a record of treating more than 300 odd cases of stereotactic procedures in the state. We are so happy and glad to have here, and we are glad to listen also. Ma'am, please.
I know on a pulling into a slumber after this long tiring day of so many lectures. So I won't take much of your time. I'll keep it very short. So my topic for today was acoustic schwannoma. So we all know it's a Schwann cell-derived tumor and it arises from the vestibular portion of the 8th cranial nerve. It constitutes about 8% of the intracranial tumors in adults and 80 to 90% of the cerebropontine angle tumors. So the natural history, or maybe say the symptoms, they usually start with tinnitus. Vertigo is a slightly uncommon symptom. Then it may progress to hearing loss with possible disequilibrium, possible headaches, where considerable growth can occur without much increase in symptoms. Brainstem compression symptoms may start like trigeminal symptoms of facial numbness, hypertension and pain. Then the hypothetical symptoms like obstruction of fourth ventricle, rapid clinical deterioration with headaches, facial weakness, low cranial nerve dysfunction. The growth rates are usually very low, 1 mm per year, but sometimes a small proportion may increase up to 1 centimeter per year. These grading system already Senapati sir had highlighted in the first slides. This is the Coos grading system which is used for the growth of the tumor. Grade 1 where the tumor is limited to the lateral internal acoustic canal. Grade 2 where there is clear CP angle, cysternal involvement but with contact, without contact of the brainstem. In the grade 3 there is contact but no effacement of the brainstem region. But in grade 4 there is clear compression and near complete occlusion of the fourth ventricle. Coming to the management, depending upon the tumor size and brainstem compression, the management is usually divided between observation, microsurgery or radiosurgery. Now observation depends upon the risk-benefit ratio where the growth is very small and the quality of life of the patient is preserved, hearing is preserved. So, in elderly subset of patients, where we can wait and watch, observation is the key. But in patients where the tumor size is like less than 3 centimeter, there is mild or brainstem compression, we can review the patient's choice and treatment goals, and you can go for radiosurgery in these cases. Once the follow the Coos grading system, we can see here grade 1 to 2 to 3 up to 330 mm or 3 centimeter. Radiosurgery is a very good treatment of choice where the neurological nerves are preserved and there is a high chance of tumor control growth. But once it is more than 3 centimeter and brainstem deformation is there, and the issue of microsurgery. So for radiosurgical targets, all tumors newly diagnosed, residual or recurrent tumors measuring less than 3 centimeters, the goal being tumor control, and if you see the outcomes, the 5-year tumor control rates are more than 93%, with a peripheral marginal dose of 12 to 13 days. Radiosurgery tools we all know by now, so let's skip this slide. So coming to the initial pioneering papers in the 1980s where high doses like up to 22 to 25 gray was used for gamma knife radiosurgical systems where the local control rates were very high, though 95%, but because of very heavy cranial nerve toxicities like 90% and a deterioration of hearing preservation around 40% in 2 years, the doses were reduced. So in this slide we can see this dose is reduced to a marginal dose of 20 gray, where again we can see in all of the papers from Lecture, Fickinger, Medenhall, we can see that the local control was around 95 to 100%, cranial nerve toxicities were 50 to 65%, and hearing preservation was 40% in 2 years. Again, the marginal dose was decreased to 12 to 13 gray, and here also we can see the local control was preserved at 95 to 100%, cranial nerve preservation rates 95 to 100%, and hearing preservation improved to around 65 to 100%. Coming to fractionated stereotactic radiosurgery, conventional fractionations we have used, or the other fractionations where 5 gray in 5 fractions or 3 gray in 10 fractions have been used, and we can also see the local control rates to be about 95 to 100%, cranial nerve preservation 95 to 100%, and hearing preservation to 65 to 100%. So in single institution studies, the SRT versus SRS was studied. We have seen the local control was around 95 to 100%, and preservation rates were very good. Hearing preservation was around 33 to 80%. Here we have seen a comparative data, a systematic review of stereotactic radiosurgery versus fractionated radiotherapy, where the PFS rates were of the order of 90 to 100% for both the treatment options. Mean deterioration ratio for serviceable hearing before treatment was 49% for SRS and 45% for FSRT. Facial nerve deterioration rate was 3.6% for SRS and 11.2% for fractionated radiotherapy. And trigeminal nerve deterioration was 6%, that is better for SRS, and 8.4% for fractionated radiotherapy. So coming to the take-home message, there were no randomized trials concerning different techniques or intervention. Excellent local control rates were found in both the subset of patients. Substantial amount of patients retained serviceable hearing. Risk of facial or trigeminal nerve toxicity was small in both. In NF2 patients, there was good local control, but hearing preservation was still a concern. So coming to the fractionation conclusion. For stereotactic radiosurgery, it is definitely a one-day OPD procedure. It is limited for tumors for less than 3 centimeter tumors. And as we all know that schwannomas are slow-growing tumors with low AV ratio, similar to rate responding tissues, do not have increased therapeutic ratio to fractionation. They are not typically hypoxic and therefore would not benefit from reoxygenation gained from fractionation. Coming to stereotactic radiotherapy, there are 5 to 6 week treatment can be given as per conventional fractionation doses. The ability to treat tumors which are definitely more than 3 centimeter and very adjacent to the brainstem. So this fractionation allows for sublethal radiation-induced damage repair with advantage of reducing long-term damage and theoretically preserving hearing. Vestibular schwannomas do not demonstrate accelerated repopulation, therefore overall treatment has little effect on impressive tumor control. So we all know imaging we have already studied. In imaging we use volumetric 3D data. Target controls for single fraction RS we use symplectic head frame, no margin is usually added or 1 mm margin. For fractionated relocated formal quality assurance assessment of an appropriate planning target volume has to be done. The planning and simulation we have already studied. Mr. Rangaswamy has already highlighted. Dose fractionation for single fraction, 11 to 14 days is the dose to the GKB margin. Hyperfractionated radiography options, examples include 5 gray into 5 daily, 3 gray into 10, 4 gray into 10, and many others. Conventional, 50 to 67.6 and 1.8 to 2 gray per fractionation to the PKB margin. This is as far as plan quality, where the plan quality studied the various indices, and we have already studied this in the earlier slides. Selectivity index measures the target volume that coincides with the prescribed isodose value, detects over coverage of the target volume by the prescribed dose. Paddy conformity index accounts for the target volume coverage by multiplying the selectivity index with the percentage of the target volume coverage. Evidently, SI is equal to PCI if 100% target volume coverage is achieved. Ideally, PCI is 1 for a perfect dose coverage and dose conformity. Gradient index is the value of the average dose following the inverse square law. Shallower dose follow versus ISA. Steeper dose follow versus ISA. So these are the 3 indices which help us to study the plan quality of the SR. And the plan analysis is always a fight between the coverage and selectivity, where the prescription isodose and the target volume, there may be excellent target coverage with poor selectivity or excellent selectivity with poor target coverage. So coming to the outcome measures. Key elements of outcome measures: radiograph will follow with MRI brain, formal audiology, and neurological examination. Neurological examination include assessment of the facial motor function, trigeminal nerve function, and balance outcomes. Pseudoprofusion is a disease where transient enlargement of the vestibular schwannomas occurring within approximately first 3 years of single fraction RS or episodic due to treatment effects and not due to tumor growth has been reported in 20 to 30% of cases in literature. For these patients who do not have progressive mass effect symptoms, observation is preferred rather than immediate surgical intervention. So acoustic schwannomas post radiosurgery show 4 changes. A, it may show temporary enlargement. B, tumor shows no change or sustained regression without temporary enlargement. C, tumor shows repeated alternative enlargement and regression. And D, may show continuous enlargement. So microsurgery may be an option after failed radiosurgery, but usually we try to observe the patient unless and until there is clinical deterioration, we do not go for aggressive surgery. Repeat radiosurgery can also be done if there is continued tumor progression, typically greater than 3 years after initial SRS, a feature usually associated with new cranial nerve deficits or brainstem compression. The prescription dose in these cases was 12 to 13.2 days and has been performed safely and effectively. Sometimes radiosurgery for those cases for brainstem compression where the patient is not in ideal status, general condition for surgery or surgical is high risk and we do not desire tumor removal can be an option, SRS can be an option. The rationale being low proliferative potential, the brainstem can compensate for compression and not require immediate surgical decompression, and the low risk of cranial nerve deficits. So coming to the conclusion, radiosurgery in vestibular schwannoma used for newly diagnosed scenario, post-op residual more than 1.5, data robust support for favorable long-term tumor control with SRS, risk for facial and trigeminal nerve deterioration was less for patients treated in single series to VS patients receiving fractionated ones, while the chance of preserved hearing showed no difference between the 2 treatment groups. Doses administered were 12 to 13 days. So the controversy still continues. A true randomized trial, although tantalizing would postulate, is unlikely to be carried out. So the message being clear, neither SRS, full course SRT, hyperfractionated SRT, nor microsurgery produces an optimal outcome with respect to auditory function. Thank you.
Trying to felicitate big felicitation. The birthday.
Thank you, ma'am. I'll call everyone to felicitate the birthday girl today. And beloved Stiti, ma'am. Sanjay sir, please. Yeah, please, sir. to all dignitaries. Now I would request Lizzie ma'am to give us the vote of thanks.
I'm honored and humbled. It's been very nice actually. Stiti has been a part of our family from HRCC, and my professor and head of department, Dr. Senapati, and I myself, we feel very proud to see her at this stage today. From conventional radiotherapy, now she is dominating the field of advanced radiosurgery and stereotactic radiation oncology. So, and on top of all this, it's a birthday today. So from all of us in this hall and from our institution and from Indo Oncology, we wish her all the best for the next coming years to this beautiful birthday girl. And on her behalf, I would first like to thank the Indo Oncology team for considering to involve radiation oncology and giving it prime importance in the oncology conference. Most of it is usually occupied by head and neck surgery, head and neck and breast sessions. So this time Indo-Oncology has allowed radiation oncology and SRS and SRT to occupy a major chunk. So we are really thankful to Indo-Oncology. And I would like to thank the organizers of Indo-Oncology, Dr. Ghansham Biswas, for participating, making us all participate in a big way. Dr. Shankar for coming in spite of all his personal difficulties. Mr. Rangaswamy for being a part of this, and Professor Dr. S.N. Senapati being here from morning till now, and in spite of all his busy schedule, and the part of Apollo, entire Apollo Bhubaneswar, and the media, both print and video. I thank all of you for being here. Thank you.
Now Mr. Sukumar sir, he will give a small vote of thanks on behalf of Apollo, because it was first of a kind to be held at Apollo. So, sir, please.
Thank you, Dr. Pallavi. Beloved S.N. Senapati sir, Dr. Saroj Das Majumdar, Dr. Shankar, Dr. Vidhukalyan Mohanty, our beloved Dr. Sanjay sir and Dr. Stiti ma'am, all the dignitaries present over here, Mr. Rangasamy, his team, Mr. Rajkumar and his team. I take this opportunity to express my immense gratitude to each and every one present in this hall and people who have been watching us across different platforms for making it a very, very special day in the history of Apollo Cancer Center, Bhubaneswar. When this concept came up in 2016 that Bhubaneswar is getting ready for its first Apollo Cancer Center, we had a lot of plans which were there, a lot of plans which we wanted to place on board, which we wanted to execute for the benefit of the patients of our state and the neighboring areas. However, I must say that in the last 5 years or so, these things would not have been possible without stalwarts who are seated in this room, who made it for a very short time today, and people who joined us virtually. It was a new space for us, though we are healthcare service providers for the last 38 years as envisaged by our beloved Pratap C. Reddy sir. However, oncology coming to Apollo, to Bhubaneswar, was a new concept. We learned it the hard way from each and every one of you, the stalwarts sitting in this room. And I would owe all my success, all our success as I always put it, to all our eminent people. I will request the audience present over here for a round of applause for all our speakers today. And thank you so much, sir and madam, for making the day for us. A special word for Dr. S.N. Senapati sir. Sir, I salute your perseverance and your patience. I have been watching you since morning. We had speakers who had come here for a session. I understand they were also busy. Out of a very busy schedule, exactly, madam. That is what I wanted to highlight over here. Sir, there is a lot to learn from you. I paid you a visit in 2017, I remember, when we were coming up with the idea of cancer centers. And I met you in a hurry. I met you, I think, if I am not wrong, for just a minute. But in that 1 minute, the values which you gave us, we have started building Apollo Cancer Centers on that day. I really thank you from the bottom of my heart on behalf of my management. My heart goes out to each and every person, each and every resident, each and every consultant, doctor who is sitting in this room today, and all the virtual modes available, who have made this program a big success. So with this, I conclude my vote of thanks and take you to the next part of today's evening before we all close. I'm really honored to welcome Dr. Vivek sir here. He is Sthiti ma'am's husband, who has joined us out of his busy schedule. This is a surprise which we have planned for Sthiti ma'am and sir's father, and two beautiful little children also who have joined us. So I will request all of you to please come on stage. We'll have a small cake cutting before we wind up this evening today. And once again, thank you from the bottom of my heart. Thank you from Apollo Hospitals Group. Thank you on behalf of our beloved chairman, Dr. Pratap Trivedi. I really look forward to meeting each one of you. A special mention for Dr. Pallavi, who really made this day an enthralling one, I would say. A word of appreciation for our nursing superintendent, Minati Panja madam, who has been with us in each and every situation. Madam has never denied anything to me. I would say personally, I am very, very thankful to Minati ma'am for not denying a single thing that I have told her in the last 13 years of my association with Apollo. With this, I come to the end of my vote of thanks. I wish that all of you had a wonderful session, and I really carry forward with pride the Apollo culture of Namaste.